was awarded by the Indian Society of Surgery of Hand. He was visiting international fellow in microsurgery at Changwon Memorial Hospital, Taiwan. He has advanced clinical fellowship in rectal plexus hand and microsurgery under Dr. Oberin Daiichi Medical Hospital, Japan. He has also fellowship in hand and reconstructive surgery at Ganga Hospital. His areas of special interest: hand surgery, hand transplantation, reconstructive microsurgery, rectal plexus and peripheral nerve surgery, lower extremity salvage and reconstruction, lymphatic microsurgery. So he'll be speaking on a very interesting topic: bilateral hand transplantation, which has not happened in Odisha till date. It has not happened in most of the major states in India today. So his talk will be really stimulating and might stimulate some of us to take this forward for the unfortunate patients who have bilateral hand amputations. So he is going to offer some hope for these patients. So over to you, Dr. Nilesh Sarfai.
Thank you very much, sir. It is a pleasure to be a part of APRASOCON, and I sincerely wish that this was physically possible and I could have attended Bhubaneswar or met all of you once again, because of the relations that we have developed in 2019 due to APRASOCON 2019. Of course, there were multiple visits in that year, but they were all for work-related purpose. So we really didn't have any relaxed time. But yes, Bhubaneswar and Odisha does seem like a second home for me. So I definitely look forward to come there someday and meet all of you and see Odisha once again. So at the outset, thank you, Vibhuti sir, for the very kind introduction. I begin my talk by seeking the blessings of Lord Jagannath. Somehow, the mesmerizing tales and the enigma around Lord Jagannath is extremely impressive. And I had the great fortune of visiting and having that experience throughout 2019 when we visited Odisha multiple times. It is great to feel it and sense it in the culture, in the traditions of Odisha, and in the lifestyle of the common man. So it is deeply ingrained in our culture and ethos, and that is really very impressive. As I mentioned, I would like to thank APRASO and the entire team organizing APRASOCON for inviting me for this special talk, which is an opening talk of the APRASOCON. And yes, it always brings back the beautiful memories of APRASOCON 2019. So to begin with, yes, we all know that human hands are extremely special. It is the complexity of the hand function that makes the human hand very special. It is the way our thumb has evolved that has made an entire difference in the dexterity and the complex functions or capabilities of our hands. And it is indeed this opposable thumb that is responsible for placing us at the top of the food chain. So this is the major evolution of the hand as compared to the apes, which are our immediate predecessors. We can see how our thumb is long, strong, better positioned, and most importantly, it is opposable to the other digits. That makes it extremely important. So the importance of hand function is known to all of us. It is indeed a masterpiece of human evolution. And it is extremely difficult to duplicate the hand function even in today's advanced computer era. Now, when we look at this picture, we come to know of the importance of the hands for the human brain. An homunculus is what the brain sees in terms of the functions that the different body parts carry out. So the motor function and the sensory function, if they are mapped on an homunculus, the hands have a really large area that occupies in the cortex. So hands are extremely important for every activities that we perform. Before 1962, there was no replantation surgery. So any amputation that happened, the limb or the digit was lost forever. It was in 1962 that the first replantation was performed for a shoulder level amputation. And that really changed the entire picture of hand and reconstructive microsurgery. And it enabled us to salvage more and more limbs which were either injured or damaged or being lost for several reasons. Uh, However, there are still some set of patients who are not suitable for replantation or who have undergone a replantation which has failed. These patients unfortunately have to live their life as an amputee, and till recent times they had no better option than to use an artificial prosthesis. If there's a partial amputation, we all know that we can try to reconstruct the hand by performing some reconstructive surgery. Toe transfer is a wonderful procedure which has enabled to reconstruct the lost thumb or the lost digits. A single or multiple toe transfers can be performed depending on the situation and the level and the need. And when microvascular expertise is not available, we can also perform an osteoplastic reconstruction in order to create a post which can oppose against the remaining digits and improve the function of the hand. This is the Krukenberg's procedures, which was performed for amputations at the level of the wrist, in which the forearm was split into two parts, the radius and the ulna, creating a sort of forceps. So, based on the muscle attachments to these bones and the interosseous mechanism, these patients would use their hands like a forceps. Of course, this has got a very limited capability and a very limited possibility of function. But yes, these were the only this was an only option available for quite some time in the past. It is very rarely performed these days. We often come across a lot of patients like this. They have lost either one or both their hands at various levels. Some of them, majority of them are usually victims of electrical shocks. And these shocks have also led to lower limb amputations at the same time, because that is usually the exit pathway of the strong electric current that passes through their body. So most of them are living a dependent life. They have lost their livelihood. They are extremely introverted and depressed because they are dependent on their family members for majority of their activities. They've lost their self-respect. They've lost their self-esteem. So we know that definitely there is a need to find some better treatment option or solution for these unfortunate patients. Now, we can only imagine what difficulties these amputees face, because we take a lot of things for granted. We do not realize the value of things that are easily available. So the hand function is one such thing. Only when the hand gets injured, it gets stiff or deformed, we realize the importance of a smoothly functioning hand. So bilateral amputee, as I said, is dependent almost for most of his activities on his family. He has a poor acceptance of processes. There are several problems with the processes which we'll discuss further. But yes, using the processes itself is quite challenging, and most importantly, the processes offers a very limited and a compromised function. So they often end up not using the processes at all, or they give up the processes because they are better off without the processes. They are psychosocially withdrawn. There is loss of work. They have strained professional and personal relationships, which makes their life really miserable. So it is extremely important to rehabilitate these amputees in order to make them stand on their own feet, make them independent, make them capable of performing their own activities for themselves. Similarly, a unilateral amputee also has some amount of disability, though they often tend to get adjusted over time, depending on whether the dominant or non-dominant hand is amputated, and they often also accept the processes relatively better as compared to the bilateral amputees. Now, as we said, there are several prosthetic limbs available in the market today. There are several Indian as well as several international brands available, and the costs have an extremely wide range, beginning from the most basic processes to the most advanced and complex processes, and also that their costs are equally exorbitant. So the most advanced processes currently available in the markets could cost close to 30 lakhs or even 40 lakhs. But the problem with these processes are that they are insensate. They cannot be used in water. They have a certain amount of weight, which is hanging on the body all the time. They can cause slump related problems due to the pressure, due to the compression, due to the heat generated in that area, due to the reaction to the silicon insoles and materials that are used to attach the prosthesis. They have either poor or inadequate function depending on their type. They are extremely costly. Plus they are a recurring expense. They are not a one time expense. You need to repair them, refurbish them, or change them after a certain amount of time. So this all these factors lead to non compliance to the use of prosthesis. So as we saw, replantation definitely is the best option and should be attempted.
ओपीडी रूम मिला नहीं, फोन किया था डॉक्टर को, बोला मैं भेज रहा हूँ। में कोई और बैठ रहा है ना? नहीं, अभी जो मिले थे वो तो उनका रूम में बैठा है ना।
Background noise.
कौन मिलेगा तो मिलाऊंगा ना। अपने बच्चे का से कहाँ मिल जाएगा?
Hello, Dr. Nilesh, can you hear us? Hello.
I can hear you, sir. There is a lot of background noise. Am I audible clearly?
Yeah, you are very clear. You are very clear. You please go ahead. You are absolutely clear.
So the most important problem with the processes is the non-compliance or these multiple factors, and often the patients end up not using these processes. Now, this is one thought which has significantly impressed my mind, and it is that the quality of life is often more important than life itself, because most of our patients, whether they are congenital deformities or they are oncosurgery reconstructions or any other patients, we often we have realized how important the quality of life is. So restoring this quality of life is an extremely important factor in order to make these patients satisfied and happy and independent in their lives. So hand transplant is one such procedure which I believe is the best reconstructive option for most bilateral amputees and some select unilateral amputees. Now, this slide is extremely important, and I think that this is the take-home message which I would give today, that the success of the entire program is dependent majorly on this factor, and that is the proper selection of the recipient. As I said, it could be either a unilateral or a bilateral amputee. Most importantly, he should be a motivated adult. He should be in good general health. He should be psychologically stable. This is the most important factor. These patients often have to undergo a very long course of treatment in terms of not just the surgery and the post-operative recovery, but yes, the rehabilitation that goes on for months and years, and the lifestyle changes that they have to undergo in order to take lifelong immunosuppression and to continue the lifelong immunosuppression without having any major problems or complications. That really demands a severe mental strength and a very significant discipline in life. So a psychologically stable patient who is motivated to be able to manage the transplant and to be able to follow the post-operative instructions and care throughout the life is the major deciding factor for the successful outcome for any hand transplant. Yes, of course, they should have a failed trial of prosthetic use, because that actually makes them realize the importance of the transplant in a better way. They actually realize the importance of having a good, naturally functioning hand after they have known that the prosthesis is futile. They technically speaking, yes, they should have a favorable amputation mechanism. A guillotine amputation is definitely better than a crush or an avulsion injury or a burns, because it tends to scar the structures to a significant extent. And often in crush injuries or avulsion injuries or in burns, the amputation stump is quite deceptive. Though it might be a distal forearm amputation, but the scarring and the injury to the structures may be right up to the proximal forearm. So that is an extremely important factor which goes on in determining or in the preoperative planning of these cases, because the recipient plan or the donor planning also depends on the needs of the recipient. So the recipient stump needs a detailed workup preoperatively in order to assess the available structures, in order to assess the level of the healthy vessels and the nerves and the musculotendinous units, in order to plan the retrieval from the donor. They also should have a favorable level of amputation. Yes, this naturally, the more distal the amputation, the lesser the distance of the nerve recovery, and hence the better outcomes. So the inclusion criteria for donors include that the family should be willing for donation, of course. It should be a compatible or a similar ABO blood type. Now hands are extremely immunogenic. That is because they have a large skin component. Also, they have a significant bone and bone marrow component. This makes the hand extremely immunogenic. Hence, it is important that the matching between the donor and the recipient has to be very perfect, and also the HLA matching between the donor and the recipient has to be done in order to assess the differences between the two, in order to see the degree of mismatch between the two. A lymphocyte cross match between the donor and the recipient gives us an idea of the amount of preformed antibodies that the recipient is likely to have against the antigens of the donor. So this also is an important predictive factor which can help us judge the behavior of the transplanted limbs in the future. The possibility of rejections happening, the severity of rejections, the type of actions that we have to take preemptively or preoperatively, and it makes the monitoring easier. So a detailed workup of both the donor and the recipient is extremely important in order to keep a check on the rejection activities happening. They, if possible, yes, they should be of a comparable age, the donor and the recipient. They should be of similar ethnicity, similar skin tone, similar hair pattern. All these factors are important because hands are external organs, so they are going to be visible throughout the life. So it is better that the hands match the donor and the recipients. They match each other in their stature and their height and profile. But yes, the getting a hand donation is so difficult that we really can be flexible on these aspects, because often we don't have a choice. Getting a donation at times becomes a very big factor, because the recipients are waiting for a long time. They are also desperate to have hands, and so they are also not very rigid on all these factors, because they are of secondary priority. The exclusion criteria for the donor are like any other transplant. Any infective pathology, any malignancy, paralysis, neuropathy of any kind, infections, systemic neuropathies, either toxic neuropathies, rheumatoid arthritis, osteoarthritis, uncontrolled hypertension, significant trauma to the limb itself. All these are exclusion criteria for the donor, which rules out a hand donation. As I said, this is a very important factor, and this is a very new area for all of us, because we have probably not been exposed to immunology after our second MBBS. So trying to understand the immunology, trying to understand how the cell mediated and the humoral immunities work is extremely important, because transplants have a very important immunological follow-up to be carried out throughout the lifetime of the recipient. And these patients, the good thing is that because the hands are exposed organs, we can do biopsies in order to assess the rejections activity that is happening at the level of the vasculature. And there could be acute rejections in the first year itself, which need to be managed with medications, or there is a possible chronic rejection which can happen over several years gradually. But yes, because hand transplants are relatively recent as compared to the other organ transplants, chronic rejections are not yet well documented in this. But yes, the current protocol is to continue doing protocol biopsies at regular intervals in order to serially follow these transplants and see what is happening at the cellular level. So managing a transplant team, or building a transplant program is a huge logistical challenge. We of course need a large surgical team. We need a team which is oriented properly in hand surgery, in microsurgery per se. And yes, we need qualified hand surgeons, qualified microvascular surgeons who are capable of thinking, innovating, and innovating at the last moment, because transplants often are full of surprises. As I said, the dissection and preparation of the recipient stump is one of the most challenging parts, because we are often in for surprises, because after an amputation, we know the kind of recovery process that these amputees undergo. They undergo multiple stages of debridement, sometimes infections, sometimes revision amputations, and then the stump closure happens either by skin grafting or by primary closure. So that adds to the scarring of all the structures at the level of the amputation stump. So we need a large surgical teams which is capable of doing all these things. In addition, we need our orthopedic colleagues to support us with the fixation of the forearm or the arm bones. We need a large number of nursing staffs, assistants, and support staff, because these are long surgeries which happen at odd hours of the day or night, and they may go on for a long duration. So we need a staff which is capable to support all these things. We need extremely good support from the anesthesia team in order to maintain the patient who is undergoing so many hemodynamic changes in a very short interval. The blood loss can be severe at times, because after the reperfusion, the muscles and all those raw areas, they tend to ooze a lot. So managing with those fluid and blood requirements, and plus also the metabolic changes that happen following the reperfusion, and also the immunological assault or the immunological injuries. We also need the help and support of an immunologist. In most of the hand transplant programs, this job is done by the nephrologists, because the immunology of hand transplants and kidney transplants is very similar. Hands are actually more immunogenic than the kidneys actually. But yes, the nephrologist is probably the perfect person to guide us with the immunology. And in fact, he becomes a very crucial member lifelong for the recipient. So and more importantly, we need good administrative support to be able to do this, because these logistics to be able to put in place, to be able to execute at odd hours, considering the distance from where the organs may have to be procured. So we need a good support from the hospital management to be able to do this. There are certain moral and ethical issues related to hand transplants, as we know that this is a life-enhancing procedure and not a life-saving procedure. Hence, it makes the selection of the recipient even more important, because now this is a non-life-saving condition for which a person is being subjected to immunosuppression for lifetime. So, understanding the value or justifying the need for a transplant for a non-life-saving condition becomes very important, and that is where the maturity, the understanding of the recipient really matters. Yes, there is a theoretical possibility of reduced life expectancy due to lifelong immunosuppression, but yes, as I said, the having a good quality of life is often more important than having just a life which is dependent and practically uh, worthless. So the unique features of hand transplants include the cortical plasticity. Now a lot of things are happening at the cortical level, because the as we discussed, the homunculus, the brain has areas which represent the motor and sensory parts of the hand. After an amputation, there is a change happening in these areas. These areas, they tend to diminish with time because no hand activity is happening. Again, when a transplant is performed, a new hand is attached, and now when the new hand starts functioning, again those areas in the brain start getting triggered, and these activities tend to increase. And then depending on what dominance they develop, a lot of cortical changes happen in order to integrate the new hands and to accept them as a part of your own body. So all these things are also quite interesting and exciting. In fact, a functional MRI done can denote all these changes that are happening at a cortical level. And yes, of course, there are some donor issues. Naturally, getting a hand donation has been difficult as compared to the other organs, because this is an external or a visible mutilating organ donation. Hence, there are a lot of ethnic and cultural hurdles in order to get a hand donation. Of course, after the donation, it is important to respect the donor's body. We always attach prosthesis to the donor body before the body is handed over to the relatives for their final rites. Functional outcomes, yes. We know the importance of hands, so a properly performed hand transplant has delivered excellent functional outcomes in most centers across the world. All these functional outcomes have been assessed in terms of prehensile function, grip strength, motor power, patient acceptance, the quality of life parameters, resumption of work, psychological well-being, and most of the patients perform really well on all these parameters. Now, coming to our transplant program, yes, technically, I had the great fortune of having to meet Professor Warren Bryanback, who performed the first successful transplant in the United States in 1999. And I met him in the first year of my plastic surgery residency at KEM Hospital, when my teacher, Dr. Amrish Balyar Singh, had invited him to deliver a talk at KEM. And that was my first exposure to hand transplants, and that had really impressed my mind very significantly. And it was at the back of my mind, and even during my fellowships, I would think and about the possibilities, because till then it was not happening in India. When I came back from Japan in 2013, I really started working on this and trying to see the logistics behind the building a program of this kind. And as we know, in January 2015, Amrita Institute Kochi performed the first successful bilateral hand transplant in India. Following that, when I joined Global Hospital, then we processed our license, and then in December 2016 we got our license for transplants. We were the second hospital in Mumbai to get the license after KEM Hospital. And since then, we have been regularly working and talking in the social circles in order to create the awareness among both donors and recipients, in order to create awareness for organ donations. And this was our first patient who came to me in 2017. She was a young 23-year-old female, bilateral proximal forearm amputee. She met an accident in the local train. She was a college going student when she was trying to alight from the train, she fell into the gap and got trapped there and lost both her hands. Now, this was also because of the mishap and the time delay. She could not undergo a replantation primarily, actually. So that is another important aspect that we as plastic surgeons should stress upon, to create awareness for hand injuries, to create awareness for replants, in order to avoid such unfortunate incidents and situations of having the need to undergo a transplant. So she came to me into 2017. Uh, she was a college student. Yeah, she was a very gritty girl who underwent and finished her junior college even after losing both their limbs. Her father was extremely supportive. Her mother was performing most of her essential activities in the day. Her father himself was a patient of renal disease, and unfortunately she lost her father before she underwent her transplant. So this is the profile. A detailed workup of the recipient is extremely important, of all the parameters. Yes, as I said, we do a MRI regularly. We do a CT angio regularly to assess the vascularity of the limbs. We do an EMG study to assess the quality of the muscles and the functions. We try to assess the level of the nerves by assessing the tenils. We do a detailed immunological workup, do a detailed viral workup, and an panel reactive antibody in order to see the antibodies that they are sensitized to as a part of their previous treatments. So these are, yes, technically these are logistically challenging procedures. We need to have 4 teams working simultaneously on 4 different stations, trying to prepare the recipient limbs and the donor limbs at the same time. And then these are some images during the surgery. The donor and the preparation of the recipient stumps on both the sides, the donor hand preparation on both the sides. Managing the ischemia time is very crucial. It is best to have a in-house donor or a donor within the city. But unfortunately, in all our transplants, we have had donors from outside the cities. In the first case, it was from Chennai. In 2 other cases, it was from Surat, and in 2 other cases, it was from Ahmedabad. So in all these situations, it is extremely difficult to manage the timings, to manage the retrieval time, to manage the time the organ is retrieved at the donor hospital. It flies from there to Mumbai. It then comes through a green corridor from the airport to the hospital, and that time has to be as short as possible, because after the organs reach, then the preparation of the donor hands does take a significant amount of time. It takes at least 1 to 2 hours at times. Then the fixation of the limbs, then the perfusion or vascular anastomosis. So in all, ideally, the ischemia time should be within 6 hours, but yes, 6 to 8 hours is an acceptable ischemia time. But yes, the shorter the better in view of the intrinsic function. So in this case, our ischemia times were 7 hours and 7 hours 15 minutes. The detailed preparation, as I said, the muscles are often scarred at the level of the stump. So if we note that the stump on the right side of this patient was extremely short, so there were practically no forearm muscles remaining. So in this case, we took common flexors and extensor masses and attached them at a supracondylar level, though the bony fixation was at the level of the proximal forearm, but the muscle repair was at a supracondylar level, and then the vascular anastomosis was at the level of the brachial, and plus the nerves also many a times they have long neuromas, and the nerve repair often has to be performed at a much higher level than predicted. So we have to consider all these factors in deciding the level at which we retrieve the donor hands. So a significant excess length from the donor of all these critical structures should be available in order to be able to deal with these intraoperative surprises. We begin with fixation of the bones. Yes, bony fixation also becomes very challenging because these hands are not, these stumps are scarred, they are narrowed So often the interosseous space between the two forearm bones is contracted or it is narrowed. So re-achieving that space is also important in order to have a good pronation and supination later. So bony fixation in these cases also is challenging, and we should definitely involve orthopedic surgeons who are well oriented with hand anatomy and these biomechanical aspects that need to be considered in order to achieve a good function post-operatively. Vascular anastomosis is, yes, technically it is a simpler thing for all of us, because at a proximal level, the vessels or the size of the vessels is reasonably good. And it should not be difficult for most of us to be able to do this. Yes, we should repair the artery at an healthy level, however proximal it may be. We should repair as many veins as possible. This is the most important factor which determines a smooth outcome, because these are long surgeries. There is massive muscle and soft tissue edema that develops, and it is the number of venous anastomosis that you perform that determines how smoothly this edema will resolve. Now the challenge here is, again, we tend to get good vena committents as they are deeper structures, but as the stumps are scarred, and with the repeated vascular problems in terms of vascular access and blood collections, the superficial veins are often not available to a satisfactory number. So we often struggle getting good number of superficial veins in the recipient stump. But yes, as much as possible, you should try to do as many venous anastomosis as possible in order to ensure a smooth recovery. So in this case, we did two vena committents, and we were lucky to get 4 and 5 superficial veins. But often, in most of the cases, we end up getting only 2 or 3 good superficial veins. The nerve and the muscle repair is then done at the respective level. Again, it is always better to go slightly proximal in order to get a good healthy nerve, because in the long term, it is the nerve recovery that determines the successful functional outcome in these cases. As I said, as many veins and as many superficial nerves. Yes, repairing the superficial nerves also is extremely important in order to improve the sensibility of these limbs and to get a better quality function. This is the closure of the skin flaps. As I said, on the left side, because there was an overlap of the native muscles and the donor muscles, the stump does tend to get bulky after the surgery. So having excess and good skin flaps to cover this extra bulk is important. Of course, this edema and bulk does settle down over the next couple of months. Now, the important things to understand as a difference between the transplant and the replant is that in transplant, we have excess tissues. So the tension adjustment becomes very critical. And also with respect to the patient's height and stature, the planning of the bony fixation and the bony length becomes very important as compared to replants, where we often face a shortage of tissues because of the injury, and but the tension repair is easier. The bone length is never a problem. So these are the basic differences. So a transplant is much different technically from a replant. This case was widely publicized in the media, and it really created a huge amount of awareness both among the donors and the recipient. This is the immunosuppression regime, which is managed mainly by the immunologists. It consists of an induction regime and 3 drug maintenance therapy. These patients have to undergo repeated checkups of the tacrolimus levels in order to ensure that the immunosuppression is optimal. This is a post-op recovery. The patients are often young and fit and healthy, so they do recover very well. This is on day 4. So this is roughly 3.5 months post-op. The patient started developing some flicker of movements in the fingers. So these movements improved with time. over the next couple of months. Being able to use a cell phone or a mobile phone on their own is an extremely satisfying moment for these people, because they makes it keeps them engaged. It makes them independent to a severe extent. So this is 5 months after the transplant. She had started using the mobile phone. So this is a functional assessment at the end of 1 year. We see that on the left side, she has better function in terms of forearm pronation, supination, wrist flexion, extension, and the flexion at the different joints. She has better function now on the left side because of the longer available stump on the left side. As the stump on the right side was shorter and scarred, the functions are slightly poorer as compared to the left side. But yes, she is still recovering, and today also she is still undergoing intrinsic recovery, and she's going to definitely get better with time. So this is the function at 14 months. She has reasonable wrist flexion and extension, finger flexion and extension. Plus the intrinsic recovery also is happening. Currently, she has a claw hand on both the sides, because the ulnar intrinsics often take longer time to recover. The thumb opposition also is improving day by day. She's definitely making efforts in order to use the hands to a maximum extent. We monitored her by serial biopsies, and yes, the good thing is that we did not encounter any major rejection in this case in the first 18 months. Yes, we were worried about the immunosuppression because it was really a very strong immunosuppression. But yes, she had a very mild urinary infection once, which was treated with oral antibiotics. She did develop COVID infection, but it was managed at home. The DASH score showed an improvement of 20 points, which is a very good recovery in terms of the functional outcome. The hand transplant scoring system assesses these patients on different parameters, and that also has shown good recovery in both the hands. And as her intrinsics recover and strengthen, definitely she will go from good to excellent. So the milestones that she has achieved after the transplant is that she is able to take bath, she is able to take care of self-hygiene, open a water bottle, drink with a glass, lift light weights, carry a bag, operate a mobile phone, travel independently, type on a keyboard. She's also learning to hold a pen and write as her intrinsics are getting stronger. And more importantly, for her mental, psychological, and morale, she is now employed in our hospital as a coordinator. So that has really made a big impact on her psychology. So and now she's become a left-handed person because her left stump was longer. She has better function on the left hand, so she prefers using her left hand more. So she's now left hand dominant. So it was a dream fulfilled when she did the Aarti for Ganesha this year. This is what she had sent before going in for the surgery, that she missed doing this. This is a second patient. He's a quadruple amputee post electric shock. He has lost all the 4 limbs. He was an aspiring kabaddi player from Rajasthan, and he underwent transplant on 15th October. So in this case, because the right side was too close to the elbow, we had to do a supracondylar transplant on the right side and a proximal forearm transplant on the left side. Now this patient is also doing extremely well. He's 4 months post-op, and he's now on his way to nerve recovery. He's gaining elbow function and also started early wrist movements. This was the third patient who was again a quadruple amputee following post-electric shock. Now these two patients, these are the first successful quadruple amputees. Now there's an important challenge in these cases is that the quadruple amputation actually changes the body physiology to a very severe extent. And after undergoing a transplant, a lot of stress is put upon the heart and the cardiopulmonary function because these patients preoperatively often have very restricted and limited activities. So these two successful transplants are rare, because often quadruple amputees have been reported to have severe complications post transplants, and there also have been deaths following transplants in quadruple amputees in India. So this patient again had a very proximal amputation, or it was trans elbow. So in this case, we had to do both the transplants at supracondylar level. He's also on his way to recovery. This was one of the recent cases that was done. A young lady with 3 children. She was extremely desperate to get her hands back, because she could see her children suffer every single day, and she herself was quite helpless in doing all the house activities and take care of her kids. So she underwent bilateral transplant, again on the right side at a proximal forearm level and the left side at a supracondylar level. She is now close to 3 months, and she's doing reasonably well. This was a recent transplant. Now, in this case, there was a proximal forearm amputation on the left side and a partial hand amputation on the right side. He had his thumb and little finger remaining. The index, middle, and the ring finger were amputated at different levels. Now, normally in an isolated situation of the right hand, we would not have recommended a transplant. But because he needed a transplant for the left side, we performed a partial hand transplant for the right side. So we transplanted only the index, middle, and the ring fingers on the right hand, and we did a transplant. Again, this stump was extremely scarred. So though the stump looks like a distal forearm, the repair actually happened at the level of the proximal forearm because of the scarred muscular tendinous units. So this is, in fact, the first successful partial hand transplant in India. So this was done quite recently. This patient also is on his way to recovery. Now, of course, this is a distal transplant, so the recovery is quite fast and quite satisfying. And I'll share the long-term results in the next talk. So it is important that all of us know the importance of what these transplants can do to these patients. And hence it is very important to continue to create the awareness in the society, to pledge our organs ourselves, to set an example ourselves, and to motivate others to become organ donors, so that they can benefit more and more individuals in their life. So this is, in a nutshell, are all the 5 transplants that we have done till date. It is a huge team effort. It is never a one man's job, and I am really thankful to all my team members who have worked untiringly in order to make all these cases successful. It is a very emotional moment to see these patients recover, because these are visible organs, the external organs, and to see the changes that happen in them is really exciting to note. And also, it is extremely sensitive for the donor families, because they can see the parts of their dear ones living and surviving on the body of another individual. So the parents of Monica's donor flew down from Chennai in order to meet her, feel the hands of their son, whom they lost. So it was really a special bonding between the two families. I would like to say my special thanks to my mentor, Dr. Baliar Singh, sir, who has been a pillar of strength behind me in all my endeavors, and he has been an extremely important support of my team. Thank you, sir. At the end, I would like to say that there's no such thing as good enough to be able to achieve victory. You, your team, and your equipment must be the best. Thank you so much.
Excellent and stimulating presentation. All is almost good, and we have a lot of questions. Anyone who is interested to ask questions, that is the mic where you can ask, because the hybrid mode. Yeah, you can ask from that mic, from there. My question to you is, when it comes to traumatic bilateral amputation and electrical bilateral amputation, which one you feel will be easier for a transplant as far as surgical aspects are concerned?
Sorry, sir, I couldn't hear it clearly.
So if there are two scenarios, one patient with bilateral amputation because of electrical cause, and the second patient post-traumatic amputation, which one will be easier to perform?
Post-traumatic. Post-traumatic will always be easier to perform because though the zone of trauma is often unpredictable depending on the exact mechanism of injury, but still in a post-traumatic situation, the zone of trauma is much lesser than an electric shock. Often in electric shock, the current is very high voltage. Typically, these patients have an 11,000 or something, a very high voltage current passing through their bodies. So it causes extreme scarring of a lot of structures, much beyond the level of the amputation. So electrical shocks are always more challenging and more difficult. Plus the extent of the internal trauma also is difficult to judge in these patients. But yes, majority of the patients who undergo transplants or who are in need of transplants are often due to electric shock. So that is not a contraindication, but yes, technically speaking, a post-traumatic amputation is always easier than a electric shock.
You had two patients with electrical amputations. What challenges you faced in those two patients compared to the trauma cases?
Yes, sir. So yes, as I said, the structures really get severely damaged, and plus depending when it is a primary injury, the goal of the primary surgeon is to be able to close the stump on and heal the wound. So at that time, a lot of things get debrided because the aim is to close the stump, because the thought that the few of the structures are important or essential in terms of long-term reconstruction does not get a priority at that point of time. Typically, the traditional teaching has been to pull the nerve in any amputation stump, is to pull the nerve and to cut it as proximal as possible so that it withdraws within the stump. So that actually increases our distance for nerve repair, and the neuroma is develops much proximal to the level of the stump. So that is one aspect, one point which needs to be reconsidered in view of not making the future reconstructive options more difficult. Again, the second thing is the bone shortening. In order to be able to close the stump primarily, often the bone shortening is done, which reduces the length of the stump. So all these concepts actually have to be thought of again and taught in a different way in order to make the future reconstructive possibilities easier.
Sir, good morning, Nilesh sir. Myself, Dr. Deves. So my question is, what happens to the color between the donor and recipient? Whether it remains same or it changes with time? And number two question is, what procedure you follow, what protocol you follow to prevent fatty degeneration to the regeneration of the muscles? What you do actually?
Yes, so the color of the skin does change with time. We have seen a remarkable change happen in our first patient, because now she's more than 1.5 year post-op, and we have seen a significant change in the color, in the texture of the skin, because yes, it is an hormonal thing. The female hormones, as they act on the skin, they are going to change the texture of the skin. So yes, the color does change with time. Also the texture, the hair pattern also does differ with time. So that is we'll come to know more of these things as these patients progress with time. But yes, definitely those changes happen. With regards to the fatty degeneration, yes, having a good vascularity is of paramount importance in order to prevent this. A good vascularized structure will not degenerate. So having an healthy arterial repair at whatever level needed will perfuse the tissue adequately and will prevent these degenerations. Also, as I mentioned, doing as many venous repairs as possible in order to have a good outflow for all the structures is important. So having a good vascular anastomosis will take care of the possibilities of any degenerative changes happening in these structures.
So whether you do any nerve stimulation procedure post-operatively?
Yes, post-operatively, the good thing in these patients is that the nerve recovery in transplant recipients is faster than in post-traumatic recipients. The reason for this is the tacrolimus that they receive. So the tacrolimus is one such medication which is said to facilitate nerve recovery. So that is actually an added or an added effect of tacrolimus. But so due to which the nerve recovery in these patients is faster, and we follow a normal rehabilitative protocol which does involve muscle stimulation in order to prevent these muscles from getting atrophic.
Thank you.
Good morning, Dr. Nilesh. This
Good
is
morning.
Dr. Akshay Raut.
Good morning.
My question is there any ethical issues? Means prior to transplantation, the clearance has to be taken from governmental agency or ethical bodies?
Yes, so the ethical issues are our own actually. So the government will not ask for ethical issues because hand transplant is an established procedure worldwide. So yes, getting a license from the appropriate authority is the most basic thing to begin with. The ethical things are in our mind because we are selecting the potential recipients. So whether the recipient is really in need of a transplant, whether it is justified to subject such an individual to lifelong immunosuppression. So in my mind, there is no question that there is a better alternative to bilateral amputees other than transplants. But
No,
selecting
any affidavit, anything has to be taken from the patient?
no.
No, it's not required. And
Our,
what
our
is the
consent, our consent is detailed enough. All these factors are covered in the consent, and often for any major surgeries, we take a video consent for all these patients. So all these factors are explained in details in all the consultations and also in the preoperative consents. So typically, I will never recommend or push them to get registered or in the first consultation because they need time to understand the entire process and the complexity, and it is always better to go slowly in order to ensure that they will be compliant for the entire requirements that these procedure demands.
and what is the incidence of acute rejection?
So worldwide, whatever literature is published, they have reported acute rejections at least once or twice within the first year. Now these are immunological things. So the immunology protocol that we are following is slightly different as compared to the what is done worldwide. And luckily, we did not encounter any rejection in our first case even till now. That is 1.5 years. In one of our other patients, yes, there was a minor mismatch between the donor and the recipient, due to which there was a grade 1 rejection reaction. But yes, we could manage it with some change in the medications, such as pulse dose steroids or local tacrolimus creams. All those things have to be used on case-to-case basis. So we did encounter a grade 1 rejection in one of our patients, but none of the other patients have had any rejections till now.
Okay, thank you.
Do you do fasciotomy in all those transplants? Fasciotomies.
Fasciotomy is not needed because the dissection is so extensive that practically all the compartments are released. So distally in the at the carpal tunnel level, I have never felt the need to do a fasciotomy. Sir.
And what is the maximum amount of blood you gave to transplant patient? How many
20,
blood were maximum
20
transfusions?
20 units.
20 units.
Yes.
How many units? 20 units.
20 units in the first case. We had it was a learning experience actually. As I said, the stumps are scarred, and plus post dissection, the important thing, there's a learning experience at each step when you are preparing the donor hands. often we are doing it in an avascular organ. So we don't realize what minor vascular channels are opening or left unattended. And plus the muscle which is stripped off from the bone or the periosteum, they are extremely raw surfaces. And once you have fixed the bone and the entire thing is lying, it is like a general ooze, and you don't have a very specific bleeder at any point of time. So there is an insensible loss which keeps happening most of the times. But yes, what we realize is that doing cautery dissection is equally important in the donor stump as well, though it is an avascular part to begin with, in order to minimize the bleeding. So post the first case, we never had to give more than 8 transfusions.
Oh, can you hear, Dr. Nilesh?
Yes, sir.
Yeah. At the outset, on behalf of the APRASOCON, I cordially welcome our Professor Dr. Ravi Mahajan and Dr. Sinha and Dr. Nilesh also. So Nilesh at the opening batsman had a very good talk. It was very much stimulating, exciting, and very much educative to our young surgeons in Odisha.
Thank
In
you.
fact, we have a center what Dr. Nayak has already elaborated. We have a Noto and Soto, and the just below our department, the kidney department or the nephrology, sorry, the urology department is there, and they have a well established transplantation unit with a modular OT, and they have done more than 150 cases of renal transplantations. So I think that is the advantage over here. So all those, I hope where replantation can be undertaken, these hand transplantation not be a difficult job technically, and most of the logistic part is more important to actually get the recipient's hand to the place of getting the surgery. So I hope for the future of Odisha, this is a eye-opening, and most of the centers in Odisha, I think we should try and we can implement this in our state. So for giving such a good lecture, we are really thankful to you, and you have finished in time. That is very important, because transplantation means the time is the biggest factor you have to respect. Anyway, any more questions from the young surgeons? Thank you, Dr. Nilesh, for a wonderful talk. So we'll go to the next speaker.
Thank you very much, sir.
Thank you.
Thank you.
So our next speaker is Dr. BSP Sinha. He is a senior plastic surgery consultant from Jamshedpur. It's mostly an aesthetic surgeon, does a lot of hair transplantation. So his talk will be on hair transplantation. Dr. Sinha.
Good morning, respected chairpersons, President APSI, Dr. Ravi Mahajan, and Senior Professor Chaudhary, and also faculty from BHU, where I also belong, all my seniors and dear colleagues. Hair transplantation is a peculiar surgery it has become, because if you see, there's so many specialties who are doing hair transplant: plastic surgeon, dermatologist, ENT surgeon, also now dentals and IUs, and almost everybody, even technicians will in metro are there, and they will just give you a call, sir, case rakhiye, and I will come and do. And there is no other surgery which you will get such a call. So at one end, this simply says that fundamentals are very easy. That's why so many people are doing it. But other spectrum is that you will find a lot of patients who will say that mera itna kharcha ho gaya, but I am still very unsatisfied, because they don't get a result. So these are the two spectrums of hair transplantation. And we have done internal. नेक्स्ट करना ना इसको। इसको ये करना है। अच्छा, So there is no doubt that this is a growing specialty. I also do all the general plastic surgery and other cosmetic, and it is just also a part of my practice, not only hair transplant surgery. But if you see from 2008 to 2019, almost 157% of increase in ST cases, and globally about 7,35,000 cases of ST was done. These are the data from ISHRS, International Society of Hair Restoration Surgeons, which was founded in 1993. In India also, Association of Hair Restoration Surgeons was founded in 2008, and they are having regular annual conferences. It is almost 4.6 billion USD dollar worldwide and supposed to increase by almost 25% in next 4 to 5 years. Although ISHRS says that men is about 85%, but in our practice more than 95% are male only, and common age group is of course here it is about 25 to 40% and 60-70% are patients from that. If you see the history, there is no doubt that passion for hair for men is from the very old stage, and Ebers Papyrus 1500 BC, this is the earliest recorded treatment for restoring hair. But in late 19th century, a German surgeon and from Japan also, Dr. Okuda, they were the first to do hair transplant, but it went unnoticed because it was not in English literature, and actually hair transplant term started with the Norman Orentrich, which is in 1950s introduced punch transplant, and ST surgery was born. But this gave the doll look, like different punches taking out from the back of the scalp. But this also established the donor dominance theory, like those hairs persisted in the scalp. In 80s, mini and micrograft to overcome the doll look came, and mini graft used to contain up to 8 hairs and micrograft 1 to 3 hairs. They were randomly cut from the multi-bladed knife, and 4 strips used to be taken. I will show you that multi-bladed knife to get multi-strips. Then comes in 1984 Haddington paper on follicular units, because every hair has a follicle, grow in follicle, and they have 1 to 4 terminal hair, and sebaceous lobule insertion of erector perifollicular vascular plexus. These are the unit of the follicle, and then they started dissecting in the follicular unit, and then the hair transplant, because then it was possible to cut more number of follicles, and results started improving, and 90s were the time for FUT. If you see, the FUE also started almost in the same time, like Masumi Inaba in 1988 and Dr. Roots in Australia, they started in 1989. But what happened that initially it was manual only, so it never picked up a lot of hair because number of follicles were less. 2010 again the FUE was modified, and Bernstein Ramson and Dr. Harris really more popularized it, and he used to come to here Conference of India for a number of time. And lot of FUE surgeons, senior FUE surgeons are basically trained by Dr. Harris in country. Baldness is increasing in younger population. There is no doubt it is a cause of social embarrassment, psychological disturbance, and professional problem. And we call this androgenic alopecia, pattern baldness, because there are other causes of alopecia also, but we are not going to discuss that. It can be male pattern hair loss, or it can be female pattern. The reason are multifactorial, we all know. 2 main factors are androgens and genetic. Genetic, initially the number of patients come in very young age, like 25 to 35 years, and their parents got bald in 45-50, but they are getting bald in younger age. It is autosomal dominant with variable penetrance, and pattern is different in male and female. The mechanism of baldness is, it starts with the follicular miniaturization. Initially the follicles get miniaturized, and the hair which are supposed to last for 3 to 5 years, they start decreasing because the terminal hair starts behaving like vellus hairs, and anagen duration decreases. Occipital scalp is not androgen dependent, and that is the gift from the God that we have still a permanent hair zone in the occipital scalp, and from there hair can be taken, and then it usually persists in the transplanted area. And the theory is that dermis in occipital area is from the cephalic origin, while rest of the scalp is from the neural crest origin. This is the famous Hamilton-Norwood classification. Grade 1 to grade 7. In female pattern, Ludwig is the most common classification which describe 3 points. It is important to say that usually in female hairline doesn't recede, but it is the central baldness which is always more. Medical treatment, the proven is the minoxidil, 5 to 10% usually used. Then anti-androgens, finasteride 1 milligram daily, usually given by dermatologist. Hair serums are there. Mesotherapy was quite in vogue few years back, but now people hardly use it because initially it will give some result, and then after 6 to 8 years, number of patients came in that time that we have expended so much of time, but after 8 years again it has come to the back to square one. So now you will hardly see anybody doing mesotherapy. Although I have never done it, but PRP is going to probably stay because it is giving good results, and especially in early stages, PRP is very useful. Stem cell therapy is in progress. Nutrition has definitely a role, and there are a lot of nutritional supplements are also there. But one thing is important in medical treatment, that we must explain patient that please don't, because after 2-3 weeks they usually get result, and it is very difficult to use minoxidil twice a daily, said then they stop, and then again there will be all the hair fall will be there, more hair fall will be there, because whatever hair was there because of minoxidil and other medical treatment, it will fall. So it is important to say them that please don't stop it abruptly. Either if you are not using it twice daily, use at least once and few times in a week at least. Some important facts of the normal density of the follicle unit in almost every scalp is 80 to 100 square centimeter. But then some people here looks quite dense, others are thin. So the difference is that number of hair per unit may be 1 to 4, and especially those people who have thick hair, about 90 micron, they have 3 times volume than those who have thin hair, 50 microns. Recipient density usually plant 30 to 40 square centimeter or 30 to 45 square centimeter. And once the graft is taken out from the body, after its viability decreases after 2 hours, like their DHI, direct hair transplant. So they claim that once they take out, they will implant. But it is accepted now that up to 2 hours the viability is almost same, but it rapidly decreases after 4 to 6 hours. After 6 hours, it is almost useless. So that is very important. Then pulling and keeping weight with chilled saline to the grafts. Initially, when we started, people will take, because FUT was more in common, and then grafts are separated and we will keep in freeze, and then we will take it out. But now it is said that repeated thawing and warming is also decreases the viability. So it is just better to put chilled saline. Of course, some are using also PRP to keep the as a media to graft. And once we implant here, initially it will look there for up to 1 week to 10 days, and then it falls, roots are there, and the shaft falls. And then it starts to regrow after 3 months, and 3 to 6 months is the time when it will regrow. And this is the most difficult time for any hair transplant surgeon and also for patient, because we get repeated calls कि सर पहले तो बाल दिख रहा था, पता नहीं झड़ गया आएगा कि नहीं आएगा. So they are also in tension, we are also in tension. But results are seen at 6 to 9 months and complete result after 1 year. Second stage, when we are doing FUT, is said to do after 6 to 9 months when the scar is soft. But with FUE, we can do after 3-4 years, and sometime for larger session, even next day FUE is done when we do in 2 sessions. Minoxidil and finasteride is used in up to 6 months. But we tell them to continue it once a daily even after that. FUT can be combined with FUE to do large number of grafts in single session. Body hair transplants is also being done like beard, chest. But the problem is there usually single hair follicle and growth restriction is there, especially for chest hair, because it doesn't grow much. Discussion with patient when we planning to do HT, discussion with person is very important, because most of them will come with very high hope, and in internet, most of the things they will say that okay, you will get complete coverage and everything. So to bring them in the ground level is very important, that how much back density is there, how much graft they want, everything is there. And most important thing is the hairline creation. for getting a good result. Hair lice is irregularly irregular. It is made for by single hair follicle. Then there is central forelock, and maximum density is given on the left side because most of the people pair their hair from left to right. So left side is given central and then left and then right. The angle of hair is usually kept acute in front 30 to 40 degree, and we go back, angle increases. Temporal region, again there is very acute angle, and vertex, the whole pattern is there, number of grafts available and area of baldness, they all we have to discuss with the patient. The procedure is done in 3 steps. We all know that harvesting. So if FUT strip method was when we used to do strip method, first we used to, and then if FUE by follicle, then making slits of or holes, maybe 2000 or 3000 or 1000, whatever, and the angle, direction, density and size is important for them. The implantation of graft is very important because if we have taken a graft and it is cut, and then nobody will put it graft. Number of times when we are implanting, we damage the root and then it will not regrow. So it is important to implant them properly. But what happens actually is that, especially in a small town where you don't have other colleagues or technicians, then how to practice and how to train other sisters also is very important, because if you are doing only 500 or 800 follicles, then hardly any result is there. One has to increase the number of follicles. Usually done under local anesthesia. What we use is 1 vial of Galocaine and 130 ml bupivacaine, 1 vial 20 ml, 1 ml of adrenaline, and 100 ml of saline, 150 ml almost total, and this is used for almost everywhere. Usually daycare surgery. In strip method, a strip of skin with hair up to hair root is taken 1 to 1.5 centimeter in width and removed, and then it is sutured. Donor area is sutured or removed 10 to 14 days, or sometimes we use the Vicryl. We used to do, now I do mainly FUE. Almost everybody now is doing to FUE. FUT is almost hardly anybody is using. Then we used to at that time trigophytic closure for FUT, but even if you do trigophytic closure, scar is there, and this was one of the main reasons that it went out of the fashion, because of the cutting and the scar. People used to say that we are doing trigophytic closure but you will not get a scar, but this was not true. The scar is always there, and sometimes scar hypertrophy was always there, which was a complication. Hair follicle with root intact is separated, and then fine slits are made in front of vertex, 0.8 or 1 mm. Needle. Hair with root intact is inserted in these slits. Now post-op, most commonly problem or complication is some swelling in the forehead is expected, and we always explain it to the patient that there will be some swelling. In chubby patients, sometimes swelling is more, especially over the eyebrows, but usually it goes by the 1 week to 10 days. Antibiotic analgesics are given for a week, and when we used to do FUT, then feeling of tightness on backache. But with FUE, all these complications are not there. For FUE, we do dressing in the back for 5 days. And shampoo, when we are doing FUT, after 2 days we used to do shampoo, and now with FUE after 5 days. Till then NS cleaning is done. Actually, when we are doing shampoo, idea is that we make a foam and then just apply it over the grafted hair. And at the back we can rub, but don't rub in the front, just shower it with very gentle and clean it and let it air dry. Avoid helmet, t-shirt and heavy exercises for 2-3 weeks. Routine work they can do from the next day. So this was the time when we were doing FUT, and the strip was harvested, and then it was slivering was done to single hair follicle strips were cut, and then these are the slivering which was done, and then there will be a team of sisters which will do the cutting business when we are doing FUT. It was very important to train these sisters because there were no such team when I started doing hair transplant. So what I will do them, suggest them, because somebody who has started a new thing or anybody who starts practicing new, they can't keep so much of a staff. So I will tell them, few of them were with me, but I will tell those who are working in other nursing home also, you come here for 4 or 5 days in a week, do cutting practice, like I will do practice for the 10 to 15 year, 10 year back, when we used to go to hair conferences, there used to be silicone head model and then the artificial hair to practice, but that used to be quite costly. So I developed some indigenous method of practice, which I will show. So, but now with FU, you don't need so many technicians. I have only 2 and we can manage that. These are the FU motorized machine, and they are the, usually I use 0.9 mm but, and there are different types like blunt, sharp, semi-sharp. So I use sharp. And this was the 4 multi-bladed knife. Now nobody, when we are doing in 90s, people were doing with this, just to show you the history. And they used to have spacers. So 4 strip used to cut 2.5 mm. When I first went to my training, then I saw this method only. There were some of the grafted, dissected follicles. The hairline, when we create irregularly irregular, and then it is the central fork where we used to give lot of more density. This was the time almost in during 15 and 16, the work for FUT almost gone, and people were asking, if you are not doing FUT, no, we don't want hair transplant from you. So initially I was doing FUT, but then shifted to FUE also slowly. So these are the time when we are doing both. And now still some centers doing both the method, especially when they do 4,000 or 3,000 plus graft, then they take out a strip and then rest of the area they do FUE also. When we do FUE, these are the up to 5 days it heals. There was those who are going to aircon 7, 8 years back or 10 years, there were a lot of discussions within the advantage, disadvantage of FUT and FUE that time, about 10 years back. And one of the advantage of FUT was, people used to say that we always stick to the permanent hair zone. But in FUE, to take more number of grafts, you have to exceed upside and downside also, and to the temporal regions also. Second thing, the transaction rate in FUT was always less, because you are dissecting it under the microscopic or the under the vision. But in FUE, transaction rate was more, and initially the number of grafts which are harvested also more. But as the people got trained and they are doing 2,000 plus FUE grafts, now these discussions are hardly there, and first choice is always FUE. As I told you that I developed some at that time to engage my sisters and to train them, because we plastic surgeons are always, it is very easy to use magnification, and to do a good hair transplant, sisters should also be trained to magnify. So when we are not doing anything, I simply got these are nothing but pumpkin, and I will tell them that, okay, I will make the slit, because we say that we have to make 30, 40 per square. Then how, unless we practice it, how you know exactly that this is 30, this is 40, or this is 60? Second thing, when we are doing FUE also, it seems very easy that we are simply scoring. But then if you give somebody who is new and tell them to score 2,000 follicle, 2,000 holes, so slowly your finger will start itching unless you practice. And to balance it, just go in and come out, go in and come out without damaging much. Because if you go too deep, or if you stay there for too deep, you are going to damage the follicle and transaction rate will be high. So this used to be the method of practice. In whole pattern, in vertex, we will draw it and then we will make a slit, because the direction of slit will different from all the lines in whole. It is not the same. So when we are going in this way or this way, direction will be in that way only. So that used to be of course it looks very funny to practice in this way, but this was quite a cheap alternative. And locally in that way we can train our sisters and staff. I will simply tell them you come for 3-4 days, do 1 hour, use magnifying lens or optivisor, because once your sister use optivisor, after a hour she will say ki headache ho raha hai, we can't use it. And without using magnification, you can't allow them to touch hair follicle, they will damage. So I used to tell them, you come, everyone do for some time, I will pay you maybe 1,000, 1,500. When there we will do the case, you all come, we will pay you more. So that was the model I developed that time to get more number of people involved with me. So you can see the, and these are nothing but the paper strips which are given by the medical representatives. They are quite tough. So I used to draw lines of maybe 5 mm, 6 mm, and tell them, all the sisters use magnifier and cut them for 1 hour or 2 hours and then apply. Then you learn how to, you will practice it. So that will just help them to do something, not that we are directly poking on the patient's scalp. And this way we can practice that what is the density, 30 or 40 or like that. These are some of the magnified view of the rear point. I use a blade for making the hole. Some people use needle also. So this is a frontal hairline, we use the irregular here. And then we make them junction JV paint, and so that lines are visible, the cuts are visible, so that we can see and we don't miss anyone. I usually use 4x Jai's loop that time which I purchased, and my one other assistant use 2.4x loop, and other sisters use optivisors. So some results. This is also interesting that if you tell them to grow longer hairs, their result usually look good. There are some early results you can see. When this patient came after a year, he said, even I could not recognize him. He said, नहीं मैंने 1 साल से तो बाल कटाया ही नहीं, क्योंकि इतना मुश्किल से आया था hair. And then you see, simply see the result is slowly it improved also, as you can see. So you can get almost full coverage. I usually used to do 2,000 to 2,500 graft in a day, even with a few. Now I have not done 3,000 or 3,500 in a day. He was a football player. Once he got a result, he was very anxious to ask कि मैं head करूँगा तो दोबारा बाल तो नहीं झड़ेगा. I said, don't worry, nothing will happen. See the result. So this is just the graft which I applied to. Actually, when maybe 10 years back, there were a lot of talk about the mega session when you are doing 2,000 plus, and then giga session when we are doing 3,000 plus. But now almost everybody, a lot of people are doing 2,000 plus sessions. So these are not of much importance. But at that time, anybody who is doing 2,000 plus is said to be okay, something good. So these are some other results. You see, it is important to create the hairline which is irregular and not at the same line. I will show you when, if you have same line, which I also had, and even the density is good, it doesn't look very normal. Like here, we slowly started getting better results. The density was much better. But if you see these two young patients, both are bald. Here you see the hairline almost in the same line, but here it is it looks much more natural. So if you compare, the hairline was better with this person, although density looks better in this person. So it is very important to give a good hairline. And the hairline, when we talk, it is anterior hairline, then temporal or lateral fringe, then parietal fringe and anterior hairline zone. Oh, sorry. Then the design for the vertex. Landmarks for the hairline is the mid frontal point. Usually we divide the face in 3 steps, the nose and then forehead. And usually we draw hairline about 1 centimeter above, so that even when the patient is getting more bald, at least he will have hair in the center region. Then this is a picture which is a transition zone is there. then the 2-3 hairline follicles, then this is the central tuft and central zone. These are the landmarks and the diagrams which are usually available. Factors for hairline. So age of the person, grade of the baldness, available grafts, number of grafts patient want, number of stage patient is willing to go, and sex. These are all important for the maintaining hairline. For example, if somebody is in the 40s and if other is in 30s, then we will give a different hairline to them. We will not just fix them the same hairline for both. And now, in fact, the templates are also available for the hairline, but it is always important to decide on that basis and what grade of baldness he is having. Like if a grade 3 or grade 4, we can give the lower hairline, but if this is grade 5 or grade 6 bald, then it is always better to give higher hairline, because number of times you will see people have just a fringe of hair in the front and the whole scalp is bald. That doesn't look natural. A male doesn't get bald from in the center totally, so that is not very convincing. Also, if patient is ready to go second stage, then we can always give them first stage a higher hairline, and second time we can draw the hairline together. Female, the hairline is always no anterolateral balding, but it is always a circular. So transition zone is there. This is the anterior most portion in the hairline. It is irregular, about 0.5 to 1 centimeter, and single hair is used shifting to 2 hair units. Then smaller intermittent triangular shaped areas of higher density is made. Then there is a micro-irregularity and macro-irregularity, what we call them. Then defined zone, posterior to high density zone with 2 or 3 hair units, 2-3 centimeter is the defined zone. And then there is a frontal tuft, which has the maximum density. See, this is also important. Like this is a 5th post-op day, and we have done a few, almost 2,200 grafts. Like these are the hairs which are to give irregular hairline, and then maximum density here. See, density doesn't mean that we increase the number of slits only. Actually, what happens that the sister who is separating the graft, once we have taken it out, 2-3 hair follicles are given in the center first, then in the left side, and then we give it to that side. So in that way, with the same number of slits, the density will be more in this region, and then patient usually pairs hair from left to right, it will be more in this, and as we go back, we can decrease the density. So this is about 2,200 graft by FUE. Number of time such patients comes which has just to augment their hairline. He is hardly grade 2 bald or grade 3 bald. First in the grade 2 bald. First, when he came in my clinic, I said, no, I want to hair transplant because you have such good hairs. He said, I have to keep my hair long, and he was showing that because otherwise it is quite recessed now. I am quite young. So he just wanted to fill that. The problem with such cases is that if there is a family history of baldness, then with age his other hairs will fall and these hairs will only remain, and then it will look very odd. So I asked him that if there is any history of baldness. He said, no, there is no history. And then only after second counseling only I went for his hair transplant. The other problem is that his density is also good, and then we should match the density also. So this was the region which we transplanted, both the side. And his temporal region, he didn't wanted a very triangular region. He said, as I have, you just augment that. So this was his result. Once you can see now there is hardly any temporal hair, and he was quite satisfied with that. And his temporal hairline has also been increased. No more anterolateral gap, and the density is also almost matching because we were all implanted almost 2-3 hair grafts to match the density. The big problem is also that to getting a result, photograph is new. Initially, patient will call you a lot, up to 3 to 4 months when they are not getting the result. But once they suppose they get the result after 6 months or a year, then you have to call to kaisa hai, even if they is okay, and it is difficult to call them to take a photograph. So number of time I have requested them, then why don't you send me photograph so that I see how you are. Achha, fast kar dena. These are the results. So they are the results sent by patients. This is the vertex. When he came, he said, can you do anything with, he's quite young, 27-year-old, but not getting married. So I said, okay, we'll do in 2 stages. First high hairline, then second we decreased it. And this was the result which we get him. This was his back. These are two brothers, as I said, age difference. He is 30s and he is in his 40s. He said कि boss इतना जवान नहीं बनना कि practice कम हो जाए. Both are doctors. So he was ready for 2 stage. And he said, no, I just want some hair. So you see how they progress. So here you can see that 1800 grafts only. And he has high hairline. Angle is also there. And he was second one. And this was the complete coverage in 2 stages. First was done by FUT, which is a scar, and second was done by FUE. Again, this is a photograph sent by patients. You can see some results. These are the grafted hair. This in ladies anterotemporal angle and the very high hairline. So this is the result after that, which we decreased. This was having grade 6 baldness. He came with it. We grafted. This is the hair which we grafted, and this is the result. These all are FUE. Now we do, like I just told you, the male doesn't get baldness in center, but sometimes we get. You can see his baldness is visible almost. We did it from the back up to, and then this is the result after 3-4 months. This again is both anterolateral baldness. Here density is more, and here we have to preserve the existing follicle also. So we trim here, frontal hair, and then we just preserve the hair follicle, and then we make slit, and then we shave. So this is the result by FUE, all this. This old one, this was with FUT. Here you can see that proper triangle also made. This with FUE. So it doesn't matter which technique we are using. If you are doing a good transplant and follicles are viable, result will come. This is the about 2,500 hair follicle which we transplanted. So conclusion, it is a personal training, then a good team, maintaining the team, taking care at all the 3 steps of ST, adding on new technique and learning process to continue. Thank you.
Thank you, Dr. Sinha, for a beautiful presentation. But because of paucity of time, we'll have no questions.
Thank you.
One question there. One question.
As 2016 at CUTTACK, Dr. Garg has presented a presentation. He got the best award. How to keep these hair follicles? The hair follicles he is keeping in this plasma. He was keeping this in the plasma rather than using this pooled.
See, most of the
any
people are,
comparative study of this pooling?
I think he is, there are very few surgeons who are using plasma. He is one of them. Most of the people are keeping it in the time factor is the more important. What his suggestion is that when we keep in the plasma, then plasma makes a scaffold, and the hair follicles will survive for longer time. But now the way we do also, the idea is to do it within 2 hours. Like first we make slit, and then we tell the patient to lie down in prone position. We do the scoring, take out the follicle, and then we graft it immediately. And then only we give a break for whole team. It is not initially what used to happen, that when you are taking a FUT, a strip has been taken. Now grafting is, they are separating it. So by the time last graft will go in, it will be 4 or 5 hours. But now with FUE, you can divide it in 2 sessions. We usually do it in 2 groups. First we score for 1.5 to 2 hours. And then if we need more graft, then we give a break, we again do it that. So in that way, of course, if you do plasma, then it is fine. I don't disagree with that, but most of the people is just using chill saline and then they are doing it.
So any questions you can discuss during lunch time?
Thank you.
Next topic of discussion is management of complex hair length by our dynamic HSA president.
Thank you. तो वो लास्ट में दिखाएंगे.
वो जब मेरी खत्म होएगी ना तो उसको प्रोजेक्ट करना है। अभी उस पे आ नहीं रहा है। It will take some time. Good morning, everybody. So first of all, I would like to thank the APRASO and its organizing committee for giving me this opportunity to be here today with all of you. And in fact, I feel happy that I was elected the president here only, and probably, this is my first meeting which I am coming here as president. So thank you so much, Dr. Vibhuti and Dr. Abhishtas and all the organizing committee members to have called me here. And the topic today, which I will be discussing with all of you, is the complex lower extremity reconstruction. So that is one thing, which is very close to my heart, and that's probably what I have been doing for the last about more than 30 years. So what is the complex wound? So we can define it as the one which cannot be healed by any conventional means and requires a specialized treatment and many times multi-specialty involvement. That's how you can, define it. And these complex lower extremity wounds can be following trauma, following cancer ablation, or even the diabetic foot disease, peripheral vascular disease, or the trophic ulcers. But I will be confining my presentation to the lower extremity reconstruction following trauma. And whenever you get a patient of complex lower limb trauma, I think the initial evaluation when you do, it's very important to do the general evaluation of the patient also, because many times, we have a very tubular vision and we forget that the patient may be having any other associated injuries also, which will have the bearing. And then, of course, you have to do the examination of the injured limb. So in general evaluation, it is very important to know whether patient is having any associated life-threatening injuries, for example, severe head injury or thoracoabdominal trauma, because if that is there, then the management of the extremity trauma will, probably not take precedence, but it will be the life which is more important than the limb. So we should always remember that, and we should look for that. And when you are taking history of these patients, so it's very important to know that when this injury occurred, where did it occur and how did it occur. So when is particularly very important when patient is having the vascular injury, because as all of us know that the ischemia time is very important if there is a vascular injury, and we'll talk about it a little later. And then where it has occurred. For example, if it's a roadside accident or it is an agricultural accident, then the contamination is very high. And the third thing which is very important is that what is the magnitude of the force and the degree of the soft tissue damage. Because in high velocity trauma, from plastic surgery point of view, I think it's very important that when there is a high velocity trauma, most of the time you may not be able to use the local tissues or the regional tissues for coverage. So I think that's a very important consideration which we have to keep it in mind. I have put up this picture just to show that in a vascular injury, if you are getting a patient where the ischemia time is going to be more than 6 hours before you are able to perfuse the limb, the first thing you should do is you should do the fasciotomy. And if there is no circulation to the muscles, which sometimes may be there even because of the vascular injury as a result of collateral circulation, then the chances of reperfusion injury are very high, and you have to then go for amputation in these cases. Then having whether your patient is having any comorbid conditions, because if patient is having uncontrolled diabetes, uncontrolled hypertension, and a severe ischemic heart disease, then that has to be taken into consideration while you are taking a decision to save the limb. And history of smoking again is very, very important, particularly, as we know that the wound healing is always a problem in smokers, and FAPS will give you a problem in smokers. Now, coming to the examination of the injured limb, you have to, first of all, whenever you get a patient, you must look for the vascularity, because that is something, which will probably make, your management very, very urgent if the vascularity is not there. So for that, you have to see the color, turgor, peripheral pulse palpability. And in emergency, you should always have a handheld Doppler which should be available to you, so that if the vessel is not palpable, you should be able to see it with a handheld Doppler. And but always remember two things, that when patient comes in emergency, many times peripheral vessels may not be palpable because patient may be in severe shock, and the patient is having hypotension. So don't think that it is only vascular injury. Sometimes it may be that the patient is in shock, or sometimes there is a fracture which you reduce, which is just putting pressure on the vessel, and once that fracture is reduced, you may get back the vascularity. So CT angiography is done only on those cases where there is a doubt. Then of course you have to do the bony evaluation clinically as well as radiologically, and you have to know the type of fracture and whether there is any bony loss. But most of the time about the bone loss you will know only after you have done the debridement and you are able to do the final examination after the under anesthesia only. So coming to the soft tissue evaluation, initial evaluation, you will just know that how much is the loss, but the final assessment is usually possible only in the operation theater after you have done the debridement, because whatever dead tissue once you have removed, then only you will know that what is the extent of the loss. As you can see in this patient, when this patient came to us, I mean, somebody had just put some tagging sutures here and didn't look like that there is much of the soft tissue damage. But once we took the patient to the operation theater, we saw that the whole of the skin was actually avulsed and the underlying tissues were also damaged, and you see the extent of soft tissue loss which is there. So it's very important that you do your evaluation of the soft tissue loss after you have done your debridement. And in this case, the loss was so much that we had to use not only the LD muscle but the SA muscle also to provide the soft tissue coverage in this case. Now, neurological evaluation again is very, very important, and motor and sensory evaluation of both common peroneal and posterior tibial nerve you have to do. But the posterior tibial nerve is more important because the sensations on the sole are very important. All of us know that if there is no sensory recovery, then the patient will go on having trophic ulcers throughout one's life. So this becomes a very important consideration, particularly when we are deciding about the salvage of the limb, about which again we'll talk. And just to give you an example, this patient came to us with a almost near total amputation and with a lot of crushing. But the only thing which was important was that somehow the posterior tibial nerve was the only thing which was intact in this patient. So what we did was we just removed that crushed part and do the kind of reimplantation or revascularization of the limb. There was no circulation, but later on, we were able to take care of the length of the limb with Elizarov, and as well as we had the bony union, and patient was able to walk on the same limb. So if the posterior tibial nerve is intact, you should make all the efforts to save that limb, but it doesn't mean that if it is damaged, you should not try, but that becomes a relative, kind of a indication that you may have to go for amputation in those cases. So having said that, still I would like to talk about the various factors which we take into consideration when we are deciding whether this particular limb should be salvaged or it should be amputated. This is a very, very important decision which one has to take in cases of complex lower extremity trauma, because if you have to go for a secondary amputation later on, it's very frustrating both for the surgeon as well as the patient. So that's why it's so important that you take the right decision right in the beginning, because after you have done your free flap, after you have done multiple surgeries, patient has spent a lot of time and money also, and then you tell them to go for amputation, it's a very, very difficult decision for both of us. So always take this decision very judiciously, and most of the time it is a individual decision which one has to take in a particular patient. And systemic factors which have to be taken into consideration is associated injuries, about which we have already talked. If there are life-threatening associated injuries, But then there are other things also which are very important, because many times these patients may be having polytrauma. So because of that, patient may have persistent hypothermia, persistent hypotension, acidosis, or coagulopathy. So if these things are there, then the situation may go more in favor of amputation. Similarly, in comorbid condition, if patient is having uncontrolled diabetes and severe ischemic heart disease, then again, your decision may go in favor of amputation. And now coming to the local factors, if the limb ischemia is present for more than 6 hours, again, you may have to go for amputation in these cases. Posterior tibial nerve, if it is transected, this also favors amputation. I'll not say that this is a total contraindication, but that is an important consideration. So if the severe mangled ipsilateral foot is there and you are trying to save the leg, the patient may not be able to stand on that foot. So if the ipsilateral foot is very badly damaged, then also you may go for amputation. And if it is a large crush injury where the soft tissue loss is going to be so extensive that it may not be possible for you to cover it, then again, you may have to take that into consideration. Then other important factors is the age of the patient, socioeconomic factors, and what is the desire of the patient and the relatives. Age is no contraindication though, but then the health of the patient, that has to be taken into consideration. And if extremes of age, sometimes you may have to take a decision in favor of amputation, considering that there is any danger to the life of the patient. Socioeconomic factors, I think, is a very important factor, because if the person is the sole bread earning member of the family, when subjecting that patient to a rehabilitation period of about 1 to 2 years may be very damaging to the family, and you may save the limb, but you may destroy the family. So do take that into consideration also. And if the amputation is required, the patient will be back to work in a period of just about 3 to 4 months, whereas it may take about 1.5 to 2 years for that person to go back to work. So having said that, you have taken all the factors into consideration. You must discuss it with the patient, with the relatives, and they should be ready, to go for a extended period of rehabilitation. Only then, you should try to save that limb. So we have to discuss it with the patient's relatives. Just to give you an example, this is a 28-year-old female with severe crush injury of the leg who came to us. And just seeing the limb, it looked like that it will not be possible to save that limb, and we may have to go for amputation. But one of the factors which made us to take a decision to try to salvage this limb was that she was a young girl who was a student, and she was going along with her friends to lay on a bike, and she had an accident. But then she had a very strong desire that whatever it takes, you must try to save my limb. Socioeconomically, they could afford. She was not a sole earning member of the family. So we took her up, and after the radical wound debridement. So radical wound debridement is very, very important, as we will be discussing there. And there was a big amount of bone loss which was there. And next day itself, we took her up, and we did a osteocutaneous free fibula flap, as you can see here. And then she was put on Elizarov so that she could walk on Elizarov itself. And then over a period of time, the fibula got hypertrophied, and then now she is able to walk with the same limb, which was so badly damaged, of course, with the use of initially with a brace, but then over a period of time the fibula will hypertrophy, because the chances of fracture are very high in fibula. So you must tell them to walk with some kind of a support initially in the form of a brace. So the sole reason in this patient was all the factors which I have told you, they were in that favor. A number of scores have been given, which help you in taking the decision whether you should salvage that limb or you should, go for amputation. But they are all, basically to guide you, and most of the time you have to take an individual decision. But we have, seen that wherever we are in doubt, we always take the Ganga Hospital Open Injury Severity Score into view. And if it goes more than 16, then we will go for amputation. But between 14 and 16, most of the time it is borderline. So those are the situations where, probably you need to discuss it with the family. And if they're ready to take a chance, only then you should go for the salvage in these kind of patients. Now, once you have taken a decision that this limb can be salvaged, then you have to have a full plan in mind that what you are going to do in this particular patient. And the first and the foremost thing is in these patients that you have to do the radical wound debridement. So this is something, which I would like to stress a lot, because if you are going to do any kind of a reconstruction without having done a proper debridement, that is bound to fail. So debridement, I will say, that forms the foundation of your reconstruction. So if your debridement is not good, your flap can fail, you can have severe deep infection, and then ultimately you may end up with amputation, in spite of the fact that even if your flap has survived and everything is fine, but still you may have to go for amputation. So once you have done the radical wound debridement, if possible, go for the definitive skeletal reconstruction, or initially you can stabilize and then later on do the proper skeletal reconstruction. And then of course you have to go for soft tissue coverage. Now, once you have done the radical debridement and you have done the skeletal stabilization or reconstruction, when should one do the soft tissue coverage? So whether you should go for immediate coverage, or you should do it early coverage, or you should do it late coverage. So we'll discuss about it, but after 3 months is something which is no more acceptable. Godina talked about it at one point of time, that if you are not able to do it within 72 hours, then probably you should do it after 3 months maybe, but we no more follow that. And what we say is that one should do the soft tissue coverage as early as the patient as well as the surgeon is ready, which means that if the patient is stable enough to be taken up for a major surgery and your logistics are good, like you have everything in place, then you should go for it. So it should be done as early as possible. But then there are certain situations where you have to provide the immediate flap cover. And what are those situations? One is that if the orthopedic surgeons have done definitive osteosynthesis, if they have put a plate or a nail, they would want you to cover it immediately. So wherever possible, we should try to do that. And if you're doing a local muscle flap or a local fasciocutaneous flap, that's something which can be done at the same time. But in those cases where there is a compromised distal circulation and you have taken a decision to do a flow-through flap, then you will have to do it as an emergency flap, as we did in this case. In this case, the posterior artery was damaged. Somehow the anterior tibial artery was not giving a very good circulation in this patient, and it looked a little compromised. So we did a flow-through ALT flap in this patient. But then there are certain situations where early or immediate soft tissue cover may not be possible. And what are those situations? If you are not sure about your wound debridement, then you should not give the coverage at the same time. Then if many times patient may come late to you, the wound is infected. So it's not that you just debride and immediately cover it with the soft tissue. If general condition of the patient doesn't allow the patient to be taken up for a free flap, then you may have to wait till the patient gets well. And similarly in comorbid conditions, and if the logistics are not in place. So just to give you an example, this patient came to us with an infected wound, as you can see, pretty bad. So after debridement, we just put a negative pressure wound therapy, and now you can see that the wound is granulating and it is ready to be taken up with the coverage. And then later on, the patient had the LSROV, and then everything healed and is able to walk. So in infected wounds, you cannot give an early coverage. You will have to wait for the wound to be totally clean. And then this patient came to us with polytrauma, or had a severe head injury, and he came to us on 19th. We did the debridement. So even if the patient is having head injury or something, you can talk to the to your anesthetist and at least try to do the debridement. Because if you don't do the debridement, then there can be a lot of problems in the form of infection or necrotizing fasciitis. So do the debridement, which is not going to take a very long time. And then in the intervening period, you can again use the negative pressure wound therapy. And when the patient is all right, then he can be taken up for a flap cover, as we did in this patient almost after about a month's time. But the negative pressure wound therapy during the intervening period is very useful, and it keeps the wound quite clean, and there is no swelling also. And then the chances of perivascular fibrosis, they also decrease, if you are using negative pressure wound therapy during the intervening period. So now next thing which is important is that how do you choose the soft tissue cover, whether you have to go for a local flap or a free flap, and in free flap, which flap has to be done. And we have all been listening to reconstructive ladder or reconstructive elevator, but I am of the view that it's not about the ladder or elevator. In a particular patient, what is required, you have to take a, the individual decision in that particular patient, and it is going to depend upon a lot of factors. What is the size of the defect? If it is a small defect, whether it is a small defect or it is a large defect, what is the condition of the surrounding tissues? Again, this is very important. And whenever there is a high velocity trauma, the surrounding tissues may have a lot of, avulsion or, injury, underlying injury, and you may not be able to use the local tissues in those cases. And then what is the region of the defect, whether it's in the thigh, it is an upper third, middle third, or the lower third, depending on that. And what is going to be the donor site morbidity? So if it is a young female patient, you have to keep it in mind that the donor area which you are giving, that should be, aesthetically should look good, or it should preferably come under the in those areas where, the routine clothing will cover it, and then functional and aesthetic outcome of a particular flap. And another thing which is very important is sometimes there may be a wound which can be skin grafted. But if the orthopedic surgeons have to come back and do some kind of a secondary surgeries, then you will have to put a flap in that area. So just to give you some of the examples, for example, this patient came to us with a wound, which could be easily grafted, and we grafted it. But then later on, we realized that the patient has the displacement of the hip joint and the fracture, and the total hip joint replacement had to be done by the orthopedic surgeon. So we had to replace this skin graft with a ALT flap, and then they were able to do the total hip joint replacement in this patient. So if the secondary surgery is to be done, even if it is a skin graftable area, you will have to do a flap, or initially you may do grafting, but later on you will have to replace it with a flap, as we did in this patient also, who needed plating of the lower end of the femur. So we replaced the skin grafted area with the ALT flap, and then later on the plating of the lower end of the femur was done by the orthopedic surgeons. Then other factors, which are important is the surgeon's skill, performance, and available resources for free flap. So it's not that if the facilities for free flap are not available, still in many circumstances you may be able to, manage it with a cross leg flap, as I will be talking about it later. Then whether the vessel is available for anastomosis or not, what is the pedicle length which is required, what is the diameter, and if you are working in a private sector, then economic factor also has to be taken into consideration, because sometimes, a patient may not be able to afford, a free flap. But what I have realized is, even when you are doing a cross-leg flap, even in private sector, ultimately the difference doesn't come out to be much, because they need multiple surgeries. So we have to decide about the best reconstructive option after taking into consideration all the above factors. So according to the region, in thigh wounds, I think all of us have seen that soft tissue of the wounds of the thighs, they are usually less challenging, and because there is a large amount of bulk and there is a good vascularity of the local tissues, most of the time you will be able to cover it with the local tissues. As you can see in this particular patient, the bone is exposed, but we were able to cover it with the local muscles here and then skin grafted. But there may be a situations even in the thigh also, though less often as compared to the leg, where the wound is very large, like in this patient, latissimus dorsi myocutaneous flap had to be used, but in thigh generally it is very less often that we have to use a flap. Now coming to the knee and the upper third region, and in large number of cases in the region of knee as well as the upper one third, one will be able to cover the wound with a gastrocnemius muscle flap. Either you can use one belly or you can use both the bellies. And I think this is very important also because these are usually periarticular fractures. And in periarticular fractures, if the orthopedic surgeons will put an external fixator initially to provide a coverage and then they will come back and do the plating, then the functional results are not very good. So, but if the definitive skeletal reconstruction is done at the same time and then you are able to provide the coverage also at the same time, the functional results are very good. As you can see in this patient also, he is having very good flexion of the knee joint. And another patient, where we have used the medial head of the gastrocnemius and they have put 2 plates. And if your defect is little lateral, then you can use the lateral head of the gastrocnemius also. But whenever you are using lateral head of the gastrocnemius, please take into consideration that you can cause injury to the common peroneal nerve. So be very, very careful. And I have seen that happening sometimes. So be careful about the common peroneal nerve when you're doing that. And this is an example where both the bellies have been used. So you can use both the bellies of the gastrocnemius without much of the donor issues of the donor area, because the patient will be able to walk in a normal fashion, though running and all, there may be a little bit of problem, but most of the time, even if you are able to use both the bellies, there will not be much of the deficit. This is another example where both the bellies of the gastrocnemius have been used. Generally, we avoid using the local flaps in the form of fasciocutaneous flaps because of the injury to the surrounding tissues. But this is just to show an example that you can do that also. But sometimes, if the wound is very large, you may have to use the free flap. But in this case also, our orthopedic surgeons preferred that they do the definitive skeletal reconstruction, in order to have the good movement of the knee joint. But then next day itself only, because you can't keep the plate exposed for a very long time. So we covered it with the latissimus dorsi muscle flap. But just see that these wounds and these fractures will heal just like a simple fracture. So as if it was a simple fracture where they have done the plating, the way it will heal in the same way. So once you cover these wounds with a flap, they will heal in the same way as a simple fracture will heal if the orthopedic surgeons have done the definitive skeletal reconstruction. So this is another example, where we have used both latissimus dorsi as well as the serratus anterior flap, because the defect was very large. And they were in this particular patient, they were not able to do the definitive skeletal reconstruction at the same time. Initially, only the fixator was put, and this was done later on. And you can see that it does the movement of the knee joint does get compromised if it is done in a secondarily later on. So this is an example of a knee joint defect where the ALT flap has been used, and descending genicular artery is a very good recipient artery which can be used in these patients. Coming to the middle 1/3 of the leg, theoretically we have soleus muscle also available, but soleus I don't think is a very good flap, and most of the time I prefer not to use it, and more so if it is a high velocity trauma. So in those cases, most of the time this is damaged, but just to show you one of the examples where this has been done. And sometimes for small defects, particularly if the secondary defect is there, like in this case, we had used the gastrocnemius initially, but then later on some part of the plate was exposed. So we delayed it and then used this fasciocutaneous flap. So even for a smaller defect, if you are using a fasciocutaneous flap, it may be a good idea to delay the flap first and then go for it. And for middle third of the leg, again, if the soft tissue defect is large, so we always prefer to use a free flap. And if the defect is very large, as you can see in this case, you can use a combination of the latissimus dorsi and the serratus anterior flap. So we have actually used the combination of the LD and the SA quite often, and it is very useful, particularly in those patients where proximally the defect is quite wide, because as you know that the LD is a triangular kind of a flap. So proximally, if your defect is very wide, so then you need more muscle there. So serratus can fill up that that kind of a gap. And for middle third, you can use the ALT also. ALT is also, but ALT, the problem with ALT is if the patient is little bulky, then in those cases it becomes a little difficult because it's quite, then becomes even difficult to suture it on all the margins if there is a lot of fat over there. And smaller defects, we can use the gracilis muscle also, as it has been used in this particular patient. So similarly, in the lower one third of the leg also, there are a lot of regional flaps which we are aware of, distally based flaps. But then I again would say that don't use these kind of flaps, particularly if it is a high velocity trauma. But then in a low velocity trauma, we can use it, because we have seen that if we are using local and regional flaps in high velocity trauma, then the chances of the failure rate is very high for the local flaps and the regional flaps. But like this was a low velocity trauma, and in this case we have used a distally based flap. Initially plating has been done, and just to buttress it further, they have put the external fixator also. But this was a local flap which has been used. But then this was a patient where it was a high velocity trauma, and the defect was also very large, and we have used a latissimus dorsi muscle flap. Again, this is an example of latissimus dorsi muscle flap for the lower one third in the TA region. And if the patient is not very bulky, and then you can use the ALT flap also. This is an example of ALT flap. And again, as I showed one of the examples in the middle third, in the lower one third also, if your defect is not very large, you can use gracilis. Gracilis actually can be expanded to cover almost about 10 centimeter of the width. If your defect is not very deep, and it is only a surface defect, so then you can expand it by about to about 10 centimeters, you can cover it. Now, we have published in Indian Journal of Plastic Surgery about the role of cross-leg flap also. We do a large number of free flaps at our center, but then there are situations where, for some reason, for example, if you are not getting a very good flow in the vessel, or it is a single vessel disease, or you have lost a free flap, so you don't want to take a chance next time. And and you don't want to take a chance for the next time, then you may go for a cross-leg flap also. This is just to show some of the examples you can. Some of the examples of the where we went for cross-leg flap, and you can do conventional cross-leg flap, or you can do a distally based cross-leg flap, and even proximally based cross-leg flap we have done for proximal defects also. So this was now I would just discuss a little bit about the management of bone gaps. So if there are bone gaps, small bone gaps, we can cover it with the cancellous bone graft. But then the other two methods for large bone gaps are distraction lengthening, either in the form of Lizarov or using a monorail fixator, or using a vascularized bone graft. So vascularized bone graft has the advantage that it is a single barrel vascularized fibula. You can use double barrel, or you can use DCIA. And Kapana technique, I don't have much of an experience because we don't have bone bank, but it is mostly used in cases of following post-cancer reconstruction, or sometimes, for femur, it has been used. And I think in the hospital, people have a good experience with the Kapana flap. Personally, I don't have much experience with that. So this was a defect, a large defect in the femur, where we have used this vascularized fibula, where there was no need for using having any skin pedal, and you can see that over a period of time this has got quite hypertrophied, and the patient is able to bear weight very well on this fibula. So if it is a relatively smaller defect, you can make it double barrel also. And in this particular patient, the defect was if it is in the lower end of the femur, so then you can either use double barrel, or you can go for a DCIA bone flap. In this particular patient, actually, my plan was to do the double barrel fibula. But then when I did the angiography, I saw that the peroneal artery was absent in this patient. So that's why I had to change onto the DCIA bone flap in this patient. But this also does very well. And you can see here that this is a DCIA bone flap which we have used. And initially, the orthopedic surgeons had put a locking plate here. And then they put another plate, when the DCIA flap was done later on, and it did quite well. But if it is a large bone defect of the tibia, then you can either go for distraction osteogenesis. Here initially we did a latissimus dorsi muscle flap, and this is the bone defect which is there. And then our protocol is that initially we put an external fixator, cover it with a free flap, and then once the wounds are healed, after a period of about 3 to 4 weeks, then we change it over to Elizrov. So though people are doing it right in the beginning also, where they're putting Elizrov in the beginning itself, and then, though it becomes a little difficult to do a free flap with the Elizrov in place, but it is possible to do it. If the only thing is you have to do use little longer, instruments, and you have to keep a little space there. But we prefer that initially we use an external fixator, and you can always change it to the Elizrov after a period of 3 to 4 weeks. And you can see that there was a large bone defect, and then this is with Elizrov that the whole bony reconstruction has taken place. In fact, another advantage of using Elizrov in place of monorail fixator is that with Elizrov on, patient can walk. Patient can do the weight bearing very well. So patient is, so that also helps actually in the bony union. So another example where there was a large bone defect, as you can see in this case, and with Elizrov, very good bony union, takes place. And though, of course, it takes a little time, but you can see that the bony union is very solid in these cases. So initially you do a flap, then put a Elizrov, do the distraction osteogenesis, and you will have, but then I'll show you some of the examples where we have used the vascularized fibula also. I showed you one example in the beginning. So this was a severe crush injury, you can see here, and there was a large amount of bone which was lost around the knee. And there was no way that we could reconstruct the knee joint also in this patient. So what we have done is that we have used a vascularized fibula, and the proximal part of the fibula was put into the femur. In this case, you can see that the fibula that has been introduced into the femur, and then later on actually had a fracture here. Then the orthopedic surgeons have put a locking plate here, and now he's having very good bony union, and he has orthodesis of the knee joint, but is able to walk on this limb. So I think before I just finish my talk on the lower extremity trauma, I just wanted to put a little bit of a word about the replantation in the lower extremity. As far as the replantation of lower extremity is concerned, this is a bit controversial issue because most of the time it is felt that since we have very good prosthesis available, so the reimplantation is usually not required. But then there are certain situations where I think there should not be any controversy. For example, if you have something like this clean cut amputation and patient is a young patient, so there is going to be a very good neurological recovery also in these patients. So you can always, do the reimplantation if the patient comes well in time. And this is what it was done. And this was in a child, again, in our part of the country, agriculture injuries, which are there, they have some cutters behind the tractors and they cause very sharp injuries. So in those cases, you can go for implantation with very good results. And these are some of the examples of that. Though in crush injuries, those of you who have heard Pedro Cavadas from Spain, he has been doing a lot of reimplantations in the lower extremity, even in crush injuries also. But we generally prefer to do it only in those cases where there are clean cut injuries. So to conclude, I would like to say that as far as the lower extremity, severe lower extremity trauma is concerned, the close coordination between orthopedic and plastic surgery is the key for successful management of the complex lower extremity trauma. principles of radical wound debridement and early soft tissue coverage is of prime value to reduce the morbidity and early rehabilitation of the patient. And microvascular surgery has of course made it possible to salvage a number of limbs which probably was not possible earlier. So thank you so much and for having me here. And
Thanks, Dr. Mahajan, for a extensive and excellent deliberation on complex trauma. Now it's open for questions.
yes, sir.
Dr. Ravi, the name itself implies sun. So the sun has risen from the east of the country now. So your presentation was fantastic.
Thank you.
And it
Thank
was
you
a
so much.
very educative to our young surgeons, in fact. And you have a large experience of your personal experience, and you are lucky in one sense, which we are not lucky, in fact, that you have an orthoplastic team. So you have a very good advanced orthopedic center there.
Yes.
You are also with them with a good coordination.
Yes.
But unfortunate part of in our country, most of the center, even including this premier institute, we do not immediately get a patient in the casualty where we have to deliver and assess the patient and advise the patient for the right ideal treatment for that particular patient. So most of the patients with compound fractures of the lower limbs, when they attend the casualty, the orthopedic surgeons are the prime surgeons who take decision about the case. And in that case, what they do, they put off suppose they find a compound or a open fracture, put an external fixator, maybe a monopolar or a bipolar, whatever system, I mean bipolar axis, external fixators. Then after a couple of days, or if there is a vascular complications, then they call us. So in that scenario, already they have put the different pins and different fixators pins on the right on the defect space. So in that scenario, what will be our module of treatment in those cases?
Yeah,
They are not neglected cases. Somehow there have been some coordination difference between these two specialties where we are concerned. In your situation, I have seen your center, I had been there. There is things are different because you have all a good cooperation right from the beginning, and it is also happening in Ganga Hospital, where both brothers, Rajshekhar and Raj Shavapati, they both have a very good unity and they take decision simultaneously as a medical board almost.
Yeah. Yeah, I totally agree with you. Actually, this kind of a management is only possible if we have a very close coordination with the orthopedic surgeons. And as you said, in Ganga, both of them are brothers, but here the chief of orthopedic surgeon happens to be a very close friend of mine and my classmate. So we have developed a very close coordination. So yeah, so I think we are the ones, who have to take this up. And I would have loved if we had the orthopedic surgeons sitting here and they could see that how we can make the difference to the patient's lives if we work together. So that is, I think, the key, having that orthoplastic approach. Actually, right in the emergency, the patient should be seen both together by the orthopedic surgeon and the plastic surgeon and make a decision about the salvageability and about the plan. As I said, that initially the decision is whether this particular limb can be salvaged or not. And the second is you should have your plan in place right in the beginning so that you don't have to face that situation of secondary amputation. So that is something very, very important. And I think that message has to go across to our orthopedics colleagues also, because we are all actually working in the interest of the patient. So, and it's not, I will say, the blame doesn't lie only with the orthopedic surgeons, because many of us are also not ready to go to the casualty and see those patients in the middle of the night. So if we are also ready to do that, I'm sure it will be possible to do that. Like at my center, now we have a team of around 7 plastic surgeons. So somebody is there, one MCH fellow is there 24 hours, inside the hospital to take, and the orthopedic surgeon and the plastic surgeon see these patients together. And now I think with that WhatsApp, it has become possible now to talk to the senior person also and send the pictures, and it becomes very easy to take the decisions at that time. So I agree with you. I had worked in the government setup for 8 years and I have also faced that problem. So I'm quite aware of that. So, but I think this is a work in progress and all of us have to make efforts to, work as a orthoplastic team. So we have to have an orthoplastic approach. Only then we will be able to give good results in these patients.
Absolutely. One of the higher meetings in the government, I was there unfortunately, the dean also there in that meeting and superintendent. I told that like we have to have a Ganga principle.
Yeah.
Then they told what is Ganga principle? Ganga principle means any patient attending of any faculty, any department, even including neurosurgery, the senior most person of the or the faculty should attend the case. And he takes a decision with the juniors. But what happens, it is the just opposite in our government setup. We are some sort of inverted pyramid. The junior most first year student, he goes and attends and take a decision. That is the problem with our government system. I think most of the places in the country, not here in Odisha.
It's there everywhere. I agree with you.
But Ganga is a very good. Raja Shahapati tells everywhere that I go and decide about what to be done, and the orthopedic surgeon also, senior most, who is on duty that day, SOC. So I think
that is why you see, if we have to take care of these patients in all the government hospitals, there has to be a bigger team of plastic surgeons. Orthopedic surgeons usually have a bigger team, but plastic surgeons don't have. So only then it becomes possible. If you have only one or two, senior plastic surgeons, it will not be practically possible for them to be there, available around the clock for 365 days. So like we are a small private hospital, but then we are 6-7 people. So it's only once in a week, that you have to be available 24 hours.
The scenario is changing now because we have 20 plastic surgeons in the Department of Plastic Surgery here.
Yeah, then I think it is possible.
Yeah, now it's possible. We are changing this trend. We are trying to do the cases immediately so that the patients don't suffer. If you don't provide immediate cover where the patient deserves it, obviously the patient will come up for multiple surgeries. So we are changing the trend.
Really, I'm sure the trends will change.
Thank you very much for your feedbacks.
Thank you. Thank you.
Sir, namaskar, sir. Sir, in the slides, you repeatedly mentioned a term about radical wound debridement.
Yeah.
Ideally, who should do radical wound debridement? Orthopedic surgeon or
No,
the
plastic surgeon. The debridement has to be done by the plastic surgeons. You see, the thing is, with no offense to our orthopedics colleagues, you see, they are not trained enough to spend a lot of time on debridement. You see, if you tell an orthopedic surgeon that you will take 1 hour or 2 hours to do a debridement, they will, feel that you have gone mad. So, and it has to be done under magnification. So you have to do it under magnification. So this has to be done by the plastic surgeons. So there is no doubt about that.
Okay, thank you. Thank you, sir.
I would like to invite you all to the APRASOCON, which we are having at Amritsar. I understand that you can all see that. I am carrying brochures with me. So I would like all of you to get registered and come to Amritsar. I am sure we are going to provide you a good conference. Thank you. Thank you so much. Thank you.
Yeah, I have the brochures.
Descending genicular artery is the one which is very frequently used, or you can use one of the sural arteries. Sural is medial sural or lateral sural, depending upon the lie of the defect. So for knee defect, descending genicular artery is very good. So you can use that. Perforator from which artery? Sural artery we use very often. Yeah. Sural artery we use very often actually. Earlier we used to do the end-to-side anastomosis to the popliteal artery. But nowadays, either we are using descending genicular or we are using one of the sural arteries.
I wholeheartedly thank all our speakers for covering all the topics with so much of clarity and enlightening us. And I thank our chairpersons also for conducting the session so smoothly. We'll have a short break of about 10 minutes, and I'll request our delegates to collect their registration kit from the registration counter as well. We'll meet after 10 minutes. Thank you. Chair కూడా పక్కన.
Digital lamp lighting.
our Dean and Principal and Guest of Honor, Professor Tateswar Hota, President APRASO, Dr. Ramesh Das, and the organizing committee on the dais, my seniors, colleagues, and juniors. I welcome you all to the 8th APRASOCON, which is happening after a layoff of almost 2 years. The last major event was the APRASOCON 2019, where we were the co-host. So it has been a long time. Our organizing committee took a decision only 2 weeks back to do this conference, and within this very short time, we have put up a lot of hard work to put up this show. The scientific committee consists of 6 prominent plastic surgeons from India, and all the plastic surgeons of the state are participating in this conference with a lot of scientific papers. So the content of this conference is very good. I think all of you will enjoy it. Only one thing I would like to mention you, that when we were inviting our senior plastic surgeons, one of our plastic surgeons was not happy with the way the plastic surgeons in the state are working and the standard of plastic surgery in state. I think it's very good when our own people criticize our specialty, but it is our responsibility to raise the standard of plastic surgery in the state. It cannot be only individual brilliance. It has to be at least average level of care all over the state, so that the plastic surgery is not encroached upon by other specialties. Because we are not organ specific, unlike other super specialties, there are a lot of encroachment. Just to mention a few, hair transplantation, you see so many specialties doing hair transplantation. So the only way to beat this kind of problem is to raise the level of care. And right now, there are 2 MCS institutes, SCB here and MCH at AIIMS Bhubaneswar. I think we have to train our students just like the department just downstairs, the urology department. I am really motivated by the department, because when I came in 2003, the department was just an ordinary department, but within a decade, it has made huge strides and has become one of the best at the national level. They have all the newest gadgets in the department. People for MCS come from outside the state. They have done more than 200 renal transplantations, and they have done also cadaveric transplantations. So that's the motivation we have to derive from our numbering department, and we have to move forward. I think this conference, which we started with a hand transplantation, will just give the impetus to all of us to work to improve the level of plastic surgery in the state. So welcoming you once again. Thank you.
Thank you, sir. Now I'd like to request our President APRASO, Dr. Ramesh Das, sir, to come to the dais and have a few words with us.
Good afternoon to all of you. To our esteemed guests, Dr. Mahajan, Dr. Sinha, Professor and Dean, a good friend of ours, and my teacher, Professor Phalguni Rai, Dr. Sudhanshu Mishra, Professor Neurosurgery, Dr. Das, Professor Surgery. I see many of our good new faces. It is nice to see young boys and girls after 2.5 years almost. As Dr. Naik told, it is in a very short span. It was decided that even in the last moment it should be conducted, and we chose the venue, and our youngsters, they really motivated us to take the decision to host the conference in SCB Medical College. As narrated, Professor Hota has taken this institution to a very good height. Because I know him since long, almost 30 years. And he is going to head the medical industry, will be special officer on duty in the, will be fully functioning as we came from the paper and other sources from December. It is nice to have him with us. And he will be the motivational force, as Dr. Naik told, for the future generation of doctors in the state. You see, we have a lot of potentiality. I see young faces, those who are here. To narrate our my concept, because I worked in almost all the disciplines, surgical disciplines. Started my life with the cardiothoracic. Then I joined neurosurgery for a short stint. Then I went for plastic surgery. Urology I worked for Dr. Hota's knowledge, I should say, 1.5 years in urology department. The two tables were working, and I was working in urology, and the plastic surgeons are. Professor, I should thank my teachers. Where from the beginning, if I narrate, you will find starting from Professor Khadanga, Professor Balachan Agrawal, Professor Nanda, Professor Patnaik, Vijay Patnaik cardiothoracic, Professor Roth neurosurgery. I joined in MCH neurosurgery, then I left. So I don't find any difference between the surgical disciplines. As Dr. Naik told that encouragement, absolutely. If you, there is a story I have narrated in our souvenir. Vivekananda once went to Sankat Machal temple in Banaras. It is near BHU. And once you visit that place, you will see a lot of monkeys are there. Once you go there, they will snatch away or whatever you are having, they will be close to you, they may attack you, all this goes on. So people told how to get rid and how we will be protected from this attack. Swami Vivekananda told, do one thing. You run after them, they will run away. Similarly, as he told, you have to be efficient. You have to be very energetic and know your subject well. Whatever you are doing, you must do well. So that is the message. And I won't tell anything because our team has worked so well. Dr. Giri, Dr. Mishra, and Patnaik, Satyababu, and all the physicians, and Dr. Raut is sitting there. Dr. Mishra joined in this department very recently, and Dr. Naik is doing commendable work. He should take this department, this discipline to new heights, involve as many people as possible, involve as many faculties as possible. You have to learn from them, they will learn from you. It is a symbiosis. So I wish that everybody will enjoy the scientific talk. It was excellently prepared in a very short time. Thank you very much, and making me the president of APRASOCON. I have continued for 2 years, and 1 year went a 0 year. We couldn't organize, and I should thank the younger colleagues. Those who are, I have not asked for anything. They wholeheartedly did everything. I should thank from my core of my heart that they are so excellent and energetic boys, young boys and girls. Thank you very much.
Now I'd like to invite our secretary, Dr. Ashish Patnaik sir, to come and present the report.
Respected our chief guest, Ravi Mahajan sir, our guest of honor and dean of our institution, Hutta sir, our president, Ramesh Das sir, Vishwajit sir, and my friend Dr. Giri. Also, all my teachers, seniors, and my dear friends. So my job is to read out the annual secretary report. So it is my pleasure to extend a warm welcome to all of you to the 8th annual conference of Association of Plastic, Reconstructive and Aesthetic Surgeons of Odisha at SCB Medical College, CUTTACK, which is about 4 years old institution. And it is a 4 years old institution as a medical institution and 150 years old as a medical teaching institution, which started from 1875. The last major conferences in Odisha were APRASOCON in February 2020, that was organized by our late Professor Ananda Patnaik at Chilika, and APSICON in December 2019, where APRASO was the co-host. After 2 years of layoff due to COVID pandemic, we are able to have our physical conference today. Thanks to our esteemed members. Members of our association have occupied various important positions in national level. Dr. Sanjay Giri, elected as a joint secretary, NABI this year. Dr. Saptaswarup Tripathi elevated to the post of professor in PGI Chandigarh. And Dr. Devi Prasad Mahapatra elevated to the post of professor and HOD at JIPMAT Pondicherry. And Professor Vibhuti Bhushan Nayak sir was elevated to head of the department in last year. Due to COVID-19, no annual meeting was possible in 2021. So 2020 and 21 year declared as a 0 year. Esteemed members are strength of our association, and our membership of our association increased from 16 members in 2014 to grown up to 91 till today. The sad demise of member, our beloved Professor Ananda Patnaik sir, APRASO was able to publish a Shraddhanjali book named Immortal Soul, which should be exemplary to the other associations. This year, we had a draft with Odisha Medical Services Association OMSA building for a permanent office cum library at Bhubaneswar. This year, we are publishing an updated directory of all members and disclosing our bylaw of our association in that booklet. And this year, we have started one Ananda Patnaik Memorial Quiz Competition in the memory of our beloved Professor Ananda Patnaik sir. And I request our President APSI to increase the executive committee members, EC members at national level, and to step to elect at least 2 members from the East zone. Actually, we are seeing, sir, in East zone and in the Central zone, our representation are very less. Unless we can defend it at national level, how can we improve our specialties? And is a super specialty. And to prevent the encroachment, we are trying our best. All of you know that Odisha government has declared as hair transplantation will be done by plastic surgeons. So people of Odisha has huge expectations from us. Let us try our best, our members should try our best to fulfill the hopes of the poor people of Odisha. Let's try our best. United we stand. Long live APRASO. Thank you very much.
Thank you, sir. Now I'd like to invite our honorable guest of honor, Dean and Professor Dr. D. Hota, to say a few words to us.
Good afternoon to all.
Dr. Ravi Mahajan, the President of APSI, Dr. Ramesh Das, President of APRASO, Professor Vibhuti Naik, Chairman of the Organizing Committee, the Secretary of the Organizing Committee, Secretary of APRASO, my revered teacher, Professor Phalguni Rai, Dr. VSP Sinha from Jamshedpur. I can see my colleague, my senior colleague, Professor Chaudhary, and my colleague, present colleague from the institution, and esteemed delegates. It is indeed a pleasure and privilege on my part to be standing here to address all of you. Well, at the outset, I must remember my friend, Professor Ananda Patnaik, who left us to the heavenly abode. And I was with him all throughout. He was my classmate in pre-medical as well. So we have to pay obeisance to him on this occasion. And as rightly pointed out, in his memory, now we are having a quiz competition. If something more can be done, that should be thought over. The other aspect, what was told, this is not my domain. I think the president will definitely address. Any society to grow need to have adequate, effective representation. I think on that he can address about it. At a national level, we have tried in our association, and we could make a lot of changes. Well, I get this opportunity to say a few words. When I speak about plastic surgery, as if I feel that I'm showing a torch to the sun. So, but still then I think I need to say, because I have been requested to say, or you can say I have been instructed to say by Professor Vibhuti Naik. Now you see, Varanasi is a place, holy place, Kasi. It is called Varanasi, erstwhile Kasi Mahanagari. It is known for two persons, and it will remain for eternity. One is Susruta, and second is Vasyayana. If you all know Vasyayana, everybody knows about it because it is very common, Kama Sutra. And they have lived in Varanasi in 400 years apart. So when Susruta was born in 1800 BC, and he lived for 100 years, he is the pioneer of surgery. And to credit, India gets the credit around the globe that the surgery was started by the Indians, by the Maharshi. Well, Charaka, he was the first surgeon, he was the first plastic surgeon, and also he had done brain surgery. Neurosurgery at that time was not conceptualized. Now, think about a situation, and I can put a word that he has contributed to urology. What dilators, Buji, what he used was devised by him. So it was from 800 to 700 BC. He pioneered the art and science of surgery when nothing was existing. And we are in the modern medical days now. So imagine the potentiality, the capability, and the expertise he was having. In our MS study, I see, contributed by Professor Phalguni Rai, a art of Susruta doing a rhinoplasty. Now, the day we enter into our specialty, we have to bow down our head to those ancient saints who have contributed enormously in the development of surgical side. We are not talking about Charaka. You know, we had both Susruta and Charaka both. Charaka contributed to the medical side. Susruta was the person, the Maharshi, who contributed enormously. And over the decades, centuries, what has developed, the foundation remained what it was. Now, the instrument that he devised for my specialty, we have only reformed it, modified it, designed it a different way. Then came, you know, gradually as we came into the AD, then the medical science took a turn, and particularly in the 19th and 20th century, the medical science has progressed with leaps and bounds. And it is in the process of development now also. Every day we find something new coming up. Well, the concept of wound healing was revised. We started understanding the modern concept of wound healing. And based on that, all the surgical procedure got a drastic change. So in plastic surgery, the first and the foremost, which we use now also, the control of bleeding or the hemostasis. And we all know that the pressure, which is there age old, and still it stands as good as it was centuries ago. Now, then came, as we know, that Sushruta had made a transfer, rhinoplasty, forehead skin transfer. So this transfer of tissue became very common to bridge the gap or defects. Now, it first was a free graft, then came flap. So that is how the plastic surgery progressed. I am expressing that thing that I have my knowledge. I may be excused if I am not telling something more than what is required. But the fact is that then came, the deficiency came in. The adjacent skin or a transfer, when the deficiency came, then they realized about tissue expander. Now the tissue expander gave a broader area of tissue transfer, and that is how the science progressed. Then came use of microscope. Then said, no, macroscopically we may not achieve many things. I think one of the first specialty or super specialty use microscope is plastic surgery. And being a urologist, I also use microscope in andrology. We do regularly the andrological microsurgical procedure like vasotubular anastomosis, vasoductal anastomosis, varicosilectomy, and so on and so forth. So microscope with magnification. Earlier we had looked for magnification. With a 25 magnification, we could see the smaller and smaller of the blood vessels for anastomosis. With the microscope came the reimplantation surgery. The finer organs, which were not thought of being reimplanted, now it is possible. Now, one area which was simultaneously growing was endoscopic plastic surgery. Unfortunately, it has not got its due diligence. Endoscopic surgery, and I have a friend, we are all batchmate, Bhartendu Swain, who also turned out to be a plastic surgeon, and he has gone into the philanthropy, reconstructive surgery, rehabilitation procedures. Well, this endoscopic surgery simultaneously progressing has not achieved the end the way it should have grown. I do not know. I do not know why endoscopic plastic surgery has not been very popular, even though it has tremendous advantage. Now, once we have gone through this step, then came the tissue engineering. And tissue engineering gave us newer tissue. Then came nanotechnology, transfer of medications, transfer with the nanotechnology techniques. Now, things improved. But what actually really started changing, it is from 2013. The American Association of Plastic Surgeons, 10th October 2013, they took a call, and they have a federation of plastic surgeons. Simultaneously, they took a call jointly, and they said enough is not there till now. We have to have definitely regenerative medicine. And regenerative medicine was just picking up at that time. And this regenerative medicine, what it led to, why the regenerative medicines came into vogue. If you go back, you go back to centuries, we have been observing the lizards, the tail regenerates. There are variety of incidences, variety of examples where if an animal is endangered, he sets an organ of his body and that regenerates. So similarly, we have seen lizards, the tail regenerates, and that gave impetus to think, why not in human being, we can think of having regenerative procedures, regenerative medicine. And that is how it came into vogue. Now, as I mentioned, this is the go of the dates. In 2013, they decided that regenerative medicine is the future of plastic surgery. And on that principle, lot of development has taken place, not only in plastic surgery, in all other medical sciences. In my specialty, we have got a kidney, we do a kidney transplantation. Now, efforts are being made for last decade that how to have a regeneration of kidney, so that the shortage of organ, how to mitigate that. And that is how the regenerative medicine is contributing in every specialty. Now, we have already done research. As I told you, my area of interest is andrology. We have also taken up stem cell therapy as a part of the regenerative medicine for the treatment of ED, which is organic, whether there is damage of nerve or damage of artery. We have been utilizing the stem cells for the regenerative medicines of nerve, for the vessel. So this is also the future for all other specialty besides the plastic surgery. And as I told you, that the future is the regenerative medicine. And these are the areas that we have elaborated, we have been doing. I am happy that plastic surgery department over the decades, led by very legendary figures in this medical college. When I joined my MS surgery, in fact, we are more inclined to be plastic surgeon. Me and Bhartendra Swami, both were coming to the plastic surgery more than we are attending our general surgery classes. So, but unfortunately, my friend took up the specialty, Professor Rai knows about it. And definitely, at this juncture, I would like to say, the young budding plastic surgeon should take up the challenge, should take up the mantle and try to address, not confined to a particular area. They must broaden their thought, they must widen their thinking, and based on that, lot of things can be done here. Lot of things. You have a department which is very well developed. What we require that we should have, which is the goal of the day. In fact, the area where we lack the most is the research. We do not give impetus to research. We have so many agencies which can encourage and support us to go for research. I wish in the near future, the MCH resident of plastic surgery take up research in the area of regenerative medicines. Thank you for all the opportunity given to me and looking forward to a grand success for this APRASOCON. Thank you.
Thank you, sir. Thank you so much for sharing us your knowledge and experience. We are really enlightened with your experiences, sir. And now I'd like to invite our Honorable Chief Guest, President, Association of Plastic Surgeons of India, Dr. Ravi Mahajan, sir, to have a few words with us.
Yeah, good afternoon. So, respected Dean of the local medical college, Dr. Tateshwar Hota, Professor Das, the President of APRASO, Professor Vibhuti Naik, the organizing chairman of the conference, organizing secretary, Dr. Ashish Patnaik, Dr. Sanjay Giri, and Dr. Biswajit Mishra, and the senior plastic surgeons sitting in the dais, our very senior plastic surgeon, Dr. Balyar Singh, Dr. Chaudhary, Dr. Falguni Roy. So I give my respects to all of them. And in fact, it's as I was telling in the morning also, it's a great pleasure for me to come back here after having been elected here only as the APSI president. And probably this is the first meeting I am attending as the president, and this honor was given to me by all of you here only. So as far as my association with the Odisha plastic surgeons is concerned, I think I have been seeing Professor Roy actually in most of the conferences, I think almost 30 years from now, and Professor Balyar Singh also, and Professor Chaudhary also, and have a very close association with Dr. Vibhuti Naik actually. In fact, I went for my traveling fellowship of Ethicon somewhere in '96 at Mumbai, and he was doing his MCH at that time, and I stayed with him in his hostel actually when I was a fellow there. So I know him since then, and I have seen the way he has progressed actually. the way he has, brought the plastic surgery at the national map, and particularly, microvascular surgery. I think in this part of the country, he has been a pioneer as far as microvascular surgery is concerned, because that has been, my area of interest also. And I think he has done a lot as far as the development of microsurgery is concerned. And I'm so happy to see over the years that how, the plastic surgeons from Odisha have been doing very well, and they have been coming, at the national level. And Dr. Chaudhary was elected as the executive member. Then Dr. Vibhuti Naik is our present, executive member of the APSI. Then Dr. Sanjay Giri, he's in the executive of the ISSH, and just now I was told that he has been elected as the joint secretary of the NABI also. So I don't think from the east, I think people are very active at the national level. So, so Ashish, I don't think that it's less represented. And in the recent years, I think what I have seen is, earlier, I didn't see any of the national level conferences happening in this part of the country. But in the last few years, we had the National Academy of Burns annual conference here. We had a national conference of Indian Society of Surgery of Hand, where again, I was the president of ISSH, and I, was here in Puri in 2019. And then we have the APRASOCON as well. So I think Odisha is really doing very well on the plastic surgery front, as it is seen at in other areas also. So whether it is sports or whether, other things, I think Odisha is really doing very well at the national level. Hockey, hockey sports, when I said it's primarily hockey, and your chief minister has really contributed, I must say, to the development of hockey at the national level. And that was probably, you see, there were a lot of people from Punjab who were there in the hockey team, in addition to from Odisha. And our hospital, my friend who's an orthopedic surgeon, he's a great sports enthusiast, and we called the team to honor them in our hospital, and they were praising your chief minister, that it is because of him, that we have been, because they did very well in the Olympics and they could reach that. So I think there's a lot being done from your state. And as far as I think we were talking about the specialty, that there is an encroachment which is taking place, and the young plastic surgeons have been quite concerned about this thing. And I think Dr. Vibhuti Naik has talked about it. And I think one of the main things which we can do is that we have to prove ourselves to be the best. As you see, if because we have a lot of areas where there is a overlapping. So until unless, so we can't say that rhinoplasties will be done by the ENT surgeons also. But if we, as individual plastic surgeons, we prove that we can do better than them, and if we train our trainees, very well in those areas, I'm sure the people would like to come to us. So I think instead of blaming others, we have to train ourselves much better. Same is true about hair transplantation. Today we saw Dr. Sinha's results. He's doing wonderfully well. Why would anybody go to anybody else than going to Dr. Sinha? So we have to, train our residents, our junior plastic surgeons much better than, the people who are kind of encroaching into our specialties. I'm sure a dental surgeon will not do better hair transplantation than a plastic surgeon, but then we have to train our people. And as far as the association is concerned, for association, I think the two things are very important as far as the APSI is concerned. One is to create awareness amongst the public about the specialty. And one of the very good things which was done by the association, by one of our past presidents, was that when Dr. Raja Sabapati became the president, he came up with the idea of having a National Plastic Surgery Day on July 15. I think that has really given us a big tool to create awareness amongst the public. So on that particular day, I think all of us, have been for the last now 12 years doing free surgeries, particularly in private sector for our underprivileged section of the society, as well as creating awareness about our specialty in the public. As Dr. Vibhuti said, that our specialty is not organ specific. For that reason, people are confused, what we are. Because at one point of time you are doing hair transplantation, other point of time you are dealing with the bones of the face, you are doing maxillofacial surgery, then you are doing hypospadias, you are doing breast, you are doing trauma. So it's so confusing for anybody to see what plastic surgeons are. When somebody says cardiologist, neurologist, or a neurosurgeon, or a urologist, the name itself indicates what they're dealing with. But in plastic surgery, people don't know what are we dealing with. So the onus lies on us to create awareness about our specialty. And I think this Plastic Surgery Day has been very, very useful to us to create awareness. And all of us, do a lot of awareness programs during that time. This year, what we are doing is that we are celebrating this National Plastic Surgery Day at national level in Delhi. So because I feel if you do it in our national capital, so it catches a lot of importance from the media, and then it comes into the national media. So some of you must have got the message. We are going to do a APSI Sushruta Film Festival there. So idea of doing that is that I will request all of you actually to come up with some films, which tell that how the plastic surgery in different areas can create a difference in the life of the people. For example, a burn patient who has been treated by the plastic surgery specialty. So how, we have been able to change their appearance, from what it was earlier to now. Similarly, a cancer patient who, a large part of the jaw has been removed and now you have restored it to near normal. So how that change, we can have films depicting those changes, which can be, displayed to the public so that they really know that what plastic surgeons, what is the spectrum of work the plastic surgeons are doing. Because many times, particularly at the government level, when you say plastic surgery, so they feel, as if it is only about cosmetic surgery, and they withdraw themselves. So whereas I think the cosmetic surgery work being done by the plastic surgeons is just a very small portion of the work which we are doing. I don't say that the aesthetic surgery is not important, but we have to tell the people that there is a lot then other a lot of other things also than aesthetic surgery. So we are dealing with burns, we are dealing with cancer reconstruction, we are dealing with trauma. So as you saw that we in the morning, that how important it is that a plastic surgeon is involved in the trauma management, whether it is maxillofacial trauma or whether it is a limb trauma. If you ask me, I feel that a limb trauma, particularly compound limb trauma, cannot be treated by without the presence of a plastic surgeon. So until unless a plastic surgeon is involved in the management of the compound limb trauma, I'm sure some of you who have seen my presentation in the morning. So if there is no involvement of the plastic surgeon, it will lead only to amputation in those kind of situations where there is a complex limb trauma. So that message has to go not only to the public, but to the bureaucrats also, and to our colleagues also. So the onus lies on us to create that awareness. And I think all of us should take up that challenge and create awareness, not only amongst the public, amongst the, people in the administration, as well as the our other doctor colleagues. Because I tell you, I'll tell you a story that when I had just finished my plastic surgery and I was working at Rohtak Medical College, I was heading the department there, and then I planned to shift to Amritsar because that's my native place. And my own professor of surgery, who has been in Amritsar, when I told him that I am coming back to Amritsar, the question he asked me is कि plastic surgeon क्या करते हैं, grafting करते हैं, cleft lip करते हैं, तो वो पहले ही लोग यहाँ पे कर रहे हैं, आप क्या कर लोगे? So I was so much, disturbed to listen to him, because that was the time when I was doing all microsurgery work. I was doing a lot of craniofacial work, and I was doing all the aesthetic work. So So it's not just the public, I tell you, even our own colleagues in other specialties are not aware, but then it is not their fault, it is our fault, because we have not been able to take our work to them and show that what all we can do. So let's not lament that that they do not know about it. If they do not know about it, the fault lies with us, because we have not been able to create that awareness. So from that point onwards, I made it a point, because after that I was still in Haryana for a lot of while. I went to all the districts and had meetings with the IMA and then showed the spectrum of work which we are doing. So I think that is what we have to do. You know, we have to create awareness amongst our colleagues. So to the younger plastic surgeons, I would like to say that whenever you go to get yourself established in a particular area, so you must, you know, do meetings with your, you know, other colleagues, so that you tell them what is the spectrum of plastic surgery. When I was doing my own MS, I didn't know that maxillofacial trauma can be done by a plastic surgeon. I always thought that it is done by the dental surgeons. So don't think that automatically they will know it. So it is for you to go and tell them that what is your spectrum of work and what all you are capable of doing. So onus lies on us. So I would request our young plastic surgery colleagues that don't just you know, blame others. The onus lies on us to create the awareness about our specialty. That is the foremost thing, and then to train yourself much better than, you know, the other people who are competing with you from other specialties. So on that front, I'm sure the APSI, you know, is going to do a lot. We are doing a number of CMEs, and we are you know, coming up with a lot of online programs. Also, we have tied up with Omnicurus, and with through which is a you know, platform over which we'll be doing the public awareness programs, as well as doing a lot of CMEs also. So two things are important. One is creating awareness, and one is raising your own level. So these two things are important. If you think that you can legally fight, though we do it at sometimes, but I don't think that is going to give you any results. We know all that, how the, you know, the bureaucracy and how the our courts work. So with these things, I would you know, again like to thank the APRASOCON organizing committee for having called me here and given me the honor of you know, being the chief guest here. And I'm really impressed with the knowledge, you know, your dean has, and I think you are really lucky to have somebody like him. And as Dr. Vibhuti said, that he's a kind of a ideal for them, you know, because the department is doing so well, and I'm sure that the department here is also going to reach further heights, and it has already achieved a lot under the leadership of so many others who have headed the department earlier, and I'm quite hopeful that Dr. Vibhuti is going to take it to further heights. Thank you so much.
I thank you, sir. Thank you so much for your valuable and golden words. We'll keep your words, sir. Now we'll have inauguration of our souvenir, and I'll request our honorable guest of honor, Dean and Professor Dr. D. Hota, and our honorable chief guest, President, Association of Plastic Surgeons of India, Dr. Ravi Mahajan, sir, to do the honor. Now we'll have, I'd like to request our organizing, our Secretary APRASO, Dr. Ashish Patnaik, sir, to felicitate our beloved late Professor Dr. A.P. Patnaik, sir.
Association of Plastic, Reconstructive and Aesthetic Surgeons of Odisha, 26th March 2022, SCB Medical College, Cuttack. Felicitation to late Professor Dr. Ananda Prasad Patnaik, Executive Committee and members of Association of Plastic, Reconstructive and Aesthetic Surgeons of Odisha consider it to be a pride to felicitate you for your pioneering work in the field of burns, plastic and reconstructive surgery and your outstanding contribution towards the poor and needy people. Professor Dr. Ananda Prasad Patnaik sir was born from Hrudayamani Patnaik and Prananath Patnaik on 1st January 1959 in the village of Sundarpada near Bhubaneswar. You married to Mr. Nivedita Patnaik and blessed with two sons, Abhishek and Animesh, and both are doctors. You passed MBBS from MKCG Medical College, Barampur in 1983, completed MS in General Surgery from SCB Medical College, Cuttack in 1991, and completed MCH in Plastic Surgery from Banaras Hindu University in 1996. You were awarded with DNB in Plastic Surgery by National Board, New Delhi in 1997. Initially, you worked in Odisha Medical and Health Service cadre at Bindhanima PSC in the district of Cuttack, where you had done many memorable works and you had done one gallbladder surgery under local anesthesia, which is remembered by local people till today. You joined as a lecturer in plastic surgery at MKCG Medical College, Barampur on 10th January 1997 and worked till 31st January 2001, and as assistant professor from 1st February 2001 till 31st October 2005. You returned back and joined as associate professor in the Department of Plastic Surgery, SCB Medical College, Cuttack on 1st November 2005 and worked till 12th January 2010. You were elevated to the post of professor on 13th January 2010 and worked till his last breath. You were former superintendent and professor and head of the department, Plastic Reconstructive Surgery Department of SCB Medical College, Cuttack. You came to this department and contributed academically to the plastic surgery research work at SCB Medical College, Cuttack, which is at rare occasion at that point of time. You were not only a sober and noble-hearted person, but also a complete institution. You were a innovative mind and dynamic brain. Your contributions towards burn treatment, carpal tunnel release, hypertrophic scar and keloid management, and innovative way of wound management were most memorable. You were the immediate past president of Association of Plastic, Reconstructive and Aesthetic Surgeons of Odisha and conducted annual conference in a grand way at Barkul, Chilika. Your contribution towards the renovative burn center, bringing new microscope and starting endoscopic plastic surgery in this department, which will be remembered till time to come. Your innovative technique of giving anesthetic block and surgical technique were commendable. You left us for heavenly abode on 11th September 2021. Sir, the executive committee and members of APRASO consider it a great opportunity to felicitate you on this auspicious occasion of 8th annual conference of APRASO 2021 today at SCB Medical College, Cuttack. We remember your versatile personality in your absence. May your soul rest in peace. Now I request our President Ramesh Das sir to felicitate uh, to his son. And I request our beloved Dean Sir, Hota Sir, and our Chief Guest Sir, and Vibhu Sir to accompany. Please, sir.
I'd like to request our President APRASO, Dr. Ramesh Das, sir, to felicitate our on guest of honor, Dr. Hota sir. I'd request our President APRASO, Dr. Ramesh Das, sir, to felicitate our chief guest, Dr. Ravi Mahajan, sir. I'd request our President APRASO, Dr. Ramesh Das, sir, to felicitate our organizing chairman, Dr. Bibhuti Bhushan Naik, sir. Now I'd request our organizing chairman, Dr. B.B. Naik, sir, to felicitate our guest, Dr. VSP Sinha, sir. I'd like to request our organizing chairman, Dr. B.B. Naik, sir, to felicitate our President APRASO, Dr. Ramesh Das, sir. Now I'd like to request our organizing chairman, Dr. B.B. Naik, sir, to felicitate our organizing secretary, Dr. Sanjay Giri, sir. I'd like to request our organizing chairman, Dr. B.B. Naik, sir, to felicitate our organizing secretary, Dr. Bishwajit Mishra, sir. I'd like to request our organizing chairman, Dr. B.B. Naik, sir, to felicitate our secretary, APRASO, Dr. Ashish Patnaik, sir. Now I'd like to request our organizing chairman, Dr. B.B. Naik, sir, to felicitate our treasurer, Dr. Satyavrata Raudre, sir. Now I'd like to invite our organizing secretary, Dr. Vishwajit Mishra sir, to do the honor of having vote of thanks.
Everybody is hungry, not taking much time. First of all, I would like to thank Dr. Ravi Kumar Mahajan, President APSI, for taking so much of pain and attending our conference and enlightened us about the plastic surgery scenario at the present. I thank Professor Dr. Datteswar Hota, Dean, SC Medical College, accepting as a guest of honor for this occasion. I also thank Dr. VSP Sinha. Dr. Anand Sinha is not here, he is going to attend us also as guest speaker for this occasion, as well as Dr. Mukund Thatte, Dr. Nilesh Satbhai, Dr. Ashish Bunkar, and Dr. Rajendra Gujranwal for accepting as a guest faculty in the virtual meeting. I thank Ramesh Das sir for actually taking initiative to hold this conference, and he has actually put us some enthusiasm on us, and we have actually gone through all these things in a short time and could hold this conference. I thank Professor Bhubhati Bhushan Naik actually leading from the front to hold this conference in SC Medical College, and I am sure it will be a huge success academically and all other aspects. I thank Ashish, Giri and Satya taking so much of pain actually organizing this conference. I thank Sachi, the audiovisual person, actually who is actually looking after all these things for this conference. I am thanking Tripathi Xerox, all the pharmaceutical company, actually with a very short span of time, maybe around 10-12 days time, they all agreed. Actually, without pharmaceutical company, any conference doing with only registration fee is not possible, but they have wholeheartedly supported us. I thank from core of my heart that they have supported us, and we could able to organize such a conference. And I also request all of you to give a visit to their stall. And last but not the least, I thank all the members of the APRASO, senior members guiding us for conducting this conference, attending this conference, the younger generation, and making it a success. So, thank you all. Long live APRASO. Request all of you to gather at that is second floor of the Bond building for lunch.
Please come, please come. Please, please. Thank you for your cooperation. Taking photograph nowadays is difficult. Very difficult, I tell you.
Hello? Hello? Hello?
Hello.
Hello, yes.
Yes, sir. It's launch time. Program will start at 2:30.
I'm sorry.
Sir, it's launch time. Conference will start after launch 2:30 p.m.
Oh, I was told 2:30.
Yes, sir.
So now there is time still. So it is not starting now.
It's inform.
No, should I stay or log out? What should I do?
So
the conference is not starting right now.
Sir, starting after 5 minutes.
After 10 minutes.
Yes, sir.
Okay. I will be around.
Okay, sir.
Amit, call about what? जी बताइए. I am in a webinar in Odisha, but at the moment it has not started. So keep talking. हाँ. या नहीं, क्योंकि वो उन्होंने क्लियर नहीं किया था अब तक, तो वेबसाइट में बाद में भी कर सकते हैं ना. अभी फिलहाल नहीं लिखी. नहीं तो लिख दो यार. दे आर 10-15 आर कमिंग, सो यू कैन राइट गेस्ट सोसाइटी बीएसएस. लिख दो. हाँ हाँ, नहीं कंफर्म है. बीबी जोशी, सुमित तलवलकर और आर वेंकट स्वामी, टोमास उल्टले. रखेंगे आप. इट डिपेंड्स ऑन यू गाइस. आप लोगों ने कुछ तैयारी की है तो मैं जरूर ये करूँगा. आप लोगों को पूछो. या ओके ओके. या ओके ओके. थैंक यू. तो आप बताइए कल मिलना है तो बोलिए मुझे. ओके. जी 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 जी. एक बार ब्रोश्योर का भी देख लेते हैं, मतलब फाइनल रेट्स क्या किए. वो 5 मिनट लगेगा उसको. ओ हाँ, लिंक भेजिए कल के लिए. जी ओके ओके. या ओके. या बाय. There is nobody, man. I'm there, but there is nobody there. I am very much there. I can see Professor Arun Kumar Chaudhary. Hello? Vibhuti, I have logged in. But okay. 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 Thank you. Thank you.
Hello. Sir, are you online, sir? Can you hear me? Can you hear me, sir?
Professor Chaudhary, I am here.
Thank you so much, sir. Can we start our meeting, sir? Your presentation?
Up to you. I am ready.
Okay. Thank you so much. Hey, के पकेगा बायोडाटा पक्का के पकेगा हम पढ़ दी मोबाइल का अच्छी Sir, we are going to start the presentation with your curriculum vitae, sir.
Okay.
Okay. Now we are going to have a presentation from the doyen of brachial plexus injury in the country. I hope there is no second to none and doing lot of neonatal brachial plexus injuries in India. He is no other than Dr. Mukund Ramchandra Thate. He is MS General Surgery, MCH Plastic Surgery from the University of Bombay. Presently, he is consultant and academic head, plastic surgery at Bombay Hospital and Medical Research Center, New Marine Lines, Mumbai. He is the head of Bhai Jerabai Wadia Hospital for Children and Susruta Citizens Cooperative Hospital and head plastic surgery, SRCCNH Children's Hospital. The position he has held, you are the past president of Association of Plastic Surgeons of India in 2010, past president Brachial Plexus Surgery Group of India 2009 to 11, past president of Indian Society of Cleft Lip, Palate and Craniofacial Anomalies in 2005, former editor Indian Journal of Plastic Surgery 2003 to 2008, and past executive council member Indian Society Surgery of the Hand. Current position is member board of trustees and executive trustee Association of Plastic Surgeons of India, president Indian Society for Surgery of the Hand 2022, and president Indian Society for Peripheral Nerve Surgery 2020 to 2022, member Sutherland Society, editorial board. So with this short curriculum vitae, if I go on talking about his details, it will take hours together. But with this, I think we start with the presentation of, and it is Dr. Mukund Ramchandra Thate. Sir, you are on the floor to start your presentation.
Professor Chaudhary, I thank you for your very kind words and your introduction. I will now share my screen.
Sir.
Can everybody see my screen?
Yeah. Make it full screen, sir.
Can you see it now?
Yeah.
Okay.
Chair, make it more visible.
Is it nicely visible? Can I see?
Yeah, it is completely nicely visible, sir.
Okay, so
we have a very beautiful auditorium like in the department. It is dedicated to our department only.
Very nice.
So Vibhuti has nicely managed and also maintained it. Huh? So we have a very good gathering of more than about 70 people are there. And we will be joining with our president, Mahajan, Dr. Mahajan and Dr. Sinha from Jamshedpur also.
Thank you.
Okay. They are on the way, I think.
Yeah, so.
Sir, you can start your presentation now, sir. Thank you very much.
Thank you very much. I thank the Association of Plastic Reconstructive and Aesthetic Surgeons of Odisha for giving me this opportunity. I'm talking on birth brachial plexus palsy today, and I have divided my talk in conjunction with Professor Vibhuti Nayak into two parts. One part is the clinical assessment, how to examine these children, and the second part is how to treat them. So I'm starting with the first part. how to examine these children, because I think that is more difficult than actually operating them. So the diagnosis of birth brachial palsy is not difficult. There is a typical history of difficult delivery, although not always. In fact, in our series, we find 40 to 50% of people do not give history of shoulder dystocia or obstructed labor. But the palsy is always noticed on day one. The palsy is typically lower motor neuron type, and the only confounder is cerebral palsy, but that always has spasticity and looks and feels very different. So it's not difficult to diagnose a birth brachial palsy. What are the special points in birth brachial palsy as against adult brachial palsy? I think it's a very different situation. The examination is difficult. The findings keep changing, and therefore keeping a note of serial findings is very important. The timeline is extremely important. And the best decision time is between 3 and 6 months of birth, not 3 and 6 months of you seeing the patient, but 3 and 6 months of birth. In global palsy, the earlier we operate, the better. I want to pay homage to this great man, Aligemantas Narakas from Switzerland, who did so much in the field of brachial plexus injury. And he gave us what is called the Narakas classification in the birth palsy realm, in which he called group 1 as the C5, C6 injury, where shoulder abduction, external rotation, and elbow flexion is affected. Group 2, where C5, C6, and C7 is involved, and therefore we have to add triceps and wrist extension to the list of things that is absent. Group 3 and 4 are both global, but in group 3 there is no Horner's, and in group 4 there is a Horner's phenomenon. I am giving you a list of simple rules for determining motor function. So C5 is for the deltoid, C6 is for the biceps, C7 is for the triceps and wrist extension, C8 is for hand and extrinsic muscles, and T1 is for hand intrinsic muscles. There are exceptions, of course. An intrinsic like ADM can be often a C8 muscle. And wrist extension and triceps can also both have a C8 component, not only C7. In addition, T1 can also power other muscles. Again, the sensory examination is very simple. You start from the shoulder and go anti-clockwise. So the skin over the deltoid going down the upper arm on the lateral aspect is C5. C6 is the medial aspect of the lateral aspect of the forearm, thumb and index finger. C7 is middle finger, C8 is little finger, and T1 is medial forearm. Medial arm is T2 and is usually intact in brachial palsy. What are the tips to examination? The videos I am now going to show you will show you the tips to examination. It always helps to cover the eyes of the infant to induce movement. Otherwise, motor and sensory tips remain the same as in adults. Sensory is a lot more difficult to examine. My recent student has written his thesis on the sensory examination of children. Once that thesis is passed by the national board, we will publish it. Timeline indicates prognosis. Earlier the recovery, the better. This is the same child being seen on day 12, day 16, and day 32. If you see day 12, you can only see hand and finger movement, but you can see nothing in the shoulder and elbow. If you then see day 16, you can see this child is already flexing the elbow. And then if you see day 32, you see a lot of movement happening. Not only is the elbow flexing, but the shoulder is abducting and externally rotating in abduction, as you will see now. There, it goes into abduction, external rotation. So from day 0 to day 32, this child showed recovery of almost all the movements. This is prognostically an excellent factor. Now, in fact, this child is grown up and is doing very well, has needed no surgery. Abduction is checked again by trying to give something in the child's hand, but in the abduction axis, not the antepulsion axis, and covering the eyes, like you can see here. And the child is in fact trying to take the hand up to that towel. For hand movements, best is to give something in the child's hand and watch what the child is doing. Here you can see the FDP and FPL are both functioning. For triceps, again, you flex the elbow yourself and then you wait for the child to extend. And stimulating the sensation on the volar side makes the child take away the arm, and you can see full anti-gravity triceps over here. This is showing wrist extension. Again, I am flexing the wrist and then I am stimulating it on the palmar side, and the child takes it up now. I want everybody to see this video very carefully because this shows false elbow flexion, where the child shows antepulsion first and then the elbow falls down. And parents whom you have briefed about elbow flexion being important will often say that my child is now flexing the elbow, which is false. See this video carefully. This is antepulsion and then the elbow fell down. I'm going to show you again. The child took the shoulder forward and then the elbow fell down. Sorry. See, this was not active elbow flexion. So you have to beware against this. On the other hand, this child, not yet fully recovered, is holding the elbow in flexion on its own, although not taking to mouth completely. This is prognostically an interesting factor and will progress to full elbow flexion, as the next one will show you. This is the same child, but farther on the timeline. Now I'm holding the arm down, palpating the biceps. And now this child has done anti-gravity flexion all by itself. So this is prognostically showing that this child is now okay for C5, C6. Why is elbow so important? Because the only muscle which is exclusively C5, C6 is the biceps flexing the elbow. The shoulder moves in 360 degrees and has many, many muscles. Some of them are 5, 6, some are 6, 7, some are 7, 8. Some like the trapezius are by the accessory nerve. And therefore, the shoulder movement is not a reliable guide to the health of C5, C6. While elbow flexion is a very reliable guide to the health of C5, C6. Now I'm showing you how to examine finger and elbow flexion. Again, I'm restricting the elbow and child is showing me finger. I leave the elbow, child is showing me the elbow flexion. But in upper plexus palsy, therefore, you look for true spontaneous recovery like this child is showing. Both the elbows did anti-gravity flexion independently and came to the mouth. While in a global palsy, you get Horner's syndrome like this and Naraka's grade 4, no movement. But I want you all to see this video for false hand movement caused by the examiner's hand, accidentally squeezing the resilis. If I exert very slight pressure, the fingers flex. If I am not careful while I am examining, I might interpret it as hand movement if my thumb presses down at this point. And therefore, it is very important that the thumb stays away from the hand. You only hold the hand in the palm of your hand and don't press it. Other investigations are chest X-ray, angio in case of subclavian thrombosis. This is more for adults, not for children. Chest X-ray is important in children also for diaphragm. Then, of course, MR neurography if possible. If your anesthesia and radiology department is not happy about doing a 3-month child, don't do it. It is not a deal breaker. I always do electrodiagnostic tests because they give me a lot of information. So an example of a raised diaphragm and an example of a blocked subclavian. This is what we do in the MRI. So the 2.5 millimeter thick slices in 0.25 mm interslice distance. And they do all this DWI, BS and STIR and T1 and T2. But idea is we want to see root avulsions, pseudomeningocele or a postganglionic injury. So the root avulsion will show a pseudomeningocele with extravasation of CSF with the tear in the dura. Nerve ruptures are seen as discontinuity in the nerve structures. And neuropraxic injury is seen as a T2 hyperintense signal, but no rupture or avulsion is noted. Some examples, these are avulsions. So these are 3 pseudomeningoceles. The same thing which is now being done by DWIBS. So you can see the plexus itself in much greater detail. And you can see 2 root avulsion, and see these 3 are avulsed and 2 roots are ruptured up on top. And this is the clinical correlation. C5 and C6 are ruptured. 7, 8, T1 are avulsed. So they are with ganglia and they are ruptured at the postganglionic level. Then for electrophysiology, we document all the nerve conduction velocities, amplitudes, latencies, everything. All representative muscles undergo needle EMG. Patients go SSEP additionally if required. And then we record the data for every spinal level from C5 to T1 and give a diagnosis of pre or post-ganglionic. This is one sample report from our department. If you see, the sensory action potentials are all low amplitude, while the patient has a global palsy, which means it is not rupture but avulsion. And if you see the motor, they are all no response. So this combination is a global pre greater than post ganglionic injury. And we can get this for everything. Note here, we in the motor NCV studies, we always get the CMAP of FCU and FCR, because those are the fascicles we are going to take for Oberla. So APB ADM is not good enough. The take-home message from this examination presentation is have a detailed history, clinical examination, chest X-ray, other X-rays if fractures are suspected, MRI and electrophysiology, and finally do your therapeutic plan. So I will close this and now start the treatment. Oh, somebody has stopped screen sharing. Can I get the screen sharing back, please? Mr. Chairman, can I get the screen sharing back, please?
This is going on Zoom, huh? This is going on Zoom. So that's why we have 2 remote controls. Here one person is there, other fellow is there in the...
So can I try again?
Yeah, you can try again, sir.
Okay. I think we are seeing it now. Can you see it now?
Yeah.
Okay.
Make it full, yeah. Okay.
Now it is full screen. Yeah, so this part of the presentation is about treatment of birth brachial plexus palsy. The incidence is about 1 in 1,000 live births. And I always say this point, it is as common as oral clefts, but it does not get even 5% of the effort compared to oral clefts, which is tragic. And this is mainly caused by wrong teaching about spontaneous recovery, both in the Department of Pediatrics as well as pediatric neurology. People don't get referred in time. The etiology classically is thought to be of a large baby getting stuck during parturition, and this is called shoulder dystocia, where the head comes out and the shoulder is behind the pubis of the mother, and then results in a vacuum or a forceps assisted delivery, which causes a stretch on the brachial plexus. However, 50% of our cases do not give this history, and therefore be very careful about what you say to the relations, because it is medico-legally huge. I personally always say to the relations that when there is shoulder dystocia, it is an absolute emergency on the life of the child and mother, and the obstetrician has no choice but to pull at that point in time. And additionally, there is no way to pre-operatively diagnose who is going to get shoulder dystocia. And therefore, to pre-operatively do a LSCS is simply not possible. So stop blaming the obstetrician. This is an unfortunate thing that happens, and it is nobody's fault. As I said, the diagnosis is an element type of palsy. I want to come to the point of delay. People play around with these things. Pediatricians, pediatric neurologists, physical therapists, people say, we will do exercise, we will do this, we will do that. Why is delay bad? Because the nerve muscle junction survived denervation for 18 to 24 months. And nerves regrow only at 30 millimeter per month. The longer you wait, the less time the nerve has to reach the target muscle. And it is completely avoidable if the child is referred to an appropriate person at the right time. This is a sentence written in Green's textbook. The treatment of denervation is reinnervation. Full stop. There is no other treatment. Nothing else works. So how do we make the decision? So this is our protocol. The ideal time to see the child is around 3 weeks. We prescribe manual mobilization of upper limb by the mother, which includes circumduction, external rotation, hand to mouth, and pronosupination. We tell the mother to do these exercises 10 repetitions for every exercise with every breastfeed. At 4 weeks, we ask for a baseline electrophysiology. It has been shown in a paper by Willem Pondak that those children who are showing even one triphasic in the biceps at 4 weeks are likely to go ahead and recover, especially in upper plexus. In a global policy, of course, there is no question of these discussions. So the decision to conserve or operate is taken between 3 and 6 months. It depends on the grade, severity, and the serial findings from 3 weeks to 3 months, like I showed you in the examination video. Anatomically, pre and post ganglionic is what we need to understand. Pre-ganglionic means no donor root, which means there is nothing to repair if all 5 are pre-ganglionic. While post-ganglionic, which is fortunately more common in children, donor roots are available. So there are 4 things to decide: diagnosis, treatment options, whether to conserve or operate, and if operate, then timing of surgery. As I said, diagnosis is usually not a problem. You only need to rule out cerebral palsy. This is where the Hamlet question starts: to operate or not to operate. That is the question. So I revisit the Narakas groups. 1 and 2 are the partial ones. 3 and 4 are global. So 3 and 4, there is not much argument. So this is an example of group 3. Nothing is moving. And this is an example of group 4. I've covered the face for privacy reasons, but it has Horner's sign. I showed you this child earlier. So here there is no argument. You have to operate these children. They are totally paralyzed. There is a lot of argument in group 1, C5 and C6. And people say they will all recover if you wait long enough, etc., etc., etc. So whether there is spontaneous recovery or not, see this child. Now in this child, the real anatomical purist will say that the child pronated while lifting the elbow. See again. And there is this question of brachioradialis substituting for the biceps. So this is the gold standard: supinated forearm and elbow flexed. That means it is not brachioradialis but biceps. This is a type where you can see a tight biceps, you can see shoulder motion, and you can see no hand motion. So this is a Klumpke type. That means upper plexus is showing recovery, lower is showing nothing. So when will you decide that spontaneous recovery has not happened? In other words, how long will you wait is the question. The $1,000,000 question has been addressed by various people. Alain Gilbert and Tassin in 1983 wrote a thesis where they put the cutoff at 3 months anti-gravity biceps. There are others who are willing to wait up to 9 months. So I did a literature survey with the help of a thesis of my friend Willem Pondak from Netherlands. And these are all the papers with sufficient follow-up and sufficient criteria for choosing, which he has listed in a table. So Gilbert and Tassin in 1984 said biceps recovery after 2-3 months, the end stage recovery was incomplete. Same thing was said by Boom and Kay in 1988. If the upper root muscle is delayed beyond 3 months, then root disruption is likely and exploration and nerve grafting is a better option. Clark's group has done seminal work from 1994 onwards, as I have listed over here. And their conclusions are written here. I won't read all of them. But basically what they say, if AMS, that means active motion score, which is their score of gauging movement, does not improve by 6 months, operate. They also say neurolysis does not help and is more or less the same as conservative therapy. If you operate, you better join some nerves. Waters et al. Said the same thing. When recovery starts at 4 to 5 months, functional impairment at the end stage remains. So basically, everybody is saying the same thing. So Pondak concluded, in our experience and that of others, it is seldom that conservatively treated children, now we are talking of group 1, do not recover elbow flexion spontaneously. But in these children, major deficits will remain in shoulder function if they have a delayed elbow flexion recovery. And therefore, at some point, you have to say, no, this child is better off with nerve reconstruction. So after this literature survey, can we formulate a policy? Let us see the obvious. This is a global plexus child. There is no movement. There is no argument. This is a spontaneous recovery child. There is full movement. There is no argument. Now see this. This is not obvious. There is a visible biceps, but when you are palpating, there is a strong triceps co-contraction. In fact, in our department, we nowadays properly document the co-contraction, and we are using root mean square of the amplitude to quantify it. So the strategy we are following is do a good electrophysiology, document a good compound motor action potential on biceps, document a strong co-contraction on the triceps, and then give a triceps botulinum toxin trial. And this is a result possible after giving botulinum toxin to the triceps. This child is now successfully taking hand to mouth. So the current strategy is electrophysiology at 1 month, review at 3 months. If the biceps is poor on examination visually and on palpation, we recommend surgery. If it is equivocal, we wait for a month. And by 4 to 6 months, we take final decision whether child needs Botox or surgery. Global plexus, always early surgery. Complete repair in postganglionic. Be prepared for contralateral C7 if there is no viable route. I'm showing you an example of a postganglionic injury. This is a very unique picture where you can see the C7 ganglion. That is the motor root and that is the dorsal root ganglion. We don't always get such a nice picture. This is the same in close-up, dorsal root ganglion and the motor root. Then what we have done is we have taken nerve grafts and connected the proximal to the distal, covered everything by tissue glue. So we take cable grafts, we label them like this. This is for C8, this is for C7, this is for 5, 6, etc. And then we take them inside and use a couple of sutures and tissue glue, like so. An example of a child with a global plexus showing abduction, elbow flexion, external rotation, hand behind head, basically more or less all functions. Another child with global plexus showing the elbow, shoulder and hand function. At the 6-year follow-up, the affected hand is the left hand. So you can see it is very, very good results are possible. Now we come to the shoulder. Sometimes despite good nerve recovery, co-contraction is a problem with no solution. And perhaps good distal transfer is the only solution to it, like this child is showing. Hand to mouth with a Oberla transfer. So for shoulder also, an 11 to SSN transfer done separately perhaps has a solution for the co-contraction. We still don't know. This is a classic example. See the attitude of internal rotation. And the shoulder is not abducting or externally rotating. Another child. Sorry. See, this is the typical attitude. They are in half abducted position and internally rotated. When you do their MRI, this is the picture you get. This side, the glenoid is completely twisted and the humerus is behind the central line of the scapula. While the normal side, the central line of the scapula is this. The glenoid is not twisted. The angle is very small, 5 degrees here, 36 degrees here, and the humerus is 50-50. So this side shows what happens because of that continuous internal rotation stress. Decision making is based on trial of Botox in early cases if the glenoid retroversion is not bad and the joint is congruent. It either succeeds or we go to shoulder muscle transfer, with or without shoulder release. And it works. Now see this child. completely dislocated humerus. That was the glenoid. This is the central line. This is 50-50, while this is completely behind. And in post-operatively, you can see that it is once again relocated and the central line is passing through it 50-50 roughly. And this is an example of the results we get with shoulder surgery. Abduction, external rotation, and hand behind head. Okay. Now, finally, I'm going to show you CC7. In 500 plus primary nerve repairs, we had 19 cases which required CC7, where you get a picture like this of multiple ganglia lying in the neck. 1, 2, 3, 4, they're all there. So there is no donor route. This is the strategy we use: CC7 to C8T1, 11 to MCN, cervical motor to SSN, and whatever routes come you think useful, not useful, give it to the posterior cord. Our maximum follow-up is 15 years, minimum is just about a year, and average is 5 years. I'm showing you one child from the earliest finger motion that was seen to the ability to grasp and eat, to the ability to put buttons. This is going ahead on the timeline. This child is getting older. To the ability to now handle complex objects and do complex motion. This is 8-year follow-up. This is 10-year follow-up. He's using the affected limb, holding the glass, feeling the opposite limb. Notice both pronosupination is available. Now he is going to hold that glass. Notice the thumb can go in opposition, and now he is going to drink it. Of course, like all Indian boys, he is now playing cricket. And his last 15-year follow-up shows this result. Independent finger flexion, finger extension, and independent wrist motion. And this is a 16-year follow-up on a shoulder muscle transfer. And it is very difficult to make out which is the affected limb. So I would conclude to keep close watch for primary surgery between 3 and 6 months. Global plexus always operate early. Upper plexus be continuously vigilant and decide between 3 and 6 months. Shoulder needs a continuous follow-up and keep looking for typical co-contraction attitude and internal rotation. Act early before you lose the glenoid, and long-term follow-up is very, very essential. I thank you all for your patience. I am happy to share papers we have written with anybody who is interested. I have shared my email here. And Professor Vibhuti Nayak will be happy to give my email to anybody who wants it. Mr. Chairman, sir, Dr. Chaudhary, I thank you for hosting me and giving this opportunity.
I thank you very much that you respect the time so much. You are on time. That is a great thing you have done. And this is a teaching for the young people. Any questions from the floor? We have a lot of people in Odisha. I think Vibhuti knows. Every year, about 50 to 60 cases of brachial plexus being done in our SCB center. But we don't have much of cases of neonatal brachial plexus injuries. Any question? Vibhuti, please.
Sir, it was an excellent presentation, both as far as content is concerned, clarity is concerned, transmission is concerned. So we have got the message. So I just have a question, sir. How late can you operate in this obstetric utilization?
I'm sorry, I'm unable to hear the question.
Sir, how late can you operate for utilization?
Oh, in babies, see, it is ideal to get the baby early. But in babies, I never lose hope. 12 months, 14 months, untreated baby comes, I still operate. Because their nerve recovery is a completely different ball game from the adults. So I never give up on a baby, I always operate. If a baby comes at maybe 5 years, maybe I won't operate. But between 1 and 2 years, I will still operate.
Any more questions?
In global policy of reconstruction of all nerves, contralateral C7 and also
I'm sorry, I can't hear.
Can you hear me now, sir?
I can hear Professor Chaudhary. I can't hear you.
You can take this mic. Sir, some of the neurotizations you have showed are extensive neurotizations.
Yes.
Contralateral C7 and all the roots reconstructed.
Yeah.
So you take sural nerves from both legs or any other
Yeah,
nerves you take?
so when you have the maximal requirement of nerve grafts, see the calculation is like this. The typical gap we find is between 1.5 to 3 centimeters between the proximal and the distal ends. Let us take an average of 2 centimeters. And let us say we have all 5 roots available. And we want to give 3 to 4 to every root. That means we want 15 to 20 cables. At the rate of 2 centimeters, we want 30 to 40 centimeter nerve graft. Now, typically on the affected limb, the superficial radial will give you 9 to 10 centimeters. Medial cutaneous nerve of forearm will give you 9 to 10 centimeters. And then if the total is 20 and you want 40, then you take both surals. Sural can give up to 12 centimeters, depending on the size of the child. So if there is a happy situation where there is plenty of donor nerves available in terms of the cut roots, then we take both surals, superficial radial and medial cutaneous nerve of the forearm, all 4.
In your experience, does the neurolysis have any role in operating brachial plexus?
No. If you have diagnosed the child as requiring surgery, you better end up doing some nerve transfer or nerve coaptation.
Thank you, sir. Okay, I think you have nicely answered. Any question? Sir, I have a couple of questions for the interest of the audience here. Number one, but regarding the etiology. So, as we know about 1.5 or 1,000 live births, we have the neonatal brachial plexus palsies. As per the, what is your experience on that?
Yeah, that is correct. Typically,
That is correct.
1 to 1.5. It depends on which part of the world, but in India, it is certainly 1.
As per the etiology nowadays, normal vaginal deliveries are not common in mostly urban areas. So,
Sir,
what your experience?
What has happened is, we are now beginning to base our thinking based on tertiary care hospitals, which have very high incidence of LSCS. But still the common nursing homes, the maternity care homes, vaginal delivery is still the norm. LSCS is not the norm.
Okay.
In fact, most obstetric societies will criticize centers with very high rates of LSCS.
What is your experience regarding the cesarean section? Do you have a neonatal brachial plexus
So, sir,
injuries?
in our, when we first collected data in 500 cases, 9 were from LSCS. And that happens with oligohydramnios. If when they take the incision on the uterus, the fluid quickly goes out, the uterus clamps around the child, and it is in fact worse than a shoulder dystocia than to pull that kid. So what gynecologists tell me is, your hand should be ready to go inside the uterus as soon as you incise, no fluid should come out.
Do you have a neonatal brachial plexus injury in case of anesthesia epidurals?
No, I can't tell you that.
You know,
because no, sir, that data is often not available. When we ask the mothers these questions, they often say, I don't remember anything.
Sir, the presentation was so clear, it appeared as if you are doing a physical presentation, sir.
Thank you. Thank
you. Clarity of presentation was so good. The voice quality was so good. Transmission quality was so good. You couldn't hear it when I told initially, but it was absolutely a clear presentation, and it appeared as if you are here physically presenting to us.
Thank you very much.
I want some of our MCA students to ask some questions. Tanmay. Take this.
Sir, actually you have presented so nicely that how to examine the brachial plexus in pediatric age group. We have not so many experience regarding that, sir.
Yeah.
And we see the video and practically we see that. So very much thank you, sir. And
most welcome. Most welcome.
Oh, Another question, sir, from Dr. Misra from Apollo.
Yeah.
Thank you, sir. Sir, are you using, sir, glue?
Yes, yes.
This for this pediatric group. I have seen that you have used glue for this.
We have used it when I came there when you were my host.
Sir. In 2016, sir, you have operated two cases, sir.
Yeah, yeah. So glue we always use. In fact, in pediatric, it is even more important because the root is very small, it is very deep. It's very difficult to get access for too many sutures. I always put 1 or 2 sutures, so I am not afraid that the graft will flow somewhere with my glue. But after that, I use glue.
Sir, about this types of the glues marketed in the India, which glue specifically not?
I only use TCL. I don't use any other. The Baxter TCL.
Thank you, sir. Thank you.
Do you feel the diagnosis about Naraka's classification is very much applicable?
Yes.
To clinical conditions?
Absolutely. Absolutely. Of course, Naraka's doesn't include the Klumpke type of palsy, but yes, otherwise it's applicable.
And regarding the investigation, which is the most valuable investigation in children?
I think EMG. I am still very slightly scared about MRI in 3-month-olds because the anesthetic is outside, the bloody kid is inside that machine, difficult to monitor. I get little jittery on that whole score. But EMG is with the child awake with the mother present, so quite safe. And it gives plenty of good quality information.
And regarding the glue, do you give any mechanical sutures there?
One or two,
it is only
so
one or two?
Make these cable bunches. So let's say I put on upper trunk, middle trunk, lower trunk. Each trunk I will put 1 or 2 sutures and then I will put the glue.
Okay. Dr. Raut from AIMS, Bhubaneswar.
Yes.
Sir, good afternoon. Sunil here.
Good afternoon. Hi, Sunil.
Sir, I just have the same question related to what Arun sir was asking. That mechanical sutures, sir, you use in pediatric age group, whether it is 12-0 or?
No, 10-0 is enough.
10-0 is enough.
Yeah, 10-0 is enough.
Okay.
Yeah.
And it's
you know, if you work quickly, you can do this case in 3.5 hours skin to skin. That's what we do.
Sir, it's in your hand, not in ours.
No,
honestly.
See, in the children's hospital, I get theatre 8:30 to 12:30. I have to finish before 12:30.
We need to have that much experience, sir. Honestly. Thank you, sir.
Okay.
In assessment, AMS is okay?
I don't use AMS, sir, because I don't have a team of therapists who are going to monitor the children and note down everything. AMS requires a lot of investment on the part of the department in terms of therapists and, calculating everything, making charts. In my public hospital, I simply don't have that luxury. But if you are in SCB Medical College and you have therapy department cooperating with you, maybe you can do AMS. I personally, sir, have other option about AMS is, for example, AMS score of 5 looks good. But it actually doesn't even mean very strong movement, 6 and 7 are the only meaningful scores. But people show a result of 5 and say we got a good result. You cannot visualize the 5 as you can visualize the M3 plus on the MRC scale.
What is your home taking message for the obstetricians from your experience in brachial plexus?
No, sir, obstetricians, I think, are in an unenviable position. They get blamed for something they are not responsible for. Except in cases where they know pre-op the child is 4.5 kilos and they still go through a vaginal delivery. That's different, but the vast majority are 3.5 kilos and have developed shoulder dystocia. There is plenty of literature which shows you cannot predict shoulder dystocia. So you can't do cesarean on every child.
The lady or girl who was dancing with Bharatanatyam,
yeah,
did she have any deficiency or she was almost normal?
She was an upper plexus on whom I had done she had spontaneous recovery, but I had done a shoulder muscle transfer on her because she had gone in internal rotation contracture.
So again, sir, Dr. Sunil wants you, sir.
Yeah.
Sir, it's regarding contralateral C7, sir.
Yeah.
Sir, how often you have come across the patients complaining of pain and tingling on the contralateral side, normal side after C7?
No, we haven't. In children, definitely we haven't.
No,
in adults, sometimes there is a transient complaint on the middle finger. but there is nothing long lasting even in adults in my hand.
Even if it is, then it should not last longer.
Yeah. You know what? I have this theory about C7. When people harvest C7, they are not careful enough not to cut the posterior division of lower trunk. You know, when I take a lecture on C7, I always show a trishul. Can you see my fingers?
Sir.
The posterior trunk is formed by 3 contributions, 5, 6, 7 and 8 T1. The 5, 6 can be seen very easily, but 8 T1 and C7, 8 T1 is very small. And it is my thinking very often people cut the 8 T1 also with the C7, which is what leads to the morbidity. So I have made a rule, like you show Callot's triangle in gallbladder. I show my assistant all 3 routes. I will put loops around the other 2 routes, 5, 6 and 8 T1. And then I will singly cut the C7 route. That way the morbidity is much, much less. People don't take care of this and people don't demonstrate the posterior division of lower trunk.
Suppose you go for a tendon transfer in the wrist for extension, which tendon you prefer?
So, sir, in birth brachial plexus palsy, results of tendon transfer are inferior to results in peripheral nerve injury. Basically, because of co-contractions. The flexors extensors are co-contracting all the time, and it's very difficult to overcome. One of the things Professor Venkat Swami told me 20 years ago is not to do tendon transfers under the age of 4. Except for shoulder. Shoulder I do very early, 1.5 also. But for hand, wrist and fingers, I wait till the age of 4. Because after that, you can start talking to the child. You can start demonstrating co-contraction to the child. You can start teaching the child how to overcome the co-contraction. So I never do tendon transfers under 4. And even having said all this, my results are suboptimal compared to the results in pure peripheral nerve injury.
Any more questions? I think, sir, you have satisfied everybody in this hall. And we are very much thankful that Senior Professor Baliar Singh is almost here and listening. So, yes.
Namaste, sir. Namaste. And I can see Dr. Falguni Rai also.
Yeah, absolutely correct, sir. So,
thank you.
So they have been all listening patiently, and your talk was really fantastic, exciting, and it was also very good, educative to everybody here.
Thank you.
So thank you very much sharing with us with our annual conference.
Maybe
you. First time after a physical conference. Would have been more happy with your physical presence.
Yes.
But now you are almost like physical with us.
Yes.
As Vibhuti has nicely told that. Thank
Sir,
you very much.
If permitted, I want to listen to the next talk by Vibhuti on polycization.
Okay. Now it is on the Zoom, sir.
So
now it has gone international, no?
So I can stay on, right?
Yeah.
Okay.
YouTube and Zoom also you can visualize, no problem.
Thank you. So I'll just
thank you very much, sir.
Yeah, thank you, sir. Bye.
Sir, it's very difficult to present.
No. Go on. I want to listen to you.
Student, you have been my teacher. So to present before you is going to be very tough. Once you said that you are going to be present.
I can see the board behind you which says Vibhuti Nayak HOD.
Yes. This one I think also. This one. Okay, Sachi. Okay. Now we are going to have the. I think I hand over the chairmanship to Dr. Sunil Raut. He is the Professor HOD at AIMS Bhubaneswar.
So just a change in the program. We are requesting Professor Naik, Sir Vibhuti sir, to present his presentation on polycization.
I think I have very less time because our next speaker will be online. So I'll have to make this presentation very short. So I'll be speaking on thumb hyperplasia, focusing mainly on polycization.
So thumb is considered hypoplastic if any portion of the array, skeletal or soft tissue, is deficient or absent. The male-female preponderance is almost similar. It's 4.6% of all congenital deformities of the hand. Right side is more common, and it's associated with congenital anomalies, other congenital anomalies. Developmentally, the primary ossification center develops in the 2nd to 4th fetal months, and the secondary ossification centers develop between 2 to 4 years. So delayed appearance of either primary or secondary ossification center is indicative of degree of hypoplasia, depending on the degree of delay. So Gosset and Hilgenfeld were the first to describe digital transposition for post-traumatic thumb loss, but it was Bock-Grumko who actually set the present-day standards for polycization. Etiology, as common for other congenital anomalies, is genetic, environmental, teratogenic, and the syndromes that are associated are Bacterial, Fanconi anemia, Holt-Oram syndrome, and TAR syndrome. So the classification wise, if you see, type 1 is the minor grade, where there is minor degree of hypoplasia. Type 2 is basically absence of the thinner intrinsic muscles with fast wave narrowing and deficiency of the ulnar collateral ligament. In type 3, the presentation is similar to type 2, but in addition, there is extrinsic muscle and tendon abnormalities. And there may be skeletal deficiency in the CMC joint, either it may be stable or unstable. If it's stable, it's type A. If it's unstable, it's type B. And in type 4, it's a floating thumb. And in type 5, it's complete absent thumb. So basically type 3B, type 4 and 5 are the ones which require polycization. So timing of the surgery is usually from 12 to 18 months. It improves anatomical, cognitive and psychology aspect of the patient. All of you know that the thumb corticalization takes place around 18 months in the post-central gyrus, and it has a huge representation in the post-central gyri. So I am not touching up the treatment of other hypoplastic thumb because time is short. So I'll straight away go into the polycization. So in polycization, what is the concept is to transfer the index finger to the thumb. So when the thumb is absent, it's easy to convince the patient, but when the thumb is present, then it's a little difficult to convince the patient about transfer. But if you have videos of your previous surgeries, I think once they see the results, then it's very easy to convince them. So when we classically take Bock-Grumko's incision, so the volar skin here, it will go into the first wave and index finger will come here. So when you take the volar skin, we have to first look into the neurovascular bundle, both radial and ulnar. And the main focus has to be on the ulnar neurovascular bundle. Here we have to sacrifice the radial digital pedicle of the middle finger, because the common digital pedicle with a branch to the index finger will go with the index finger. And the common digital nerve normally needs to be teased as far proximally as possible, because it will help or aid in the shifting the index finger to the thumb position. So the transmetacarpal ligament needs to be cut. And on the dorsum, one has to be very careful while taking the incision, because when the thumb is completely islanded, the index finger is completely islanded, the dorsal digital veins have to be preserved to help in draining, otherwise there will be problem in transfer. So at least 2 prominent dorsal digital veins have to be protected. This is a little difficult in 1-year-old child. You have to do under magnification or sometimes under microscope. So once you have isolated the digital pedicle, cut the ligament, you have to cut the A1 pulley, and then expose the metacarpal ligament. The second metacarpal. The second metacarpal, you keep the epiphysis and remove the whole of the metacarpal, so that it's adjusted to the length of the thumb. So now this entire index finger is islanded on the neurovascular pedicles and all its intrinsic tendons. The interossei, the palmary interossei of palmary interossei and dorsal interossei are also taken with it, and the palmary interossei will be connected with the radial lateral band, and the dorsal interossei will be connected with the ulnar lateral band. They will act as abductors and adductors when the index finger is transferred. So this is when it's transferred. The epiphysis is fixed to the carpal. This can be done with a K-wire or with a monofilament suture material. And this is where the index finger was. So it's transposed to the position of the thumb, and you have a wave here. And this is what our aim is. The patient should be able to oppose. So here are a few clinical slides where you can see the thumb nicely in position, and the fast wave is very well maintained. This is 6 months post-op of the same patient, and this is 1 year. He is able to use it as for grasping. This is pause deflotant. However, here also it's not difficult to convince the patient the need for a polycization. So the steps are similar, and this is how the thumb is positioned after transfer. And if you have preserved all the veins and the digital pedicles, there is no need to worry about the vascularity. And this is nicely grasping objects with that hand and using this hand. You see, she also started writing. So complete absence of thumb. Here it's little difficult to convince, but once you show the videos of how the other patients are doing, then they get convinced that it's required for them and it's beneficial. So once they are convinced, then it's not difficult. This is the immediate post-op. And this is the X-ray. You can see the metacarpal is shortened, and the dimension of the thumb is similar to a thumb. And this is post-op grasping with the same hand. So to conclude, polycization is the treatment of choice in type 3B, type 4 and type 5 variety of thumb hypoplasia. Timing of surgery is very, very important because the cognitive PMCL functions, they start very early. This provides anatomical, cognitive and psychological improvement. Toe transfer leads to functional defect in the foot, and there is a risk of failure. So in children with isolated thumb hypoplasia, polycization is an excellent procedure which we should adopt. Thank you.
Nice presentation, sir. Any question from the audience on polycization? Sir, I have one doubt.
Yeah.
Like in pause floatant and the complete agenesis of the thumb, type 5. So there will not be, I don't expect to have a good scaffold. So does it cause a problem for the stabilization of the after polycization? CNC joint recreated.
So when first thing is you have to shorten the metacarpal. Unless you shorten the metacarpal, you will not be able to get the dimension of the thumb. Once you have shortened the metacarpal, you are preserving the epiphysis. So this epiphysis needs to be fixed to one of the carpal bones available adjacent to it. So whatever bone you get in the base, you fix it.
So it's basically CMC is getting fused.
Yes.
You don't need to fix with a K-wire.
This bone is soft, so you can easily use monofilament suture material. But If you're confident, you can use K wire also.
Or you are afraid that epipieces may get damaged by passing a K wire?
No, but 1 mm K wire, if you do it carefully in one motion, it should not be a problem. Many times in patients, we use K wire in contracture releases or in reimplantations also.
I have a question, Vibhuti.
Sir.
How do you play with the tendons? No, thumb has a variety of
Sir,
tendons which are cognitively placed in the cortex in a different way.
So polarization in children is different because children adapt very well. Once you have shortened the metacarpal, the length of the musculotendinous units, they adapt over a period of time. So there is no need to specifically work on the tendons. But what we have to work on is the using the interossei muscles to good effect. The palmar interossei is usually transferred to the radial collateral lateral band, radial lateral band, and the dorsal interossei to the ulnar lateral band. So they will act as intrinsics, abductors and adductors, and the long flexors and extensors are there. So basically, you will have the function of the thumb. So imagine index finger in position of the thumb. So the percentage of function improved tremendously once the index finger comes to the position of the thumb.
So by passage of time, patient adapts.
They adapt.
The child adapts cognitively in the.
So I don't have. I've just started doing it the last 2 years. So I don't have a long-term follow-up of these patients to see what the long-term problems are. But the parents are happy because the children are able to hold objects, use their hand, and one child has already started writing. So maybe after 5-6 years, I'll know what are the secondary problems associated. If Dr. Thatte is online, he will be the best person to answer this question.
Dr. Thatte is there in the line?
Yes, I am there.
So can you answer each question, sir? He is supposed to answer, but you will answer on behalf.
Yeah, so I always cut and redo the extensors. Otherwise, you get a flexion attitude in the reconstructed pollex. So I always redo the extensors. In fact, I redo the extensors at extremely high tension because later on, there are 2 flexors instead of 1, FDS and FDP. And both are going to contract with time. And if you don't do extra tension on the extensor, the thumb then goes into flexion. So when I do the policization, I cut the extensors and I pull them and re-suture them at high tension. That is one point. And second point, I think Vibhuti should mention is rotating the head by 90 degrees to achieve a extension position. Otherwise, the new pollex can go into hyperextension at new CMC. Now, somebody said CMC is fused. CMC is not fused. If you put just one suture, the CMC reforms there in the gap between the 2 carpal bones. Somebody correctly pointed out scaphoid may or may not be there. We are uncertain about which carpal bones are present in radial dysplasia. But whatever is present, when you remove that metacarpal, I noticed in one case, Vibhuti has not removed the full metacarpal, but you have to remove the full metacarpal. And then when you reposition in that gap in the carpometacarpal joint and put one suture, it forms a neo-CMC joint. And I used to use the K-wire just like he is doing in my early years. I gave up the K-wire and let me explain to you why. I gave up the K-wire because the K-wire doesn't allow me to adjust the tensions properly. With the K-wire, the thumb is already in a fixed position. So I don't know the effects of my skin closure or my muscle tension adjustments are having. And therefore, nowadays, I never use a K-wire. I use the various muscles around the thumb to position it and the final skin closure.
Thank you for your tutorial, sir.
No, not tutorial, sir. Just
Sir, you don't do anything to the laxity of the FDS and FDP?
No, FDS and FDP contract on their own very nicely. They take 6 months. After 6 months, you can see the DIP joint flexing.
Okay. Only extensor need to be laxity
needs to be done, and if both are present and in good condition, one becomes APL and the other becomes EPL.
Thank you, sir. Thank you.
Thank you very much, sir, for being here and guiding us. So I actually wanted to request you to present policization.
Next year. Next year. Sure, sure. Okay, thank you, everyone.
Thank you, sir.
Thank you.
I think our next speaker is on waiting.
Yeah, for the next session, I request Professor Falguni Rai sir and Dr. to chair for the next session.
Hello. Hello, hi.
Dr. Bhumkar, good afternoon from our.
Good afternoon. Good afternoon.
And Dr. Ashish Patnaik, my co-chairman.
Yeah.
Dr. Ashish Bhumkar is 30 years in ENT practice in Thane, Mumbai. And he is the founder member of the International Auricular Reconstruction Society, World Microsia Society. He has earned an international reputation in doing microsia repair with hearing improvement surgery in a single stage. Currently, he is the member of COVID-19 task force of Maharashtra, specially assigned to mucormycosis. Now I request Ashish Bhumkar sir to continue. His topic is microsia reconstruction. I have also trained at AIMS New Delhi under him.
Thank you. Thank you, Ashish. I will get my slides to be. Hello. Yeah. Good afternoon, everybody. Can I start?
Yes.
So, good afternoon to the delegates and namaskara to the professors here. Thank you for having me here, and let's begin at the beginning with something very auspicious. And my talk is on the external ear, and this is what an external ear to us is. This is what it means to us. I'm 30 years in the practice of hearing restoration and about 15 years in microtia. And this is where we have reached the level of religiousness about the ear. I happened to be the founder member when this was first thought of, and I was lucky to be a part of this as a founder member. And actually, yesterday and today, the World Congress is going on. And at 5:30 India time, day 2 of this World Congress will go on. The top question, mostly at 15 years back, and it still continues, are the results of this microtia surgery really good? Because often few people have attempted a few cases, they don't go well and they give up. Is it really worth doing it? Do the ears really look normal? This is a very standard question even in the ENT circuits, and the few plastic and maxillofacial have gone. And the answer is an emphatic yes. And we'll show you here is where the journey begins. This is a typical microtia that we have. And in one single stage, we are able to achieve this, the entire framework and all the fine details of the ear in one single stage. It keeps getting better with time as the skin remodeling, as you all are masters of the skin, keeps on getting better. And this is what actually the patient landed up just yesterday in the OPD. And I've had, and not just that, because we are doing something more than just the microtia repair. And this is in Hindi, but this is where. के बाद सुनाई देने का सुधर गया ये कान से बहुत सा सुधर गया much better. The hearing is much better. The perception of sound is good. So in that single stage, besides the microtia repair, we do something of a canal drilling, and I'll speak about this. I'll run through a lot of photographs and small videos, which is what I have been told, only to inspire a sense of confidence that yes, it is possible to do and give a nearly normal looking ear, an external ear. And with time, the skin remodeled itself, and actually it starts looking better and better with every passing month. This is on the table itself. It's a beautiful 3-dimensional framework that we made, and all the contours, everything is visible. The skin slowly starts to become remodeled and becomes very fixed. There is a second stage to bring it out. And after that, you can actually, the child can wear an earring, which is the topmost priority in every girl child's mind. This is how they look when they keep coming to you. And this was a small poster. I'll not talk about trauma. I'll only talk about this. Now, to update something, there's a lot of talk about these stem cells growing in the lab, regenerative medicine, cartilage cells, etc. I've been lucky. Alex Afilian was a star scientist. He came to our center. He spent a week with us. I interacted. I went to London several times, but this was 5 or 7 years back. And honestly, nothing of clinical use yet. Even yesterday, there was a lot of talk about this regenerative medicine, but there's nothing coming up, at least for the next 3 to 5 years. There's some reports from China about ears being grown, but no clear evidence yet. So it's still the rib cartilage reconstructions. Now, donor cartilages, many a mother will ask that, can you take my rib and make the ear for my child? If you can take the kidneys, why not my rib to make the child? Obviously, we know that it will need it's a transplant, and immunosuppression is simply not a value-based proposition where donor ribs are concerned. There's some work going on, especially in Zurich, Switzerland, to make these ribs immunocompatible. But again, it is for when the application is for a smaller segment and not a bigger segment, not for external ear. So we come down to the gold standard still in 2022 is the rib. At number 11, from 1 to 10, it's the rib. At number 11 comes the medpore, and I will show you some photographs of the medpore. So I'm, like I said, 30 years. So my experience of hearing improvement is far more, double of my microtia. And it's just a question of time that the two merge together. So a little bit more about the specifics. So what the heck is microtia all about? I mean, why is it such a premium or a rare or not too many people into this? I see it in my mind as a tango. Microtia repair is nothing but a surgical tango between the framework and the skin. It's a harmonious surgical. The framework has to lovingly invite the skin, and the skin and the framework have to remain married. This is the cartilage framework made from the child's own rib. This is the skin pocket made. And then this cartilage has to go into the skin pocket that you have made. And you apply a vacuum here, a suction vein, and then you wait for the magical moment of the birth of an ear you're about to witness. There it goes. Now the suction will be applied. Appropriately done, skin will drape it and sort of shrink wrap it. This is another one on the table itself. All the fine details. Look at the inferior crust, the superior crust. The inferior crust is in a lower plane than the superior crust. There's a high point of the antihelix. There's a high point of the helix. And all of this on the table itself, you start getting a complete, the entire framework is there. So let me give you whisper some secrets, because I think the power of whisper is far bigger than the power of talking. So this is what we are going to be doing: the microtia, the rib framework, and the skin pocket and the suction. The rib, of course, comes from the child's own chest, and this is where it will come from. And therefore, there is a selection criteria which is specifically based on this chest circumference rather than the age. So this is the synchondrosis of 6 and 7 is typically which will form the base plate. And then I will tell you the 8th rib will form the helix, and this is how it is. So this is the block of the synchondrosis of 6 and 7, and I will explain to you what that blotting paper template is about. This is where we are going to. At what age do we do? The top question. So age really is no bar. And I say this with a lot of responsibility, because for me, the chest circumference in a non-obese child, the chest circumference should be at the level of xiphisternum, should be 60 centimeters or more. This is the selection criteria for. Typically, this age in an Indian child will be 8, 9, 10, or 11. But you should wait till it is 60 centimeters. Anything short of that, there are two potential problems. One is you may cause a certain weakness in the rib itself, and that can be a terrible thing for the child. Plus, equally importantly, the quality of the rib, especially its thickness, is not so good. So the sculpture that you make out of that raw material will not be the most ideal and the most beautiful one. So having patience is very important. To reach the level of 60 centimeters is very important. So the top options today are the rib, which I said is the gold standard, the Medpore, the synthetic one, and of course also the prosthesis in some cases. For Medpore, however, because the rib harvesting is not there, it can be done in as young as 3 or 4. Although even in those cases, I still like to wait till 5 or 6, and I will tell you why. But technically, internationally, it is done. These are our Medpore results. They come out very beautiful. When it goes very well, it goes beautifully in one single stage. You can get a nice normal looking ear, external ear. We have a very large stock of Medpore, which now goes by the name of Omnipore after the company was taken over. You can get an elevation in that single stage. But the question when I'm asked, do I use a Medpore? I definitely use a Medpore. Do I prefer to use a Medpore? No, I don't prefer to use a Medpore for several reasons. The Medpore, unlike the rib cartilage, you cannot slip it under the skin pocket. That's a disaster. The Medpore has to be covered, every square millimeter has to be covered with a rich vascular temporoparietal flap based on the superficial temporal artery, or if that is damaged or that is not of a good caliber, an occipital artery. But it has to be covered entirely with a very rich vascular flap. Now, so you are avoiding a cut on the rib, but you have to take incisions on the scalp and you have to harvest this. You typically will need 11 to 13 centimeters of the length and about 11 centimeters width of the TP flap for it to wrap the Medpore almost like a masala dosa. You want to have extra margin so that they don't get exposed. These are our these things of the temporoparietal flap. Now, even if there is a minor exposure by a millimeter or 2 millimeters, there's exposure, there's a big chance of an extrusion, big chance of an infection. So even a millimeter of exposure can lead to a disaster. And unfortunately, this may not happen in the immediate few weeks. You may have good healing while the patient is with you, but it can happen anytime later with friction. There is no play between the skin and this synthetic framework. So 2 years, 5 years down, sometimes right at the top of the helix or sometimes at the root here, at the lobule, you start getting exposure, or sometimes at the high point of the helix. The skin starts to break down, and then there's really nothing except now going in for another operation and trying to get flaps from here and there, or very often to simply remove the Medpore. That's the reason why we use it in very select cases. The skin graft, of course, we have the dermatome, and we use the skin most often from the scalp for whenever we need the skin flap. So 95% of the times in microtia cases, primary microtia cases, I will use the rib. Only 2% of the times when there's hemifacial microsomia, when there are certain more challenges, chest deformities, we'll use the Medpore. 1% of the times, prosthesis, these are mainly in secondary cases, mainly in bad burns or severe trauma. And 2% of the times, I will actually tell the patients, let's do nothing. This was the great man, and he had this peculiar hairstyle because he's had a minor but a microtia, some form of a deformity, and that's the reason why he always took efforts to cover that this thing. Google says so. Now the right and the left ear are never the same. Deepika, this symbol of beauty, she has a stall deformity on her right ear and not on the left. Even the Miss World, she has a helix which is quite not so good. So I show this as an inspiration for the mother or the parents that not all ears have to be perfect, and this takes away the pressure from on the parents. It's very important that you also tell them that doing nothing is also a viable option, and anything can be done at any time. Now, how many stages do we do? I showed you the photograph. Now today, with Nagata's contribution, the entire framework is done in one single stage, and all the details of the ear can be made in one single stage. The second stage, if at all the child wants a post-oral groove, and more than 30% of our male children do not want it, They are happy with what you just saw. The post-oral sulcus, it needs a second stage. The post-oral, we have simplified the surgery, and we just take a simple cut, mobilize the skin of the neck, advance it forwards, and take a full thickness inguinal skin or a skin from the chest itself. And this is how the ear will look. The beautiful post-oral, it has a certain mobility. They can wear their glasses, they can go about. You can pierce this ear and the child can wear any earring. There's no problem. This is one more, but I think I will skip this. So what are the important steps, main steps? There is harvesting of the rib cartilage, there's sculpting of the ear framework, and there's creating of a skin pocket. This is where microtia was. And now we have added this drilling the canal and freeing the ossicular chain, because it is always engulfed in a thick atretic bone and the ossicles are rock solid like in a cement assembly. This gives an additional aesthetic appearance. Beautiful conchal bowl can be created because you're drilling part of the mastoid. You can get a deeper and a much more circular, natural looking conchal bowl in the first. And of course, the hearing improves, the perception of sound improves. When there is no hemifacial asymmetry, it's very easy to simply mark the normal side and flip the paper to the opposite side and get your X, Y, and Z coordinates right. This first marking is very, very important and very fundamental to microtia repair. You can also do a trick about the long axis of the nose and the long axis of the opposite side, and is standard. I mean, standard, but it's something very important to notice. You may please notice that I'm using the Doppler to mark the superficial temporal artery, because this you definitely don't want to damage. And in every case, you want to mark it, because they may have a slightly abnormal course. You have to make sure, because if there is a skin necrosis, it's the artery which is going to come to your rescue. This is very important. This is something about marking. This is about the template, and I'll speak a little bit more about the template. This is a template on an X-ray film made first of the normal ear size and then 2 millimeters reduced, and this is the template made of the framework, and then it is kept on this to make sure that you have enough non-hair bearing skin for that framework to be fitted and get a single and a ear in a single thing. So it has become a standard protocol for us to now do CT scans, because there's tremendous value in this. We see grossly ossified ribs even in 18-year-olds. They're very difficult to sculpt. You need a powered drill to do that. We can also choose the side, right side or the left side. And there's like a virtual surgery. Sorry. Can I go on? And there's like a virtual surgery that we do way before we have wheeled in the patient inside. We all know there are variabilities in size, shape, configurations of the ribs, and all these surprises have gone away now because we are doing the CT scan, and therefore it is predictable, and we know precisely where to take the incision, where to take only as much as we need. We do not take too much cartilage now. As you may notice that one needs a lot of cartilage to make an ear. Therefore, the 60 centimeters at xiphisternum circumference is sacrosanct. Do not do it in younger kids. They will get chest deformities and you will end up making very poor frameworks. The other tip is to keep the perichondrium intact on the internal side. That's the surest way to make sure you are not damaging the pleura. These are all possible, but these are more tricks. You can get a 3D model of these patients' rib and try the surgeries beforehand. So this is the synchondrosis of 6 and 7, which forms the base plate. Then the 8th will typically form the helix. Sometimes if it is too long, the antihelix can also come from that. And usually it is the upper part of the 6 or the 9, which will form the tragus, antitragus assembly. This is nothing much about this. On the table, with the template, we have marked, and we do not take too much. We take only as much as is required for the template. This is the Colorado tip, and it's very safe. No problem, no damage to the cartilage. Take the template and take out precisely as much as is required. So there is no extra cartilage for it to be put back in the chest. and you're unnecessarily not wasting any cartilage by taking out too much. So you actually mark only that is required. This is typically, and this will keep changing depending upon so you need a lot of cartilage, so 60 centimeters, and the end of it, this is what you will do. So very often the big guys will have a junior surgeon harvesting the rib, and the junior guy will take out a lot because he doesn't want to fall short. And that's not a good strategy. I think the primary surgeon, because while you're harvesting, there's a lot of planning that is going on in your head. So it is very important to do this.
As far as concerned, we insist on doing the CT scan of the chest where you can see the rib cartilage. There's a special software. The routine scan does not show, so there's a special software. And then we get a true size of the cartilage from our scan center. Then we do virtual surgery. We decide from where exactly we are going to take, what sort of a cartilage confluence we are going to get.
So this is the virtual surgery that we will
this
do.
is the entire 8 and probably the facial nerve, the look at.
What has happened?
One is the factors that we look at.
The CT temporal
One is
bone has
to
changed.
look at the course of the facial nerve. So the facial nerve is very important because we know in atresia we have a lot of, especially after the second genu, the facial nerve can go really anterior and superficial. So we make sure that we have the facial nerve in its normal course, or we determine the course, and then we also look at the presence of stapes suprastructure.
So these are pretty much the two important criteria for us for committing on hearing improvement. Now the sculpting is really the sexy part. I think everybody, when they get into microtia, the first or the only thing they want to know is how to sculpt. So at the request of this, I've added a lot of the details about sculpting. Most attractive with the template is made, which is a very standard, and then you discount the skin thickness of 2 millimeters, and then you duplicate this framework of the X-ray on a blotting paper. This makes precision and the work very easy. So this is an approximate template of the normal side in a unilateral case. Then we went through a learning curve where we were measuring everything in millimeters and trying to get our things completely right, measuring each and every part and the subunit of the ear and marking them, color coding them. And this is where the 2 millimeters all around has been reduced. And this is now the template of on an X-ray film of the framework that will be needed, because this will get covered with the skin. And this is on a blotting paper, the same with this thing. We sometimes do a color Xerox and then just cut it. Things can go wrong if we do so this is again the template. This is the template kept here. And now this is the blotting paper soaked in ink, and we'll make an ink mark. And we know that this part of the tragus cannot is not fitting in this synchondrosis here. And this part of the root of the helix is not fitting. So there'll be other pieces which will form the missing jigsaw puzzle, and we will wire them together. So this is the ink mark. The blotting paper is soaked in an ink. This is see, very little of the cartilage actually gets extra and wasted. And we keep measuring. This is in that particular case 6, 7, 8. And in that case, because the CT scan showed the 9 was wonderful, we decided to make the anti-helix and anti-tragus in one single piece. It just looks beautiful. So you customize it like in every surgery to everything. The beauty of the blotting paper template is the pieces can be cut and individually made. And when you bring the jigsaw together, there is no approximation. It all fits in like a lock and key. This is how it all goes. And on the table, when it goes under the skin, this is how it looks. Few days later, also, this is how it looks. This is a case I will speak about later. This was the case in whom we did the bone bridge at the same time. He's a bilateral. At the same time, we did the bone bridge surgery along with microtia repair, and he hears beautifully. This is just for those. We look at the template of the framework and make sure we design the framework exactly as per that. Nagata has figured this out. There's nowhere else to go. He was the master, unfortunately passed away in January, but I think he's the ultimate word in microtia reconstruction. And he had figured out everything to the last millimeter detail about having these different pieces together, wiring them and creating a beautiful framework. And you can really practice this. He has worked out all the details, all the options. So one only has to look at his papers and start getting into this. Everything should be measured. It's very important to measure everything and then go on, practicing your sculpting. This is the 8th suitably sculpted so that it has this beautiful the helix. This is an anti-helix where the piece was a little more short. And then we start using the 5/0 steel wire on a silicon block and start wiring this together. This is typically how it will look when the helix is being fitted. This is the silicon block on which this is just to show you some more and more. These are the beautifully done sculpted frameworks. Let me go. This is the ink mark that is kept there, and this is the tragus which will come. This was, I think, the case that I showed you. And this is a standard Nagata instrument. It has a blade which can be reusable, and you can. There is a Karl Stoss set, but that's a fixed set. But I like the Nagata instrument for sculpting. And then once you have the ink mark in place, it's not such a big challenge. These blades are replaceable. They come in different sizes, and you can. When it is not ossified, it is really like the hard butter from the fridge, and you can do this. Interestingly, actually, it is my anesthetist who now for the last so many years, she's the one who sculpts it. I've almost stopped sculpting. She sculpts it and she does the suturing also. So while the patient is under anesthesia, we are using her time and her talent to do this. Then comes these are the details. There is a high point of the anti-helix. It goes down and before it becomes a high point at the anti-tragus. And all this is just a matter of practice. But one needs to very patiently create these little pieces of jigsaw and then put them on, make sure things are going right. While she's doing it, I'm doing something else. I don't know what. But this is fixing the wires. And I'll show you the B Brown 5/0 steel wires, double-ended needles. They go through and you have to screw them at the undersurface of the framework. That's the wire that's caught there, cut, and then she will simply screw it in place and of course dig it in. At the end of it, she'll take a blade and make a small nick, and so that the wire does not touch the skin, especially on the outer surface. Sometimes the ossified ribs, they cannot be sculpted with the standard instrument, and under copious irrigation, one has to drill and you have to create a ear framework en bloc. It's impossible to pass the wire. Very important to have a lot of water running in and creating the framework. This is just to show you to include this. Because typically the tragus will not fit in the 6/7 and we will create an extra piece. This is some more wiring. Very patiently one has to do. Typically we'll need 30 or 40 wires, and Dr. Gayatri, she's an expert now. Through one wire suture, she's able to get 3 knots. I mean, she can use the same wire 3 times. So we are saving because they're not easy to get anymore. This is how it goes on, the framework. Not so in 2015, it was still not that finished. Now you can see the finish. The hallmark is the tragus, anti-tragus notch. So this is the magic of the 5/0 steel wires by B. Brown, not available anymore in our country. So you have to keep buying them from somewhere else. And this is the silicone block. This is where they all fit in. This is the B. Brown 5/0 steel wire set. At the end of it, it should look like a piece of art. All the 3 planes that you want, the high point, the low points, and perfect calculations where the skin will not come under tension and the framework and the skin will get married forever and be happily in love. This is what it is all about. It is not about trying to make it look exactly like the opposite side. It is trying to make the most out of the skin that is available here. That's a big mistake in trying to be God, to make them both the same side. Some more photos because I'm running, framework before, after. This is anosia, gross hyperplasia of the mastoid. Still you can get a wonderful, if the planning is good, if you factor in what is to be. This is important. Some more photos just for us to see. 1 month. 1 month. This is again a case, complete anosia, almost anosia here, very small tag left there. Flat, tight skin, but still we are able to do this one again, and this will actually keep getting only better and better. So the framework has to be rock solid, the secrets. The 2 millimeter less on all sides of the normal ear one has to do. The 3 planes are very important to understand. The high point of the helix, anti-helix, the inferior crust is at the lower plane, then the superior crust, it's important. And the hallmark, the medal, the true symbol of excellence for all microtia surgeons all over the world is the tragus antitragus assembly. The helix and anti-helix are easy to do, but this, creating this to the natural thing is what separates, let's use the word average from the extraordinary, is when you are able to get this each and every time to be able to do this. Post-op, it says it's a vacuum, 3 days more or longer depending upon what it's raining. The skin, like you all are the masters of skin, edema, color, all that, the play of colors of the healing, I liken it to the Alfonso mangoes. Just looking at the color, you can tell how ripe it is or not. So it teaches you all this. As an ENT, this was a learning curve for me, but it all settles down in a month's time. And of course, if there's a breakdown, one has to very quickly address it. Now, this is about the microtia, but if the child is born with microtia, they will almost always have a conductive loss. I've never seen a child of microtia, unless it's associated with some cerebral palsy or something, to have a sensory neural loss or be deaf mute. So these are the patients who don't need cochlear implant. They are conductive hearing loss. And therefore, the question is, can something be done for their improving their hearing? Most definitely. Should something be done? Most definitely. Something must be done to improve their hearing, even if it is unilateral. And we will tell you, because a structure is nothing but, an organ is nothing but structure and function. So one must always keep hearing, if not uppermost, equally important. It's very important to collaborate with the ENT. And I'm going to show you a little bit video here, only to tell you, because what it is to have a conductive hearing
I know
loss.
I'm young, could be a little bit
normal hearing?
wise,
If you have a mild conductive loss, this is how you hear it.
and fire and ice to know the cold will suffice.
This is moderate. This is how the child is hearing.
Underestimate me if you cannot tolerate my opinion.
This is how a severe conductive hearing loss child will hear. So it's quite a lot. Although we tell them if it's unilateral, it's okay, do nothing. Because today it is possible to do many things with tremendous safety, accuracy, and efficiency. So any deficit must be addressed, whether you do something or not. And for this, understanding hearing in its totality is very important. Because hearing is not just a pure tone audiogram. And this is where our understanding of, so we hear sound. Actually, in evolution, the sound came mainly or only for localization of the sound. The hearing came not for speech, but it came for localization of the sound, and speech is a very small part. So there's something called as a perception of sound, which I speak about in all my ENT conferences also, which is akin to something like the perception of light, where you can't really measure it, but you know it is there, and it's a perception. In the same way, every case of properly selected atresia, if the stapes suprastructure is intact, even if it is slightly dysplastic, and you free it from the atretic plate, the patient's perception of sound increases exponentially, and his or her 3D orientation in time and space improves fantastically. This is very important. Now, unfortunately, the pure tone cannot test the perception of sound. But to me, science does not begin just with measuring. science begins with observation also. So hearing improvement, like I said, for unilateral, bilateral, it's a different thing. The hemifacial microsomia is a separate category altogether. In 2021, we must look at hearing differently because a lot has changed. You know, the Jofta scores and all these were 30, 40 years back when the CT scans were not showing the details that they're able to show now. Now they're able to show the detail, they're able to measure the detail, they're mapping the entire course. You can look at the size of the stapes, the oval window. There's like virtually you're going in and you can see everything that is going on beforehand. You can rule out a cholesteatoma using a special MRI. So the imaging is giving us a lot of information, and it would be a pity to not use that technology to the advantage of the child. This is the ossicular chain, malleus, incus, and stapes, and this is the oval window here. This is the footplate. These are the details one gets. The entire course of the facial nerve with the oblique, longitudinal oblique views, you can figure out, so that there is no fear of or danger of damaging the facial nerve. The pneumatization and some other things which are mainly for the otologist. Intraoperatively now there is a fantastic facial nerve monitoring. So even over and above your imaging, over and above the Google map, you can be very accurate about where is the facial nerve, map it and make sure you don't damage it. There are lasers now. Earlier when there were no lasers, to mobilize the ossicular chain, there's a possibility of a mechanical damage to the chain causing some sensory loss. All that is gone. Anesthesia, of course, we know has become fantastic and very safe. The implants are there. I will only share a few images with you. Active or passive, there's a lot of discussion. Honestly, for me, in all practical terms, any implant that the child is able to get for himself or herself, you should go ahead and do it. The advantage and disadvantage are more theoretical and academic rather than practical. So stapes is the thing. We started modifying our surgical technique and our framework to accommodate the canal and accommodate the skin in the canal. We started making the concha a little wider and a little bigger for the skin to go in. We start this thing, and then we go ahead and drill through that same incision, and we drill the mastoid going down to the ossicular chain. This is what I said, we have started cheating. Typically, we also measure how much deeper is the ossicular. This is the malleus and incus for the plastic surgeons who may have not seen it earlier. No, sorry, I'm trying to see which is the video. So this is the malleus and incus, the standard surgical landmarks. It takes an additional 20 minutes or so, not more. It's a very, very small time that one invests. Typically, this entire thing is now come down to 3 hours, and we will do 3 microchias in a single day when we go for camp surgeries, and typically 2 in a day in our own private setup. This is the bony plate, and in this bony plate, the malleus is almost always incompletely formed, and this is where it is all fused. You have to take this bony plate out. So we thin it first, then use our KTP laser, which we have, char the bone, make it really fragile, and then honestly, if I just blow my air, the bone is going to go away. This is through, we have made the skin pocket. Now we have gone down to the soft tissue, exposed the mastoid region. Here anteriorly is the TM joint, here is the dural plate, the middle fossa. And you always begin with a diamond burr, where very quickly you can go to a cutting burr, and in 5 or 7 minutes reach the critical landmarks. This is the ossicular chain here. This I'm skeletonizing the middle fossa dura. This is use of the KTP for the final parts. The malleus and incus is here, but all around we're getting hemostasis. Then we are going to char this bone. This is a fiber guided KTP. This is the incus. This is the malleus. This was the atretic plate that I showed you. This has been charred. Now with a very thin, fine burr, we are drilling away all around so that there is no bony ankylosis later on as the years go. So you have to create enough, not just simple mobility is enough. There has to be a big gap without violating, of course, the TM joint. And all this we can predict on the CT scan. See, now this ossicular assembly has become mobile. This is just an additional of 20 minutes or so. All the redundant skin now starts to fall. Look how beautiful the concha is. It's gone deep. The shape of the concha, look at the shine there. Otherwise, most microtia will have a very flat concha and it doesn't show. And then they start hearing. And
repair. How many days back? 14 days.
14
Now
days.
she has blocked her left ear completely. Now beta, we have also done hearing improvement surgery. Come back to the side. Dia, are you hearing better now with this ear? With the right ear? You are able to hear the sound much better, no?
Yes.
From before? Yeah. Okay. Good. Very good.
So there are many cases, I think, for like these are patients in Moscow, the Russian ones that we do. This is also about 5 or 7 days post-op.
Okay. Pretty smile, yes. Miri, can you hear better now?
We have an interpreter and they hear very well. Let me not waste time. So in unilateral, this form of hearing improvement is a natural hearing over and above the device. So for unilateral, we will almost always include improving the hearing in one side. For bilaterals, of course, we insist on the implant because the improvement is not to the normal levels. So the ossicles must be drilled. Just drilling a canal for the sake of a canal is not going to give you any hearing. We've almost stopped doing drilling the canal and putting free skin graft because the graft take is very poor on a raw bone. And more importantly, is if the tympanic membrane, because it's a modified skin, if it does not take place, then the mucosa keeps weeping and the child keeps getting ear discharge. That is the reason why we do not. We drill away, of course, much more than what we do. The bone anchored implant, like I said, any implant that is available is good enough. At the age of, the FDA says 5, but we do CT scans even in a 4-year-old, and if the skull is reasonably thick, we go ahead and do the implants way before. Only we make sure that the skin that is then going to come over the framework is not violated. Again, in this we have several protocols for the thickness to make sure where the emissary veins are and be away. So this Google mapping of the precise location of the implant is also very easy. Again, this surgery takes not more than 30 minutes from the time we take the incision because a lot of planning has already happened. This is, I think, an ossia that we fitted for this patient, the cochlear. This was the patient I showed you in that single stage microtia repair along with a bone bridge. Bone bridge takes a little longer because you have to drill the mastoid. You have to sort of compress the sigmoid sinus. But on the table here itself, healing, no problems, no compromise on the vascularity of the skin in spite of such an extensive work in the mastoid. And here it is, the external device that he wears on it. Sometimes when they come early and they want an atresia repair, we've developed a new technique now for several years, of course, it's no longer new. We are using this actually skin over the deformed cartilage. We know now by experience that actually the ossicles are going to be at the junction of the lobule and the deformed cartilage. This is the location. So we take out this cartilage and actually apply, drill away, make a wide canal, mobilize the skin like I showed you, and then we apply suction after removing, and this skin, which is not a free skin graft, this is live skin, goes in and actually lines the canal. So there's no question of any breakdown, there's no question. And at a later point, we have not touched the skin around. The skin that will form the ear has been untouched, so that's the post-oral skin, and this child will get a normal looking canal. And if need be, you can fit a conventional hearing aid. This skin will never break. This is something which we have done. This is about showing you vacuum. Once the thing is over, we apply a mini vac here and it goes down in there. This is one more. Then it needs to be tidied up a little bit. If need be, we put a mold inside. For bilaterals, like I said, a soft band Baha, the trial begins with a hairband they start using at 6 months or a little more when they're a little responsible, or the mother is able to do it. Implant at the age of 5. The approximately 8, or like I said, when the chest is 60 centimeters, do the external ear reconstruction. So the others we will do at the same stage when they come later to us. And atresia repair, along with hearing improvement and microtia, has become our standard protocol now, because we do the CT rib and the CT temporal bone in every case. For those unilateral, those who want an implant, we do not, we sometimes will advise in unilateral cases, we'll do the hearing improvement surgery, but not do the implant at that age in a unilateral case, because we ask them to wait till their hearing requirements becomes more acute. So if it's 10 years down the line that they're going to be in a medical college or a professional college or in a job, we want them to take the benefit of time and therefore technology. Of what 10 years down the line the implants will be, we don't know. So for unilaterals, we don't do implants at the early age. We just do the hearing improvement surgery of mobilizing the ossicular chain and drilling the bone, and do the implant later. So this is what we are talking about. This is the video of the vacuum that I showed you. On the table, this is what we are doing. The skin, in this case also we have drilled. The skin goes in, the trachea starts to look much more beautiful. This is, I've shared this. These are more and more of the videos. Showing everything. That was the tango and this is the Indian. We have a lot of fun in the operation theatre. So this is the birth of a ear in our operation theatre. And this is a fun moment for all of us. Look at the trigger, anti-trigger. This is a drawing made by one of our microtia patients from Karnataka. She was very impressed with the way we were measuring her, and she's got the scissors with the ears there, and 9-year-old child. Now, this is a wonderful saying which I use because I'm in the otology field. I'm a senior in my profession. There's a confession here that there's no complication written in the textbook that I have not had. I have had complete loss of the ear. And if at all, I think the experience that I have about complications, I could write a new chapter in a book about the complications and the misery and the emotional upheavals that one goes through trying to do. Also because there are not too many people that I can discuss with. Of course, now with technology, WhatsApp and all, the world is a small community, but otherwise it's been a very solo ride for the last 15 years, not knowing, and I'm not a plastic surgeon by training. So for me to understand the character and culture of the skin was a very challenging thing. When to intervene, when not to intervene, how thin. So it's been a solo journey, a lot of emotional and egoistic. Many times I felt like giving up, but I did go through. It was a solo journey. Friends around helped.
যদি তোর ডাক শুনে কেউ না আসে তবে একলা চলো রে
No matter if you are alone, just keep going. With the right intentions, always equip yourself. Thank you. This is my contact number. Anybody willing and wanting to partner. For those who wish to see this in Bangalore on May 6th, I am performing 2 live surgeries on May 6th for microtia at this National Facial Plastic thing. I think it's at Ramaiah College, but we keep doing these courses here and there. I like to do live surgeries much more than just talks. So thank you very much. Thank you for having me with you, and I'm happy to answer any questions.
Thank you for your excellent and elaborate paper. We have learned many things from this presentation. I'm sorry.
Sir, namaskar. Myself, Dr. Devesh.
Hello.
Yes. Sir, thank you for a nice presentation. So my question is, how you manage low hairline?
The low hairline is to be managed with the TP flap. The hair-bearing skin has to be excised, and that deficient part, you have to take a TP flap cover the framework with the TP flap, and then put a skin graft. And usually then in such cases, it will be a single stage. So you have to give a bigger projection in the first stage itself. I'm sorry I didn't cover that part because I thought let me go more in details for a simpler case. Yeah.
I due permission of the chairpersons. I am Dr. Chaudhary.
Yes, sir.
Thank you very much. Your presentation was so nice. Almost you was like Harold Gillis with the same degree. You have done your perfection so rightly. So I have a question that in a small kid or a child, can you harvest the catalase from the mother?
No, sir, not yet. I mean, they are working on doing something to make it immunocompetent, but still not yet there is tomorrow. In fact, tonight there's a paper on a cadaver at the World Congress on Pinna. There's a paper, last paper is on the cadaver ear reconstruction. There's some chemical treatment that they have to do. Otherwise, it's not worth, because putting the child on immunosuppressants for life is not a good idea.
Okay. Sir, can I have one question? Because the lobule you're making, or maybe with the Nagata method, it is composed of cartilage also. So in case of a girl child, once he grows, they would like to have the ear piercing for putting on the earrings.
Yeah.
So does the cartilaginous lobule piercing create any problem as per your experience?
So we actually remove, when we are doing the ear piercing, we take a small incision, expose it, and remove the cartilage. And then it's a through and through. So the earring never really touches the cartilage for the potential of it giving trouble. One can also do, and we've done it in sometimes in the primary framework itself, you create a larger hole so that you can do. But there, you then cannot match the right and left side. And girls can be very, very demanding where the level of the earrings are concerned. So we prefer to do typically under local in 10 minutes, you can manage to do it.
Sir, you told that the bronze wire is not available nowadays in India.
Yes.
How do you manage to fix this cartilage nowadays? If it is not available?
Fortunately, sir, I have a large stock with me, which will hopefully last me for another 2 or 3 years. There's a Chinese company now which has come out with a tantalum wire. They also have steel wires. But around the world, people who don't get the B brown wire, they've started using this Chinese wire. Those who don't even get that, because that's not US FDA approved and European, they're using PDS on double. It just takes longer. The precision is that much less, but then people will have their own learning curve if the steel wires go out of business. Nagata himself had his own branded wire in Japan. It was slightly shorter and more expensive, of course.
Thank you. Thank you.
Please discuss regarding the drain you used. Actually, you used special drain. Actually, the vacuum drain you used. Please specify.
I went through that curve of trying to source the best drain in the world, and I realized that I was a poor plastic surgeon, not knowing how to handle the skin, and I was blaming the drain. Now we use the standard Romovac. Absolutely standard Romovac. There's nothing really. It's really managing the skin. And the drain, I went to Stanford to watch somebody, and my God, for him, there was such a high sophisticated suction, and the boss would scream at his residents for not following the protocol of how many minutes to put it on, put it off. I think it's all not necessary. A simple Romovac is fine.
Sir, which size? Actually, you do a large skin pocket. I have observed you have to use large skin pocket. Actually, I have never seen anybody has done such a large skin. So what is the drain size, sir?
The drain size, I think it's 10. The smallest that you get in the Romovac, the smallest, I think it's 10. I forgot what size I use. I can ask. The smallest in the Romovac, not the Minivac. So I don't put the drain under the framework. Most Europeans have these flat silicone drains which are expensive. I did get them, but now I make a large because I put it around the framework. And I put it a few millimeters or a centimeter beyond the framework so that the skin is sucked in deeply. And I put only one drain. Most ear surgeons put two drains, one in the concha and one around or one under. But
hello, Dr. Ashish. This is
yes,
Dr.
sir.
Vibhuti. I
Ah,
talked
yes,
to
sir.
you. Yeah, yeah.
Yes, yes, sir.
It was, watching a master craftsman doing ear reconstruction.
Thank you.
You have actually compounded our problem by doing the ossicular chain release and creating a concha. So now I wonder whether we should really do ear reconstruction.
No,
It will
sir,
just take some work.
get your ENT to come in and just drill it. So it's very simple. Any otologist can drill. It's not
No,
a
it was
problem.
an excellent result, excellent presentation, and everything was so well demonstrated.
Thank you, sir. Thank you.
Thank you so much.
So
Thank you
please,
so much.
please keep some case. I'll come free of cost to your center and do it. It's my mission to do whatever, wherever we can.
No, I am promising you, you'll be here in Odisha in next couple of months. We will have a couple of
Most
cases ready
definitely.
for
Very,
you.
very happy.
Okay, but you get your brawn wear with you.
Yes, of course. Yes, of course. Yeah.
Sir, I want to say that actually another company in India, actually Amrita Institute, they are using also that ware, sir. That ware is available in South Indian company. Those are making
Yes,
the lens
yes,
and
yes, yes.
so I have also buy at least 1 or 2 pieces from them from Delhi.
Yes.
Rather than it has finished up.
Sorry, I forgot. I've used it in
Yes,
one of
yes,
the workshops.
that is prepared in India, sir. I know.
Yeah.
I have also buy that. Thank you, sir.
I
Nice
think it's a
presentation.
much longer wire also, so you can have more
Yes,
number
yes.
of sutures. Yeah.
Sir, we are doing 3, 4, 5 suturing in a
Sutures
single.
with that. Yeah, yeah. I used it only once. I'm sorry, I forgot about that.
Sir, I have used twice or thrice. Thank you, sir. Thank you very much.
Thank you
It's a
very much.
nice
Thank you.
presentation. Nice
Thank
to
you,
be here,
and
and
thank
you
you.
have
Thank you
spent
for
lots of time.
Thank you for
And,
having me there.
sir, you are going to now the international conference is going on. Still, you
Yes.
have got the time.
Yes.
Thank you very much, sir.
5:30 it begins. Thank you so much. Thank you. Thank you. Thank you, sir.
Hello. I wholeheartedly thank all the speakers and our chairpersons for conducting the session very smoothly. Now I'd like to request Dr. S.K. Giri and Dr. Satyabrata Rautre to conduct the next part, that is First Professional Another Prashad Patnaik Memorial Quiz. I invite them. Thank you, sir.
Slide. Good afternoon, everybody. As you know, Another sir is our beloved teacher, and sadly we missed him. So on behalf of his memorial, so this is the first time we have started this first Professor Another Prasad Memorial quiz for our residents, because he is very fond of teaching to all our residents. So on his behalf of his sad demise, we have started this one, and we have also, the organizing committee has decided this there will be a running shield, and which will go on every year to the winner team. So basically we have 12 residents, each 6 from the AIMS and 6 from SC Medical College. So 12 members has been divided into 2 teams each. They have given their names. So I would request and there are also a lot of exciting prizes for the audience. So I would request all of you to stay in the hall, and we'll make it, the first one will make it success. So I would request all the team members, each by each. Dr. Satya is there or not? Satya, you just sit. Sir and Arun sir has agreed to be the quiz master. If any problem occurs, he is the solve man. Anyway, the Satya sir, what we will do now, these 12 members, they have been divided into 2 teams. So I would request each of the one member will come and pick one of the, we have made checks, so they will pick it up,
and the group, whatever it will come out, they will sit in down. Make छोटा chair नहीं है sir. नहीं ना टीम डिक्लेयर ही है सर रेड कलर चेयर नहीं है Singer, Das, and another is Avinash Jivitesh, another is Amitav and Isan. These three teams are from SCV. Teams from AMC is Akankhya Gopika, Kausik Ahana, and Priyanka and Vishnu. So what we have done now, there are 6 cheats are there. So groups has not been allotted. So whatever you will pick it out, that will be your group. Satya, so yeah. One from each team come and take it. One. Go. Satya is our scorer. I would request all of you to sit, please. Rosaline and Ved and everybody, please sit. And I think there are a lot of prizes for audience, and I hope all the audience prizes will be finished. It is there, right? It is there, it is there, it is there. Don't write. It is there. Just I think we should give a big clap to Amit sir, because he has made this running field first time, which will be start from this year. Thank you, sir, for giving this opportunity and also making this field for our another sir. Another sir na कहली sir तांको पे करछन दिबे sir. Ramesh sir has done. Our president already told sir. Satya will tell now the teams. I think everybody has picked up the cheats and teams has been allotted.
I think Tanmay and Rusinga is group C, Avinash Jivitesh is group F, Amitav and Isan is group A, Kausik and Ahana is group D, Gopika and Akanksha is group E, and Priyanka and Vishnu is group B.
So we will do like this: A, B, C, D, E, F. So accordingly, who has got this way, do you change it? So you change it accordingly. So all of you have got according to your cheats. You have taken all your positions accordingly your cheats. Yes or no? Yeah.
Group A is here, group B here, group C, D, E and F.
So all the best to everybody. Before starting, I would like that Satya will be our scorer, and I would like that all the participants will introduce to all our esteemed members present in the hall. So in hall A, just a brief introduction.
Hello. Good afternoon, everyone. So I'm Dr. Ishan Agnihotri, and I'm first year now MCH resident in SCB Medical College.
Good afternoon, Arun sir. Good afternoon, Giri sir. Myself, Dr. Amitav Das, and third year MCH resident in SCB. Thank you.
Good afternoon, everyone. I am Dr. Priyanka Pant, first year MCH resident in AIMS Bhubaneswar.
Good afternoon, everyone. This is Dr. Vishnu, first year MCH resident, AIMS Bhubaneswar.
Good afternoon, everyone. I am Dr. Tanmay Mahapatra, final year resident in SC Medical College. Thank you.
Good afternoon, respected sirs. Myself, Dr. Nrsinga Das, second year resident, SCB Medical College.
Good afternoon, everyone. I'm Dr. Kaushik Madik, for second year MCH resident at AIIMS Bhubaneswar.
Good afternoon. I'm Dr. Rahana Bandyopadhyay, first year resident in AIIMS Bhubaneswar.
Good afternoon, sir. I am Dr. Akanksha from AIIMS Bhubaneswar, first year resident.
Dr. Gopika Jait from AIIMS Bhubaneswar.
Myself, Dr. Avinash Sahu, third year MCH, SCB Medical College.
Hello, sir. Myself, Dr. Jigitesh Kumar Behera, second year SCP MCH.
So scorer Satya, you are ready, and groups are accordingly you have made it A, B, C, D, E, F, and you have written the names. So I'll just tell the rules. There is 9 rounds. 9 rounds in the. Question 9 rounds, and in each round, these are all multiple choices. There will be no passing round, no passing, and always the first question will from A, then second round will from the. For second round, the question will first start from B. Third round, it will be C. Like this, it will go on in all the rounds. Starting point will change. And 10th round is the rapid question, where it will be 1 minute. You will answer as much as questions and you will get the marks. All questions will be 10 marks. Nothing, no pass, nothing. And in each round, there will be audience questions and audience will get the prizes. So what is this? And rapid round, any doubt, anything you can ask. No passing, no passing. Rapid round, 10 marks, all are 10 marks, all are 10 marks, because they have to answer. And for each question, it is 10 seconds, 10 seconds. Yeah. So time will be looked after by Satya. No negative, nothing, no negative. Actually, no negative. No, this will be done in the next year, because many of the why it has happened, many residents are first year. Usually in all the questions, usually in all rounds, in all the quizzes, there should not be multiple choices. So as you all have not gone deep, so that is why I have decided this time multiple. Next time there will be no, you have to directly answer the question. That is the basic of the quiz. But as most of the students are first year, so that is why multiple choices has been and no pass round is there. So we'll start. All the best to all the groups. So we'll start. So the first round is first round is on the, all the rounds are in different topics. So it is on the general principles. Yeah. So first question will go to the group A. The first successful human skin graft for covering the stump of an amputated thumb with skin from the amputated part was performed by which of the following?
It's A, Rewarding.
Yeah. Yeah. One minute. No, sorry, it is wrong. It is wrong. Sorry. Just tell me, anybody knows from, yeah, it is Ashley Cooper. Yeah. Cooper. Sorry, it is Ashley Cooper. So Ashley Cooper was successful before the first human skin graft. Rewarding was the actually, he was famous for the partial thickness graft. Yeah. And he was done it in 1871, Thias graft. So it is wrong. Satya, it is wrong. Eh?
Okay.
Where is the prizes? वो chocolates था क्या? It. हाँ it is. अच्छे. Yes. Sorry, actually, for them. Second. So, Satya, just see the time. Eh? Which one of the following plastic surgeons won the Nobel Prize for his work?
D. Joseph Morley.
Yeah, it's right. Joseph Morley. It's group B, yeah. Because for what he has got the Nobel Prize? Can anyone? Yeah, renal transplant. For renal transplant, he has got it. Year I also don't know. Do you know? Huh? 1958. Yes. Give one chocolate to Rosalind. Rosalind, give one chocolate. Yeah. So 10 marks to group B. Yeah. Then we'll go to the third round. The third question. Who introduced the technique of fast placing triangulating switches to ensure equal traction on the blood vessels at the time of microvascular anastomosis?
Carroll.
Yes. It's Carroll. Correct. Questions are very easy. I think everybody can score. So next to group D, which of the following is credited with the first use of an expansile implant of a latex balloon to enlarge the periauricular skin for traumatic ear deformity? Yeah, very easy. Don't whisper.
C. Newman.
Yeah, it's Newman. So I think all should clap if we are getting right answer. So it's Newman. So this is 4. Group D answer. Next to group E. Which of the following is considered the father of fetal surgery? Fetal surgery.
C. Lilly.
Yeah, right. It's Lilly. Because Sushruta is father of plastic surgery. Lister is father of modern surgery. And Gillis is father of modern plastic surgery. And Joseph is father of rhinoplasty. So Lilly is the father of it. So to group E, it is 10. Rhinoplasty. So now to the last question of this round. Colloids are commonly used for restoration of intravascular volume and oncotic pressure in burns. Which one of the following resuscitation formula advocates the use of colloids on day 1? On day 1. Just read the question and the answer is within the question.
Modified Brook. Modified Brook.
No. Brooks formula actually. This is most Brooks formula. Sixth answer is A. Because Brooks formula is used in the colloid on the day 1. On the day 1 it is Brooks. Then after that all those formulas are after that only.
Brooks and Evans.
Yeah. On the day 1. So group E has not scored. I think it is not 0.
Group F has not scored and group
Oh, just 1 minute. Just 1 minute. Just 1 minute. So the last question is for the audience. It is like this. Sliding bar in double clamp used in the microvascular surgery developed by which of the following? Which one of the following? No. It is Tamai. It's Tamai. No one has answered. No one has answered. Tamai. It's Tamai. So I think sliding bar. Yeah. Sir. So I think round 1 is finished. After that, the score will be declared by Dr. Satya.
Hello. Group A has not scored. Group B, C, D, E each have 10 marks, and Group F has not scored.
So it's good going, and I hope Group A and Group F will score in the second round sure. So we'll go to the second round. The second round is there will be some personality figure and you have to identify. There will be no choices. Yeah. And there is no passing, no passing. And this time it will start from group B. Satya. Yeah. Group B. Satya, you just look after this. Huh? After group B. Who is this person? Who is this person? In this, there is no choice. Who is this person? Hints. This is a what we are using for gender. That is some plastic like this. Yes, McIndle. But chalo, McIndle. It's McIndle. McIndle. Little bit of difficult. Anyway, take it. So this is for group C. Group C. It's a very easy. Oh, don't tell. Please let them answer.
And
10 seconds, huh? Just see.
see something in the background.
It's 10 seconds past.
Yes, past.
So anybody can tell. It's in the background. Already Satya has told. Anybody? Now just we have seen these cases by Ashish Bhumikar sir. No, Nagata. He is not Nagata. He is Brent. So you all have to know all these peoples. So that is the basic aim of this group. This round is that these are all famous personalities. So you have to know. Yeah. Next to D. Please, audience, please don't whisper. Don't whisper. After that, you will get it. Group D.
Nagata.
It's Nagata. They are very easy. They actually, he has shown the picture. They are lucky, I think. It's Nagata. Group D it is 10. Actually, Ashish sir has shown in the next slide. That is why they got it. Anyway, so next is for group E. Just see.
Sir,
These are 10 seconds.
I think 10 seconds past.
Audience can tell it. Huh? Gillies, it is not Gillies. Gillies.
Lister, sir.
No, not Lister. It's fractures, different fractures we are using. Leaford. He is Leaford.
Paul Tessier.
Yes. All right. Very good. Tessier. Very good. This is for group A. Eh? Don't whisper, please, because this is yeah. Yes, see, very famous. We are doing every day. 10 seconds. Then I will give the hint.
Yes.
We are doing smile train. What? Yeah, Millard Junior. Yes. Yeah. Chocolate. Sarle secretary Bujivo. So this last question is for the audience. Just see. I think anybody can tell this one. Audience. Already group is. Gillies. Lakshmi sir has told it is Gillies.
No. You tell the full name.
Yes. He is Gillies. Who was telling Gillies? He is the Gillies. So So with this, we completed 2 rounds. Round 2 completed. I think Satya will tell the score.
Group basically, what is his professional qualification?
Yes, CNT sir.
Should I tell the score?
Yes, yes. it will.
Group A has not scored. Group B 10 marks. Group C 10 marks. Group D 20. Group E 10 marks. Group F 10 marks.
So Group D is leading with 20 marks, and I hope in the next rounds all will score. All will score. So we'll go to the third round. Third round is completely on aesthetics. So this is for Group C, the C sir. Which is the sensory nerve most commonly injured the right auditomy? Do you know what is right auditomy?
Great auricular nerve.
Yes, great auricular nerve. Great auricular nerve. Right. It is the most sensory nerve which is mostly at. But the question is sensory nerve, na? So the great auricular nerve.
What is the innervation area?
What Dr. Bala is telling, if the question will be asked on motor nerve, then it would have been buccal branch of facial nerve. As it has been asked sensory nerve, so it is great auricular nerve. So give full marks to the Group C. Yeah. Then second question to the Group D. This C. Provisionally healthy nasal lining is essential for nose reconstruction. Which one of the following flap options for nasal lining is usually based on the scar tissue? Contralateral septal flap, ipsilateral septal flap, bipedical lining flap, turnover flap, nasolabial flap.
Nasolabial.
No, it's wrong. Turnover flap. The name is suggesting turnover. Actually, scar tissue, they are first year, that is anyway. Turnover flap. No, turnover flap. So, writing here, turnover flap. The next question is to the Group B. So, a patient has having a breeze hair between the frontal and the occipital baldness, as per the Norwood classification, will be classified into which of the following type? 1, 2, 3, 4, 5. Which one?
D, so 4.
What?
D. D.
Type 4. Yes, it is type 4.
So it is correct.
It is correct. Correct. It is correct. The double chin can be reliable. This is for the Group F. The double chin can be reliable treated using a submental incision, and this incision should be given at which of the following location? Along the submental crease, posterior to submental crease, anterior to submental, and any of the above.
Posterior to the submental.
Yes, it is right. Posterior to the submental crease. Posterior to the submental crease. It's right. Because it prevents accentuation of this double chin only by giving the incision posteriorly. The next question to the Group A. Which type of graft should be used to improve the shape of the nasal tip? Straught graft, batten graft, spreader graft, seal graft. Don't whisper, don't whisper.
Spreader graft?
No, wrong. Yes, it is seal graft. Seal graft. Seal graft. Because spread graft is used for longitudinal. So spread graft is actually longitudinal. Just listen. Spread graft is longitudinal piece placed in between the place cartilage, whereas the septum is between the ear. But Straught graft is for the support of the columella, and batten graft is for the side of the ala. Ala is for batten graft. So that is why it is a seal graft for the spreading. This augmentation for it is used. Group B, na? The nose is divided into separate zones based on the texture, subcutaneous fat, and sebaceous gland content. The nose tip falls majorly in which one of the following zones? 1, 2, 3, 4, 5. Nose tip.
C3.
No. It's B. Zone 2. Because zone 1 is upper dorsum and 3 zones. Still. ठीक है है ना what is zone 1 zone 2 zone 3 can anybody tell zone 1 is alar dorsum and zone 2 is tip zone 3 no zone 3 is 4 centimeter along the alar margin that is zone 3 so this is about so just one audience question is there which teeth in the maxilla and the mandible help in defining the time of malocclusion very so don't give anybody, it is everybody else told. So we completed 3 rounds and I will request Dr. Satya to row.
Hello. After completion of the 3 rounds, group team A has not scored, team B 10 marks, team C 20, team D 20, team E 20, team F also 20.
Oh, so good competition, huh? ठीक. So next round is on head and neck. So this is for the group D. Which one of the following is the weakest area of the mandible and shows the highest incidence of fractures?
Coronoid process.
Neck is the neck. Wrong. It's wrong. Neck of the mandible is the weakest area. But it is given neck of the. We'll go to the E. Satya, E. Satya ready, eh? E. Question for E. Which one of the following should select to manage a depressed fracture of the zygomatic arch? Yes.
A. Gillies.
Gillies approach. Please don't whisper. Last. Yeah. Huh? All right. This is correct. F ready? Which one of the following part of the mandible is directly implicated in causing restricted mouth opening in zygomatic fractures?
Coronoid.
It's coronoid process. It's all right. Coronoid process. Because the coronoid process is intrinsically related to the body of the zygoma, so that is why during the time of A it helps. So now we will go to group. Then it is group A. I think group A has not scored yet, na? I hope this time they will score. All of the following are complications of untreated maxillar fractures, except which one of the following? Very easy.
Non-union.
False. Wrong. Yeah, hypoplasia. You just see the choices. Fracture it is there, na? So it is a very. If you see, all are complications. Hypoplasia is never a complication of fractures. Yeah. So then to group B ready. Which one of the following is the flap of choice for central full thickness defects of the upper lip? Upper lip. Central full thickness defect of the upper lip. Abe flap. Or correct. Abe flap is for the upper lip. Slender flap is for transposition flap from the upper lip and is used for the defects of the lateral defects, lateral lower third defects. Philtrum, yeah. Gillies fan flap for the, it is an extension of the slender flap. And Karapanji is the lower lip. That's all. So, who has given the answer? Yes, it's all right.
Next answer question will be to group C.
Group C ready? Which one of the following is the flap of choice for reconstructing lower lip defects up to the 2/3 of the lower lip?
Appendage.
No. it is written lower lip defects up to 2/3 of the lower lip. So this is Suchar's procedure. Wrong. Yeah. So I think we completed 4 rounds. Huh? So 4 rounds completed, and so the audience question: strongest bone of the face, which is one of the following? Strongest bone. No, it's not mandible. Frontal bone. It's frontal bone. It's frontal bone. Mandible is not the strongest. Frontal bone is the. Okay. So we completed 4 rounds. After 4 rounds, please tell the scores.
After 4 rounds, Group A has not scored. Group B 20 marks, Group C 20 marks, Group D 20 marks, Group E 30 marks, and Group F 30 marks.
So what? Who is the leading?
E and F are leading with 30 marks.
E and F. Group A has scored or not?
Group A has not scored.
So this time you score, eh? This is 5th round. It is totally on the craniofacial and cleft. So we will start this round from Group E. Group E, your first question. Which one of the following muscle does not participate in VPI, velopharyngeal function, during speech production? It's very easy. Tensor veli palati, levator veli palatini, palatopharyngeal, superior constructor, palatoglossus.
So D.
Yes, it is right. D, superior constructor. All muscles are of the muscles of palate. So only superior constructor is the muscle of pharynx. Then we'll go to the group F. So E and F are scored equal. So many classifications have been proposed for the clefts, taking into consideration various themes. So which one of the following classification system is based on the evaluation of cephalometric radiographs? Cephalometric radiographs. It is there in the classification. It is there in the classification of it. 10 seconds over.
E.
No, not C. One man. Answer. Tell me what. It is Lassal. Structure involved, but it is radiological. It has been given. Next. Group A. Which of the following may be Group A? Which of the following may be present in craniofacial microsomia in addition to the characteristic finding observed in the ear, mandible, and maxilla?
All of the above.
Right? All of the above. No, it may be confused. There is no problem. Correct. It's correct. Group A has scored. Which one of the following authors has described a cartilage graft to lengthen the short medial cross? It is little difficult for you.
D.
D. No, it's not. It is cronin. Wrong. So next question to the C. Ready? The humor flap is commonly used for the closure of the nasal lining in the repair of the cleft palate. So which one of the following structure needs to be incised for raising this flap? Easy. It's very easy. Over.
10 seconds.
This is septum. Last question to Group B. Group D. Ready? Secondary deformities of the cleft lip and palate are common. The whistle deformity refers to which of the following? Whistle deformity.
Sir, C, vermilion.
Yes, correct. Vermilion. Vermilion. Because vermilion, notching of the vermilion, that is why this happened. Huh? Audience question, last one. Which of the following is the correct option? Describe the type of relation in a cleft patient with posterior cross bite in the primary dentition phase. Teeth relationship in a cleft patient with posterior cross bite. With posterior cross bite. Yes, labial displacement. Who is telling it? Labial displacement. Labial displacement is our anxiety. Labial displacement. So we finish the 5 rounds, na? So just it's the halfway of the quiz. So let us see who is the leading.
So Group A has scored 10 marks, Group B 20, Group C 20, Group D 30, Group E with 40 marks, Group F with 30 marks. So Group E is leading with 40 marks.
So now we'll move to the 6th round. 6th round. This will start from the Group F.
Yes.
So this is 6th round, Group F. Ready, Group F? This is totally oncoplastic surgery, this group, this round. So the Piquet Fence arrangement of the nuclei in the peripheral layer around the tumor on histological examination is characteristic of which one of the following lesions? Piquet Fence, Piquet Fence. Piquet Fence. Over?
E.
No, E is wrong. Anybody can tell from basal cell carcinoma. Because basal cell carcinoma has this typical features in histological. Then we'll go on to group A. Ready? Group A. The reported recurrence rate of the basal cell carcinoma after 5 years maximum in which of the following site? Which following the site? Maximum recurrence. Maximum recurrence. Maximum recurrence.
Nasolabial.
Here. बहुत तो सोरा पढ़े सब zero not answer. No, boy, it is all right. Here, good, very good. Boys, death rate is also highest. Death rate is highest, right? So next question to Group B. Group B, ready? The Paget's disease originates from the nipple and areola. It's clinically characterized by which of the following features? Paget's disease. Paget's nipple and areola.
Eczema.
No, wrong. Paget's disease, P for P, pigmentation. Yes, pigmentation. Then Group C. Group C, ready? Which one of the following classification system of melanoma is based on the micrometer reading regarding the depth? Micrometer reading. Micrometer.
Breslow.
Is correct. Actually, Breslow's is micrometer. Clark's in the depth of involvement. If depth of involvement would have been asked, it is Clark's. And clinical classification mostly in the extent of the spread of the tumor. So it's right. Group C is correct. Then this is for Group D. Ready? So Marjolin ulcer occurs in unstable burn scar. Which one of the following is not a feature of Marjolin ulcer? Very easy.
E, lymphadenopathy.
Yes. Marjolin ulcer has no lymphadenopathy spread. All right, good. Full mark to the. Next,
Group E.
Which one of the following neck incisions for radical dissection gives a wide exposure with less morbidity? With less morbidity.
So C.
Hmm?
C.
No, it's not C. Double opposing nerve. It is posterior neck incision. Posterior neck incision. Double opposing is exposed to dissect and provide excellent support, but lesser morbidity is always in the posterior neck incision. Yeah, neck incision. Finish na? Sixth round end. So the audience question is this one. Keratoacanthoma is a tumor which is commonly in seen in the sun-exposed areas of the light-skinned older individual. It arises from which of the following? 7. Keratinocytes, melanocytes, hair follicles, epidermal cells, Merkel cell. No, it is not keratinocytes. It is hair follicles. It is hair follicle. It is from hair follicle. Never it arises keratinocytes. They are typical features, keratinocytes, but not origin. Origin is from hair. Question is from origin, where it is hair follicles. So 7 round is
Sixth rounds are
sixth round
over.
over. Huh?
And Group A has scored 10 marks, Group B 20 marks, Group C 30, Group D 40 marks, Group E also 40 marks, Group F 30 marks.
So there is a competition between
yes, D and E, with each having 40 marks.
D and E.
Yes.
C is how much?
C 30 marks.
And F?
F also 30 marks.
Achha, ठीक है तो. So it's a good competition between C, D, E, F. So we'll go to the next round, 7th round. Start with A. And the whole round is in trunk and lower extremity. So this is for Group A. Which one of the following best measures the compliance of the soft tissue envelope of the breast for deciding implant placement? Which one of the following best measures the compliance of the soft tissue envelope of the breast for deciding implant placement?
10 seconds pass.
No, not E. Yeah. Pinch test. Because pinch test is the compliance and elasticity of the breast to skin and supple of the breast pins between the thumb and palm to know the compliance so that you can use decide the implantment placement. This is pinch. So no score to the Group A. Ptosis of the breast is commonly classified on the basis of position of the nipple in relation to which of the following? Ptosis.
Inframammary is B.
It's right. Inframammary. Correct. Inframammary. Ptosis is always inframammary.
Then to Group C.
C, yeah? C ready? Which one of the following liposuction procedure causes least disruption of the vasculature? Least disruption of the vasculature.
Ultrasonic.
Ultrasound. Right. It is ultrasound. It is not power assisted or it is not suction assisted. It is ultrasound. Right. Very good. This is a good one. Yeah.
10 marks to Group C.
Group C. Next. Ready? Group D. Rupture of the breast implant can be best diagnosed by which of the following method? Sudden onset of burning breast pain, detection of a mass removed from the implant, mammography, ultrasound, MRI. Which one?
E, MRI.
MRI. MRI. All right. Right. Good. Implant, the rupture of the implant is always by MRI.
Then to Group E.
Group E ready? Which of the following is not corrected by abdominoplasty? Which of the following is not corrected by abdominoplasty? Skin wrinkling, skin excess, stretch marks, muscle laxity, all of the above.
So C.
Yes, right. Stretch marks. Stretch marks is never done by this abdominoplasty. It's more prominent. Body gas So Group C. Which one of the following pressures are typically present with minimal skin involvement and extensive bursa information. No, it's not. No, not is here. Trochantery. Hello? 0 mark. So audience question. Which one of the following muscle is unsuitable as a flap for chest wall reconstruction? Sternocleidomastoid. Moyes has to. 7. 7 Salah.
Group 7, round 7 is over. Group A has secured 10 marks, Group B 30 marks, Group C 40 marks, Group D 50 marks, and Group E also 50 marks. Group F 30 marks. So D and E equal with 50 marks.
So this is the 8th round. Group B. There are 10 rounds. So
Now you try to make up. Huh?
yeah. So this is all about upper limb. 5 annular and 3 cruciate pulleys hold the flexor tendon in contact with the bones and joints. So which one of the following annular pulley from the longest tunnel?
So B, A2.
A2 pulley. Right, A2 pulley. Group B. Just tell A2, A4 where it is present. A2 pulley is present in the proximal half. You are not answering, sir. Azhar is asking.
Dropping won't work.
Then A4 pulley is present in the middle phalanx. So Group C. This is the dorsal retinaculum lies about the extensor tendon in which one of the following zone? Dorsal retinaculum.
7.
Right. 7. 1, 2, 3, 4. Just tell. Where is 1? Where is 2? DIP. 1. Yeah. 3. 6 and dorsolatus. Right. Group D. Ready? In a case of sprained wrist, tenderness over this knock box is due to injury to which one of the following structure? Which one of the following structure?
A scaphoid.
Yes, it is right. Scaphoid. Scaphoid. Because scaphoid is the person where you will get it. Yeah, next. 4. Which one of the following nerve can be provided a 40 centimeter nerve graft? 40 centimeter long nerve graft.
So D. D.
Yes, it is D. Saphenous nerve. Saphenous nerve. D. Group A is ready. Which one of the following tendon is transferred during the great toe transfer? Tendon is not transferred during the great toe, not transferred.
C. Extensor hallucis brevis.
No. Flexor hallucis brevis. Flexor. Flexor hallucis. All extensor and all is gone. Last question. I think Group A will answer this one. Finkelstein test is used for testing which of the following tendons of the dorsal compartment? Finkelstein.
Second.
Fast. Can anybody tell what is Finkelstein then? Huh? Recurrence disease. Yes, recurrence disease. Recurrence disease. What is recurrence disease? Fast. So 8th round is finished. This is the question for the audience. The functional integrity of the radial, median, and No, not in the index. Not in index. It's thumb. Thumb, it's thumb. Because thumb by all these extension by the radial nerve, abduction by the medial nerve, and adduction by the ulnar nerve. So thumb is the case where the integrity of all these they are there. No, it's thumb. How it is index? Tell. Medial, and all these are not by thumb only, because this is the only where all the muscles is covered, all the three nerves. So it is thumb. It is thumb. Yeah. So 7 over. Just tell the.
Hello. After 8th round, Group A has scored 10 marks. Group B has 40 marks. Group C has 50 marks. Group D has 60 marks. Group E has 60 marks also. And Group F has 30 marks.
So there is a top competition.
There is a tie between Group D and E.
Yes.
Each having 60 marks.
60 marks. And Group C?
Group C having 50 marks.
50 marks. All right. So then we'll go to the round 9. This is all recent advances. Group C. So peripheral nerves are prone to compression of multiple places. Which one of the following nerve has the least number of possible sites for developing a compression event? Least. Least number of possible sites. It's median nerve. Least. Least number. Yeah. Then which of the following is not a feature of simple type of Poland syndrome? Yeah, simple type of Poland syndrome.
E.
The answer is
E, abnormal.
It's not E. It's abnormal, deformed hemithorax. It's abnormal. It's not deformed. So answer will be C. Yeah. All right. Next to
Group E.
So the temporomandibular joint injuries in children are commonly intracapsular in nature due to which one of the following factor? Following factor.
So B.
It's B, anatomical consideration. Because in children the neck of the mandible is broad. So that is why. Flap monitoring is an essential post-operative part of plastic surgery. So which one of the following flap monitoring method is the most reliable? Which one of the following flap monitoring method is most reliable?
Infrared spectroscopy?
No. Yeah, it's laser Doppler. Laser Doppler.
But clinically, which is more clinically, which one is better?
Clinical. Color.
Or scratching?
This is for Group A. You must be knowing face transplant. So the first full face allotransplant was performed by plastic surgeon. Belong to which of the following?
France.
Yes, right. France. Correct answer.
Then to Group B.
French first allotransplant, and you must know that they have before this allotransplant, they have tried it in 33 cadavers. Then after that, they have tried to do it.
And these allotransplants were done in which case? What was the case where these allotransplantation was done? Postborn. Postborn lady. Unfortunately, 8 months back she has died.
Fireman. No. France.
That lady was postborn.
Last question, I think it is.
Group B.
It is the last question for
Yes,
this
last
round.
question of this round.
So that which we have discussed, the first full face transplant patient died within 2 months of surgery due to which of the following complication?
E.
Huh?
E.
Infection. It is infection. Infection.
They have answered wrongly.
Wrong. Infection. It is due to the pseudomonas infection. They have patient died. No, there is no audience question. So we will go to the rapid round. I think all 9 rounds have been finished. After this, just this course. So we can take a small break, just 2 minutes.
So
Just tell the
after
marks.
9 rounds, the Group A has scored 20 marks. Group B has 40 marks. Group C has 50 marks. Group D has 60 marks. Group E has 70 marks. And Group F has 30 marks. So Group E is leading.
So Group E is leading. Break 2 minutes. So this is a rapid round. Mark system is we have given 1 minute. In 1 minute, as many answer you will tell. There will be no multiple. You have to answer the question. As many answer you will tell, you will get into 10. That means there are. Yeah, this will be deciding because there is no multiple choice. They will get it. And maximum time is 1 minute. 1 minute is maximum. In between 1 minute, as many answer you tell. Otherwise, if you are not able to do it, just tell pass.
No prompting from the audience.
So no, don't because this is a vital round. With this round, anybody can lead. Yeah. So we'll start this one from because we have finished with C.
Last round was started with C. So this round we can start with D.
D. See round add करो see आरो round आरो ये टा अच्छा खोलो इटा खोलो. So Group D, you ready? Just 1 minute. Keep. First round, first. Group A लेके जाइए. Group that is for we'll go start with group. Group. Ready, Group D? Ready? Start.
We start with Group D.
The word endoscope is derived from which language?
Latin.
No. It is Greek. The deformity of crow's feet is located in which region?
Lateral region of eyebrow. Eyebrow. Lateral.
Eyebrow, periorbicular region. Right. This is right. One right. Third. Which is the single base plane X-ray view to evaluate the fracture of the zygoma?
Waters view.
Yeah. Right. Waters view. Double ring sign in nasoethmoidal orbit injury is useful in the diagnosis of
CSF rhinorrhea.
CSF rhinorrhea. Hemangiomas occur most commonly in which region?
Face. Face.
Craniofacial.
Face.
Right.
Right.
Right. Peroneus disease is characteristic of by the formation of fibrous nodule in which layer? Which layer? Tunica albuginea, right?
Stop 1 minute. So they have corrected 5 questions.
Hello.
3 plus 2, 5 questions they have corrected.
1, 2, 3, 4, 5. They have answered 5 questions.
5 questions.
10. This can be for the audience. MRI though will not give. It is MRI. This gummy smile is a condition where when more than 2 millimeters of the gums get exposed during the smiling. It can be treated by which method? Can I know? No. Gummy, that is the Leafort one. Leafort one osteotomy. So group we have finished with Group D.
Group E. We'll go to Group E.
Group E. Group B color. So group D has scored previous you have added 50 marks. Yes. So group E ready? E. So group E ready? Yeah. No. Just one. Ashwini kai? Take Ashwini. Epidermolysis bullosa is a condition characterized by epidermolysis bullosa. Blister. Dark brown skin falls in which type of cliff glass classification?
Sir, type 5.
Type 5, right. The blow-in fracture of the orbit may be observed in which of the following diagrams?
Inferior orbital floor.
Yes, inferior orbital floor. In the functional neck dissection, which structure is preserved?
IJV, SCM, and spinal accessory nerve.
Spinal accessory, sternocleidomastoid,
IJV.
Yeah, all right. Right, give it marks. Which modality has the highest diagnostic accuracy for breast imaging?
No, MRI.
Yes, right. Tissue expansion was first reported by
Newman.
This is repeated again. Cubital tunnel syndrome is compression of which of the following nerve?
Median nerve.
No. Cubital is ulnar. Yeah.
They have also scored corrected 5 questions. So 50 marks to the group B.
2, 3, 4, 5. 5 questions. They have answered 5 questions. Group F. Achi. F pe kada F pe. Ready? तुम भलो की करो तुम F ready? ହେଲା କଣ ହେଲା କୋଟା सर न्यूमेंट ସେଇଟା सर ଥିଲା एक्स्ट्रा क्वेश्चन दरकार पड़लानी Group F ready? Biological dressings are commonly used in burns as they are relatively abundant and inexpensive. Which biological dressing composed of acellular human dermis?
Integra.
It is alloderm. Next, alpha tocopherol is the biological active form of which vitamin?
A.
Vitamin E. Wrong. Which abnormality causes diplopia in zygomatic fractures? Zygomatic fractures. You can pass. Muscular abnormality. The classical neck dissection removes which structures? Classical neck dissection. Classical.
Pass.
Sternocleidomastoid, spinal accessory, internal jugular. All those it is easy. The skate flap. Skate flap is reconstruction of the
nipple.
Yes, right. Which type of complication may be observed while using the breast implant?
Extrusion.
No, you have to tell what infection that you have to. Anyway, give them. This is the process of establishment of blood supply to the graft. Skin torn days. What is the term?
Inosculation.
Inosculation, right? Which method?
They have corrected 3 questions.
3 questions. Which method is the most suitable for reconstructing a nipple for optimal result? Audience. A diamond separate flap it has been given. I also don't know. So leave. Next we will go to Group A. Hey, the best. Don't tell. It's a vital. Ready? Reorientation of stars can be achieved by jet plasty. 60% jet plasty would increase the length of 2 endpoint star by what percent? All right. Then the angle SNB is an important parameter for analysis of the mandible. Its normal range in men and women is
110.
Don't tell. Wrong. This is wrong.
Next.
Don't tell. Please don't whisper. Which teeth is the maxilla and the mandible help in defining malocclusion?
First molar.
Wrong. First was mask molar.
First molar.
Give it. The scalp has 5 layers. Which is the most plane of avulsion of the scalp?
Galia.
Areolar tissue.
No, wrong. It's loose areolar tissue.
Sir, loose areolar tissue bola to.
He has told. Then right. Make it. Which condition seen in bilateral coronal craniostenosis? You can pass.
Plagiacephaly.
Huh?
Plagiacephaly.
Yes, brachycephaly. Right.
Next.
Brachy. He said brachy.
Edema.
So 1 minute ends.
Edema.
Hey, don't do all these things. What you have told? You have told plagio or brachy? Hey, don't. ठीक है, four right. प्लाजियो बोला है, बोल रहे हैं 40 marks. Anyway, 40 marks.
Then to group B.
Group
B.
Don't whisper. If you don't know, please pass so that you can attend as many as questions. This can be audience question. Interscalene block is better suited for surgery. Which region? Interscalene. Shoulder. Yeah. Chalo. Next group. Group 2. Group B.
Group B.
How many groups left?
B and C.
B and C. Group B. Ready? Just after these 2 rounds, you announce. Secretary, yes, whatever you tell. Yes, he will take.
We have one directory of the members. Souvenir cum directory of members will be available after this meeting, so anybody can collect this. Number 2 is anybody has not collected the immortal soul, the
previous
another search jo Shraddhanjali article, he can also. Yeah, and third thing is our jo dinner, it will be at Pramod Hotel at 7:30, and after this
general body is there.
General body meeting is there, so everybody is requested to stay.
Yes, secretary, you can proceed. Take it. Thank you. Ready, group B, ready? Ready? Satya, ready? Yes. Limber flap is a noun. Which type of flap?
Rotational flap.
No, it's a transposition.
Transposition.
The number of fat compartments in the upper eyelid? Three. Which type? No, not. Which type of graft should be used to support columella? Strut. Right. The lower eyelid gets its sensory innervation from which of the nerve? Infraorbital, right. Reconstruction of mandibular ramus, condyle and the glenoid fossa is required in which mandibular deformity? Type.
Brzezinski C.
Yes, right. Type 3. So the 4 palmar interossei adductors of the fingers. Which finger is without a palmar interossei?
Thumb.
No, middle finger. Dupuytren's disease affects the palm of the hands. It is commonly involves which finger?
Index finger.
No, ring finger. Wrong. Which is more common site for the origin of migraine?
Temporal.
Yes, temporal.
1 minute and they have answered 4 questions correct.
4 question, infraorbital right, Pujanski 2, temporal 3, Stroud 4. 40.
Then to group C.
This is the last, na?
This is the last group C.
Group C. So this is the last round, last PA. So this is to group C. Group C, ready?
So group C.
Ready? Ready? Ready. The term angiosome is derived from which literature? Which literature?
Greek.
Yes, right. The lateral canthal ligament is attached to which bone?
Zygomatic.
Yes, right. The most common form of condylar head dislocation is?
Posterior.
Medial and anterior. A transverse fracture of the maxilla above the spices of the teeth is called?
Leafort 1.
Yes, right. Scrofula is a type of?
Skin disease.
It is a tuberculosis.
Tuberculosis.
Which pre-flap is the flap of choice for reconstruction of breast?
DIEP.
Tram. Fracture of the thumb metacarpal base into 3 fragments is called? Fracture of the thumb metacarpal base into 3 fragments is called?
Buttons.
No, it is Rolando. Cervical liposuction is done for removal of the fat in the submental region. The submental fat is present in which location?
Skin.
Which muscle? Or
Mentalis.
Platism. Platism. Wrong.
1 minute ends.
Platism. How many right there?
They have corrected 3 questions.
You give that actually tram, it is DIP. There DIP. DIP. It is DIP. So it is 4 correct. 4. That is DIP. DIP. Hello, what a secretary coil. DIP. So Scorer has done a great job. I think. Secretary. No, sir. Ram actually previously to a DIP. DIP.
Both are same, but different books and others are different choices. So you have to tell this
Best.
Test choice is always accepted. So all of you have played very nicely, and I think all of you have answered very nicely. So it was a very good talk competition. I think Satya has done a great job. Please give a big hand to Satya. Good test, sir. Winner, sir. Secretary. Secretary, please come.
Because the sir running shield, it is a running shield. It will go on every year. This shield has go next winner will be transferred to that shield, and the cash prize will be given 2 or 3 that he will decide. Running shield is the best. They have open secondary report. Seta best paper ପାଇଁ ସେ କଥା ଏଟା ହେଲା quiz ପାଇଁ ଆଉ cash ଦିଆ ହବ ଅଲଗା ଦିଆ ହବ cash କହିଲେ ତ ଆଶିଷ 2 prizes चलो leave चलो okay चलो हाँ
Vibhuti, is it okay? We will have this running prize is there. That is the first prize.
No, running shield will go on to the.
Will go on. That is first prize. So can you make second prize as honors prize?
First and second, sir is asking first prize and second prize can be done. Matlab cash that will be given in cash.
Whatever form, if you cash or kind, whatever you like. There are so many participants who do first, second, third. That's why I asked you, na, something new. Second and third. They agreed for 1, 2. Then you are telling for 3. That's why I asked you. There are 6 contestants.
Okay, winner is one. Sir, winner is one. Finally, winner is one. Second, first runners up. Second runners.
But the shield will be with the winner. Yes. He will transfer to the next year. Who will be the winner? That's all. Actually, no. No. Chalo, that's all. Chalo.
Decision is without
the shield. The shield will be runners up, and he will hand over tomorrow. Today he will take, and tomorrow he will hand over.
Okay. Why?
No, next meeting.
Next year. Tomorrow. Next year he will hand over the shield.
Next year, 1 more.
Yeah. Exactly.
So winner will return.
Winner will return. Even the base paper, whatever we have done it, that will. No.
Next meeting.
Next meeting. That is.
How to? Sir. भांगी जी
हाँ सर करिए I don't know देख लो किया देख बच्चे Online somebody is there. Online रे क्यों पूछे भी? हाँ.
Anybody who has not taken the Sodhanjali, the Anandha sir's book, please come and any esteemed member who has not taken the Sodhanjali, the book.
If I am permitted to speak.
Yes, sir.
This is regarding the quiz, and it is the first quiz competition, and we have a very overwhelming attendance from 6 groups, and from SCB, from AIMS, and we are very proud of that so many contestants have come up, and this has been done nationally also, but in the state chapter of APRASO, officially we started in 14, and this is the 8th our annual conference. So we are starting something new. So we are feeling all about you proud that you people have, everybody has done excel. It's nothing to feel that I couldn't compete. So this is the starting point. The failure is the pillar for the success. So this will be a running going on for the next conference also and be going. So who have not performed to their expectations, they should try for the next. But overall, always there is a competition, means we have to land up with some sort of giving somebody excellency of the prizes. So we have just formatted as an infancy stage. So Giri suddenly, Giri and Professor Nayak and all that, and Professor, our President Dr. Arsidas, all this executive committee have taken a very prompt and very smart decision of having this quiz in name of Professor Ananda Prasad Patnaik, who was a colleague for me for maybe last 30 years. And we worked together very congenially with Dr. Naik also. And this department was built not by a single person, but it was by, so everybody has contributed a lot, and his contribution was immense. And he is the first, not the first, second plastic surgeon in SCB became the superintendent of the medical college hospital. So that is also proud for us that our department professor became the medical superintendent of such a premier institution. So with his name and fame and his shop corner and his passion for teaching students, is a memory for us, and that memory has led us to creation of this new chapter in our chapter of state chapter of plastic surgery, of having this quiz competition. So I am not lengthening my speech on this, but with that note, I am going to announce the result of this quiz. I think the questions which are prepared by Dr. Sanjay Kumar Giri, I think he is now very famous all over Odisha, not me here only. He is working as associate professor in AIMS Bhubaneswar, and he is also keen about, fortunately I am fortunate rather, he was my student here in MCH, and I was his internal, and Dr. Naik also, and also a thesis guide to him. So now I feel so much proud that at least he could make it yesterday night when he asked. I asked him, sir, do you require any help, sir, regarding this quiz? He told, no, sir, I will do it. So that type of confidence one should have, and confidence and responsibilities has to go par if you want to improve yourself and your organizations. So now the total marking, as in your front marking was done. So it was completely transparent. There was no question of any problem or confusions. So the first prize goes to All India Institute of Medical Science of Bhubaneswar, and been represented by Akanksha and Gopika. So have an applause for them. Always hard work pays you, and this is what you have been paid with a, and this will be given by a trophy, which will be a running trophy. So that will be given in an official way, formally. And the second prize goes to All India Institute of Medical Science Bhubaneswar again, Kaushik and Ahana. So congratulations, both of you, for winning such a prize with talent, knowledge, and merit also. Then last not the least, we have the third prize. It goes to you tell it second honors up or third prize, whatever may be, that goes to SCB Medical College, the department represented by Tanmay and Nushya. So congratulations again to you. So you keep it up next time. I think you should come out as champions. So others who have participated, I have all congratulations for the future, and you are going to feel about. But I am really happy to be here and announcing these results, as we are doing so much of MCH exams. But I feel they very much thrilled about this quiz competition, because I didn't know also the questions, also I know few answers. I tell you honestly, I don't know every answer. In fact, now I have to go back today and see the book also, which are exactly like Dr. Ashish Patnaik pointed out, which flap is a tram or DIP. Then I have to consult, and I keep a lot of books also, I have to consult it. Anyway, thank you very much, Dr. Sanjay Giri, conducting such a nice quiz competition in our association, and long way to go. I hand over to mic to our secretary, because he's. So I think next time we can add something. So we will have a more concise, more instructive, and also, and we will have also video clips with it, because video clip nowadays, it will be a different, because so this time we started, so there may be some lacunae and lapses which we require the senior faculties to give their feedbacks, so that in next time we can have a better quiz competition. Thank you very much. Ashish.
Tomorrow's best papers, I request everybody, because it's very time pertaining. So all of you come before 8 o'clock and give all your presentations directly to this review room from today only, because it is very time. The 7 minutes presentation, all 4 judges will be there, and there will be 2 minutes discussion. Immediately after 9 minutes, because the ASHI president is going to leave by 10 o'clock. So before that, we have to finish everything. So accordingly prepared tonight, and please stick to your timeline, that is 7 minutes.
Because we want to showcase our association to the national level, no? So that's why we want a good gathering, and he should carry on a good impression. He should not carry on second day, I found nobody was there, or some people were there. So I hope you can make it. It's not a big issue. And these all things have gone through YouTube and Zoom also. So your relation, friends in the country, abroad also must be seeing this. And this will remain in YouTube also. So you can call on your friends and family also to please come here. Clean है क्या रमेश अरे ये तीन अच्छा मुझे तीन क्या रहा मगर आप क्या ऐसे हैं गिरी ये कोऑर्डिनेट करियो